We're live and you can unmute and start.
Okay, good morning to everyone in India and good evening to all our guests from the US. Thank you for joining this program on a Sunday morning. On behalf of Idea Clinics, I, Dr. Kalyan, welcome you all. Idea Clinics is a group of endocrinologists started in Hyderabad and expanding across the state and India. Headed by Dr. Sudhakar Rao and Dr. Rakesh Sahai and Dr. Shyam Kalavalapalli, Idea Clinics is designed to have a common platform, a practice platform for endocrinologists and all allied specialties. We have a distinguished list of guests and speakers for today's program, including Dr. Sanjay Kalra, Dr. Wasim Hani from UK, and Dr. Vidya Kidamba from US. So without further ado, I introduce the chairs for the first session. So I introduced Dr. Sudhakar Rao as our president of Idea Clinics. Dr. Sudhakar Rao has immense experience in endocrinology with 33 years practicing in the field. And he's a DM endocrinology from PGI Chandigarh. He's been a former professor and HOD of endocrinology department at Gandhi Medical College. He has been a former president of Hyderabad Society of Endocrinology. He's been a president for multiple other associations across India. He's been the first to introduce DEXA scan in South India, formal legislation in our AP Assembly, and he's also the president of Idea Clinics. I also like to introduce the moderator for the first session, which will be Professor Dr. Rakesh Sahai. He's the president-elect for Endocrine Society of India. He's the joint secretary for RSSDI and AAIRO. He's been a former secretary for Endocrine Society of India and a former secretary for the South Asian Federation of Endocrine Societies. He's also an associate editor of Indian Journal of Endocrinology and Metabolism, and he's got over 100 publications in various national and international journals. He's also the vice president of Idea Clinics. So with this introduction, Dr. Rakesh Sahai, I hand over the session to you to introduce our next guest.
So I would, it's my pleasure. Thank you, Kalyan. Thank you, and welcome everyone to this important meeting. Today we have a day-long meeting where we're going to discuss various aspects of endocrinology, and it's a proud privilege to have as our guest of honor Dr. Sanjay Kalra, who's the immediate past president of the Endocrine Society of India. He's well known across the globe as an eminent endocrinologist across the globe, and he currently practices in Karnal, where he is the managing director and head of endocrinology at the Bharati Research Institute in Diabetes and Endocrinology. He is also a visiting professor at the All India Institute of Medical Sciences in Rishikesh. And he is also the educational editor of the International Society of Endocrinology currently. He has been the past executive editor of IJM, and he has contributed tremendously to the growth of the Indian Journal of Endocrinology and Metabolism. And today it is second amongst the various national journals of India. And he is also the associate editor of Diabetic Medicine. And he's also currently played a great role in formation of the South Asian Federation of Endocrine Societies, and is currently the vice president of the South Asian Federation of Endocrinology Societies. So it is my great pleasure to welcome him today. And he's a very good friend of mine, and I would request him to sort of formally give us a inaugural address to this meeting, and to take this meeting forward to initiate this academic activity. Thank you, Dr. Sanjay.
Thank you, Dr. Sahai, and thank you, Dr. Kalyan, for inviting me to be part of this great educational movement. The Idea Clinics is a great idea. Idea Clinics has not only revolutionized clinical care in the field of endocrinology, it has also improved things like research, education, and advocacy. And we can very confidently say that with all the good work that Idea Clinics and its doctors are doing, Hyderabad and the surrounding areas like Warangal, Chennai, they are emerging as the endocrine care capital of the world. And a CMA like this helps us cement our place as the endocrine education care capital of the world. It's nice to see the wide spectrum of topics that have been included in this program. And we also welcome our distinguished speakers from India and abroad. All of them will be contributing their own expertise, their eminence to this program. And the topics are all a must listen to, whether it's learning about obesity. And I hope that Dr. Shri Vidya is able to help me lose some weight also. I'll listen to her talk. And Dr. Vidya, do you think I'll be able to lose maybe 2 kg in 20 minutes? So she'll talk.
Well, I can have you gain some weight, I guess, with drinking water.
So we'll try that. And then we'll learn about transgender endocrinology from Dr. Jenna. And then about thyroid eye disease, which is a field where management is changing very fast. Dr. Srinivas Rao will speak to us about that. But throughout the day, we have interesting topics. We have excellent speakers. And I invite all of you to be part of this educational event today. Thank you, Dr. Rakesh, for inviting me.
Thank you, Dr. Sanjay. We'll now move on to, I will request Dr. Sudhakar Rao, the co-chair for this session, to say a few words before we start off with the talks.
We are pleasure to have Dr. Sanjay Kalra and thank Dr. Kalyan for the nicely coordinating with this work. I support this Kalra's idea that the idea is a great idea, and especially we are doing very well in Hyderabad, Madras and other areas. We are trying to extend to Andhra region also. It will be, we are maintaining a one data, one India, one data. For the, we want to make it as a important data for the future generations. And we have been doing every year these conferences very nicely. So we are doing a, this time we have to forcibly do a virtual one. I welcome all. Thank you.
Thank you, sir. Thank you, sir. We'll now have pleasure in introducing Dr. Srividya Kidambi. Dr. Srividya Kidambi is an associate professor and chief of the Division of Endocrinology and Molecular Medicine at the Medical College of Wisconsin. She is an alumnus of the Gandhi Medical College in Hyderabad. She is editorial member of many prestigious journals like the JCEM, Clinical Endocrinology, and the American Journal of Hypertension. She has been a principal investigator in many clinical trials in diabetes and obesity, and author of many journal publications, books, chapters, and reviews. Her clinical interests have been mainly in the field of obesity and diabetes, dyslipidemia, and hypertension. And her other research interests have been basically in the area of adiposity distribution, hypertension, diabetes, and obesity. So it gives me great pleasure to welcome Dr. Srividya. She has been to Hyderabad several times. She has addressed the Association of Physicians of India also earlier in the last year, if I'm not mistaken. And I welcome her to this meeting, and she's going to today speak to us about the hidden causes of obesity. So over to Dr. Srividya.
Thank you, Dr. Sahai. Let me try to share my screen. Thank you. Good morning, everyone. I am going to talk about hidden causes of obesity today, and thank you for this invitation. I am trying to see how I can advance the slides. So today my talk will just a couple of slides on reviewing the causes of obesity and common contributors of weight gain that we don't often take into account when we are seeing patients with obesity. Majority of my practice right now is diabetes or obesity, and I interact with many providers that take care of patients. But I think sometimes we forget, in some of these things that are hiding in the plain sight. And if I have some time, I would like to talk about genes and hypothalamic damage, just because of the newly approved drug by the FDA on November 27th about setmelanotide for specific, very rare but specific causes of obesity. If I have time, I would like to share some slides on that. So as you all know, the definition of obesity differs between Western world as well compared to the Asia Pacific region. So in United States, overweight is BMI over 25, whereas BMI of over 25 will cross into obesity class in the Asia Pacific region. So using that definition of BMI over 25, as you can see, the prevalence of obesity and overweight has jumped significantly over past 10 years in India. Mean BMI has risen from 20.3 to 21.9. I think the data before that, 2005, are hard to come by. But this is an alarming increase within 10 years, 10% increase. So most common causes, and they are given a lot of importance, and rightfully so: dietary indiscretions, social and behavioral factors, and of course, sedentary lifestyles, and genetics and family, mostly family because of the some of the habits that are perpetuated in the family. They may not be necessarily genetic, but there are also multiple genes perhaps that are associated with the obesity transfer within the families. But I wanted to talk about some of the secondary causes of obesity, primarily medications and endocrine causes, but I would like to really focus on hypogonadism and some neuropsychological causes. So as you all know, there are many medications that are associated with weight gain, particularly psychotropics, among which come mood stabilizers, antipsychotics, antidepressants, and pain. These medications are very commonly used for various reasons. And then hypoglycemic agents, which we all know: sulfonylureas, thiazolidinediones, insulin, and meglitinides. And some cardiovascular drugs. Again, these are the things that we probably do not pay attention to that much: beta blockers and dihydropyridines, which are like amlodipine and nifedipine and that class of drugs. And hormones, somewhat a little bit more well known than the cardiovascular drugs, and antihistamines and antiretrovirals. So there has been a significant increase in obesity in United States, just like, this is a very common graph, probably many of you might have also seen. And India is not immune to that, as I've seen before. So if you look at this picture here, this is the number of FDA-approved drugs for various psychiatric conditions, including atypical antipsychotics for bipolar, schizophrenia, depression, and autism. So as you can see, in the past couple of decades, there is a significant increase in approval as well as use of these medications. This is a meta-analysis of the study that showed that after 10 weeks of use of many of these drugs in standard doses, there is a significant weight increase in a duration as short as 10 weeks. Some of these drugs are very commonly used in Western worlds. For lack of time, I'm not able to show. So perhaps these are less utilized in India, but for us in the United States, it's a big cause, particularly a lot of antidepressants. This is a graph that shows the adjusted rate ratios for more than 5% weight gain by antidepressant type, except for nortriptyline. Almost every one of these antidepressants have been associated with more than 5% weight gain. When you think about it, 5% may not seem a lot, but when you think about diabetes prevention program, all those studies of diabetes prevention, 5 to 7% weight loss was associated with the prevention of diabetes for 5 to 10 years. So this is not a simple, small amount of weight gain when we are thinking about 5%. Now coming to the diabetes drugs, there are numerous studies on both sulfonylureas and insulin. I just chose this ACCORD trial just as an illustration as how much weight gain occurs in patients after initiation of insulin. So at some point, the insulin, while it controls blood sugar, the weight gain may actually result in further increase in usage of insulin and insulin resistance. These are antihistamine data. Antihistamines are, again, very commonly used over-the-counter drugs for various things, seasonal allergies, and maybe even dry cough and things like that. Again, these antihistamines have been shown to be associated with increase in all anthropometric parameters. So asking the medications, particularly over-the-counter medications, is extremely important. Now, this is one graph about the beta blockers. As you can see, this is a number of studies that have shown increase in weight with beta blockers, except a couple. So again, very commonly used drug to keep in mind. We actually performed a study in our own hospital by taking the outpatient data from between 2012 and 2019. We had about 12,642 individuals who were not on any of the medications of the obesity class. We have electronic medical records, so we can actually weed out every drug that I've talked about in the past slide. So these were the individuals who are not on any of these medications prior to 2012. About 9,000 were started on one or more of these medications, and we call them as cases. And the remaining 3,600 were not on any of the medications in that class, as I discussed. So what we found was that if the patients were not on any of the drugs I discussed in the classes that I talked about, including antihistamines, there is a subtle decrease in weight actually over the years. This is perhaps because of aging resulting in loss of muscle mass. So there you would probably see a slight decrease in weight, contrary to common belief that as you age, you gain weight. So if you are not on any of the medications, it looks like people actually do lose some amount of weight. So what we saw was there was a statistically significant increase if the patients are on one or more of the medications of that class. And this is true even after controlling for baseline weight. Obviously, people who are of higher weight are the ones who are going to be on diabetes medications or blood pressure medications. So when we actually evaluated them based on the drug type, like psychotropics or hypoglycemic agents or cardiovascular, so you can see that there is this blue line, there is a slight decrease in decrease in weight. This is not significant, but you can say either it doesn't change or goes down slightly unless you're on one of these medications. These data are actually better represented here. As you can see, but both univariate and multivariate analysis, there is a significant weight gain compared to baseline to year 4. Hypoglycemic agents is a substantial weight increase at the end of year 4. Same with the cardiovascular, even though it's not substantial. All these drugs are additive. We only did just one drug, but when we added 2 or 3, the amount of weight was substantial. So medications can stimulate appetite. They affect how body absorbs glucose and stores glucose. They may decrease metabolism. Drugs like beta blockers can cause fatigue and maybe make people less active. Drugs like amlodipine, they can cause water retention, can add weight, but may not necessarily be fat. So in the context of current obesity epidemic worldwide, I think it's important for us to be aware of these weight promoting potential of these medications and consider weight neutral alternatives. This is particularly true for diabetes. We really try to avoid insulin in our practice. Of course, the type 1s are on it, but we are able to utilize all the newer drugs that are available to us, and it's really helps people to use some alternate drugs. And also not using beta blockers for hypertension, which is still commonly done. So I want to move on to the hormonal conditions. I'm not going to spend much time on most of these you guys know already, which is hypothyroidism, Cushing's, growth hormone deficiency, extremely rare insulinoma. So the only thing I'm going to say about hypothyroidism is almost every person walks into the clinic thinking that somehow thyroid is abnormal and I fix it, obesity gets better. But the weight gain from hypothyroidism is modest. It's real, but it is just modest. And growth hormone deficiency, the true prevalence is not known. When I was in fellowship, we used to use it quite often, but in the last 8-9 years, we haven't been using it very much because of lack of long-term data. But if anything, growth hormone replacement may improve some body composition. So Cushing's, I'm going to skip. One of the things is that it's extremely rare. So one thing everyone thinks about hormonal condition and obesity, automatically Cushing's syndrome comes into mind, but it's really, we test a lot for Cushing's. Dr. Findling is one of our faculty. If you guys know, he's really very well known in Cushing's. So we are very in tune with that, but it's not as common as we would like to think. But the most important thing that I wanted to bring up was male hypogonadism that often does not get addressed. So hypogonadism can cause depression, loss of lean body mass, increase in fat mass. And also it results in lack of initiative. So people are not as active as they would have been, and reduce in bone mass that can result in weight gain, which with the deposition of fat can cause aromatase to convert testosterone to estradiol, which again inhibits gonadal axis, resulting in low testosterone. So it's a double, this is a two-way street. So hypogonadism may result in obesity, and obesity may in turn cause hypogonadism. So this is a study that showed that weight loss results in increase in testosterone levels. And this is a study that showed increase in testosterone. These are number of studies that have shown changes in testosterone levels after bariatric surgery, which is a direct relation with weight loss. There's also improvement in adiposity measures with testosterone replacement therapy. And this is a study that after 6 months treatment with testosterone, there are significant changes in BMI of men tested. So we are also very in tune with that. So we do test for hypogonadism in obese men. And we are in the process of looking at our data, but anecdotally in my practice, I think there is a huge improvement in weight in men who have low testosterone. Of course, I do not treat everyone. Sometimes, the weight loss may improve testosterone levels back, but if the levels are under 100, I actually think that perhaps the hypogonadism may have been the cause of the obesity. So we go ahead and treat that, and we have had substantial success with that in our practice. The other one I wanted to talk about was sleep deprivation. According to CDC, Centers for Disease Control in the United States, adults require more than 7 hours of sleep. Obviously, many people do not get adequate sleep. In the United States, the prevalence of short sleep duration is about 35%. And of course, this is associated with the increased use of electronic devices and many other social and cultural factors. So these are the findings from various cross-sectional, longitudinal, and cohort studies, which indicate that short sleep duration is strongly and consistently associated with increase in obesity in both adults and children. So this is in every group. The relative risk for obesity is higher in comparing short sleepers versus normal sleepers. In people who are age over 65, under 65, male, female, no matter how you think about it. A number of studies which looked at less than 5 hours, less than 6 hours, or 7-hour duration. So there is increase in sleep, increase in obesity among those who have short sleep duration. So there's also sleep apnea increase in patients who have increased weight because of increase in soft tissue in the neck region and the throat. So the sleep apnea can result in poor sleep. Again, this is a vicious cycle that gets established. So there are actually several studies that showed that sleep restriction results in upregulation of reward and pleasure networks in response to food stimuli. So these will predispose people to choose high fat, high carbohydrate, and high energy intake. These studies were done by Dr. St. Ange in Colombia, a good friend of mine, really has done tremendous studies where they've actually had people, habitual 7-hour sleepers, had them sleep deprived for 5 hours. And these people were actually in what we call as clinical research centers, where they actually come and live there. And they have looked at those same person who has sleep deprivation. The day they are sleep deprived would actually choose different types of foods. Every day you would present same types of breakfast, and they would wake, the day they had sleep deprivation, they would choose high fat, high carbohydrate foods compared to the day that they would have had good sleep. There is definitely there's a biological basis. The leptin levels are lower. The orange bars are the leptin levels in those who had shorter sleep duration versus those who had higher sleep duration. Ghrelin, which is the appetite hormone, is higher on the days that the patients had or the individuals had lower sleep duration. So these are the studies that actually showed that sleep restriction and sleep fragmentation can result in changes in insulin sensitivity. I mean, look at this. I mean, this is amazing how much the sleep deprivation results in our metabolic changes. So the sleep deprivation, as I said, decreases leptin, increases ghrelin, which results in increased hunger, increased caloric intake, then also increased opportunities to eat, altered thermoregulation, increased fatigue. People are unable to be as active next day. So all of this in a longer term or intermediate term can result in weight gain. Being aware, we always ask about sleep. Sleep is one of our big questions in our obesity intake. We test for sleep apnea, talk about sleep hygiene. We have a close working relationship with sleep specialists in our clinic, and we use behavioral therapy. Definitely, I'm not a big fan of medications. Of course, I mean, it's a hard job. People sometimes getting, waking up late and sleeping early, sleeping late and waking up late. Do I have some time? Can I go over this, or am I?
Maybe another 1 or 2 minutes you can.
Okay, so I just wanted to talk about, there are several monogenic forms of obesity, and they're extremely rare. But I wanted to talk about MC4 receptor mutation because of the new drug that's been approved. I look for everything, because we do have some children in our practice that come from our children's hospital. I haven't yet found, they are very, very uncommon. But this is a very uncommon. Homozygotes are more severely affected. This is affected in the arcuate nucleus in the hypothalamus. This is where the POMC is the satiety center, and neuropeptide Y, agouti-related peptide, the other set of neurons are the ones that increase appetite. They're affected by ghrelin. So this is the, I think finally after decades of research, they've honed in to this region of the brain for the appetite. It's usually manifests in childhood. So if you see a boy or a girl who has higher height and weight compared to their siblings or the same age, that's when you would suspect. They have a tremendous appetite. There's both increase in lean mass as well as fat mass. So I'm going to skip that. So this is the compared to, this is a 4 or 5-year-old boy compared to a 12-year-old sibling. So this is how these children grow. So these are the first trials that were published in New England Journal for setmelanotide. Again, these are very, very rare. Even the 2 studies based on which the FDA approved really only had 25 people in it. But this is the case reports of those 2 patients who were on the therapy. After 40 weeks of treatment, they showed that there is decrease in hunger score as well as change in weight. So this is a game changing for this cohort of patients. So the FDA just approved on November 27th. This is the first weight management medication for rare conditions. So there are 3 of those: POMC deficiency, PCSK1 deficiency, and leptin receptor deficiency. Again, if you, this is one of those that if you see a child with this kind of problem, now there is a treatment. Again, all of us, some of us will see them in our lifetime. So I thought I would mention this. So with that, this is our medical school, and this is our campus that I work at, and Dr. Saradio, both of us. And with that, if you have any questions, I can take them.
Thank you, Dr. Srividya. You gave an excellent overview of the less known causes of obesity. Also, these are the causes on which everybody wants to blame their obesity on. I mean, I would like to, while the audience come up with questions, I would like to ask you 1 or 2 questions. I would like to ask you, what is the contribution of drugs in the causation of obesity? How much do you think? How much percentage of obesity is contributed by use of other medications?
So there are no data to exactly do that. That's what we are trying to do. We know that these contribute. So from my personal experience, it's a lot. So we go over, I have to say in my own practice, I would actually discontinue drugs that belong to that class in about 50% of my practice. It's extremely common in United States. I'm not that familiar with in India, how often patients use antidepressants and antihistamines. Those are extremely common in our among our patients. And beta blockers are still, even though it's been several years now, it's not the first line agent for hypertension anymore. They still do that. So having 2 or 3 drugs of, each one may cause 4 kilograms, 5 kilograms in weight. But when you add up, what I find is that there is a substantial amount. So part of, my medical management of obesity is really stopping the drugs that people are being used. Again, as I said, it's really hard to get that kind of data because it's all intermingled with everything.
If I were to ask you between the 3 causes, 3 important areas that you highlighted upon on drugs causing obesity versus low testosterone versus sleep deprivation. So how do you rate the 3 in terms of their contribution to obesity, prevalence of obesity? I mean, amongst the people that you see.
So based on my practice, really, for us, it's really the medications. I think that's a big problem in the United States. I mean, it's not uncommon to see patients on, 10 drugs, and at least 2 or 3 of them have a weight gain potential. And probably next comes sleep. And hypogonadism is less so, but it is there in the mix. I don't treat if the testosterone is 200 or 300. I only treat with testosterone if it is, as I said, something what I consider as more severe and cannot be just explained by just increase in fat mass and estradiol production in men. So I would think medications are probably my top concern.
Thank you, Dr. Srividya, for the excellent presentation and highlighting the role of these lesser known causes, which may not be always looked into and maybe overlooked by many people when we are evaluating obesity. Thank you for the excellent presentation. We look forward to to interacting with you on further meetings and further platforms. And thank you for sparing your time today. I understand it's quite late in the evening there in the US, and I thank you for taking on as well.
I'm glad.
So we thank you on behalf of Idea Clinics. I would thank you for having spent your time. We'll now move on to the next presentation, that is by, I have the slide, Kalyan, can you slide for the next speaker? We have with us.
Sorry, Doctor. Can I just, if you just stop your, yes, sorry. Let me just override you, Doctor. I just have to put up your introduction slide. Sorry about that.
Yeah. So we have great pleasure in introducing Dr. Jenna Sarvaidyo. She is Associate Professor, Division of Endocrinology and Molecular Medicine, and also the Assistant Program Director of Endocrinology Fellowship Program at the Medical College of Wisconsin. Her clinical interests have been mainly in the field of transgender medicine and also on male and female hormone disorders. She has a research interest in transgender medicine and has brought out several publications in this field. We are indeed privileged to have her today with us and to speak to us about transgender medicine. So over to Dr. Jenna.
Dr. Sarvaidyo, I'm stopping my screen share now. Screen share, you can share your screen now. Thank you.
Okay. All right. Is it visible?
Not yet.
Okay. What about now?
Now it's coming up. Yeah.
Oh, great. Okay. Well, thanks for the invitation. I'm Jenna Sarvaidyo. I also am from the Medical College of Wisconsin, and I'll be talking about transgender medicine today. All right. I have no disclosures. So the background of my talk is basically that cross-sex hormone treatment is the main aspect of transgender medicine, especially for us endocrinologists. And gender-affirming care may be considered medically easy, but should not be practiced without any insight, in my opinion. Gender-affirming care may be socially and culturally challenging for some providers, And there is definitely controversy around the globe surrounding transgender medicine. And just this past week, the High Court in England ruled that patients under 16 years must not be referred by the Gender Identity Development Service to pediatric endocrinology clinics for puberty blockers unless a best interest order has been made by the court for the individual in question. So England is definitely moving away from hormone replacement therapy for maybe a lot of their population, unless certain circumstances arise. So why provide gender affirming care? So research provides evidence that hormone therapy can reduce symptoms of anxiety and dissociation, perceived and social distress. It may improve quality of life and self-esteem, and in some studies, depression, global psychopathology, and psychosocial functioning difficulties can improve. So the objectives of my talk, first I'll just go over some terminology just in case some of this stuff is new. I'll talk a little bit about the biology of gender. I'll talk about transgender prevalence in the US, health disparities of the transgender population, including mental health and mortality. And then I just included some basics of gender affirming care, but I'm happy to answer any questions on hormone replacement therapy. So the definition of gender identity is this internal sense of self as being male, female, both, neither, or something else. And this is something that patients determine and define, not us as their physicians. So, and then with this table that you can see, I'm going to define cisgender, which you may hear me use in this presentation, transgender, and then gender non-binary. So the definition of cisgender is it's an adjective for persons whose gender identity and expression align with their sex recorded at birth. So this is really the majority. And so an example is a cis female. So this is a person with a female sex recorded at birth who has a female gender identity. And then you have transgender and gender non-binary. So these are adjectives for persons whose gender identity and or expression do not align with their sex assigned at birth. So a trans male, for instance, is a person with a female sex recorded at birth, but they have a male gender identity. And then gender non-binary is just an umbrella term for a broad range of identities along or outside a male or female binary. And one that you might have heard of is gender queer. Okay, and then more about gender identity. So how we learn about gender is unclear, but some of the things that we understand is that most children develop the ability to label faces as male or female between 18 and 24 months of age. And then by age 2 to 4, children understand gender differences. They use gendered pronouns and they can label themselves as either a boy or a girl. And then by age 4 to 7, most children achieve a gender stability and they express gender identity by playing with toys and games that correlate with their anatomic sex. But it's important to note that exploring sexuality and experimenting with gender roles, such as interest in cross-gender toys and games and cross-dressing, is a normal part of child development. And then I just wanted to define sexual orientation, just to really point out that this is independent of gender identity. And it is, again, defined by the individual, just like gender identity is. And sexual orientation encompasses physical, sexual, emotional, romantic attraction to other people. So now moving on to objective number 2. So the biology of gender. So this, for the next couple slides, I'm just going to move away from, there's definitely people that believe, and probably all of this is is the cause of why someone might become transgender, but the next couple slides are moving away from societal and environmental causes of being transgender and more of like a biologic cause. So there was a study that looked at individuals with CAH that were 46XX. So these people have increased androgens and more virilization. And in the population studied, those that were raised as female, actually 5% of them had gender dysphoria, which is a higher prevalence than trans men in the general population. So maybe this is suggesting that in utero, if you're exposed to more androgens, you might have more of a male gender identity. And then interestingly, in twin studies, there was a higher concordance for trans identity in monozygotic than dizygotic twins, so maybe a genetic cause. And so of 23 monozygotic female and male twin pairs, about 40% were concordant for a gender identity disorder. So both of them had gender identity disorder in 40% of the population. And then there were 21 dizygotic twin pairs, and all were discordant for gender identity disorders. So they didn't agree with each other. And then there were 3 sets of twins who were raised separately, but were concordant for gender incongruence. So that's kind of interesting too. And then the next just example of maybe this is more than a societal and environmental cause is the story of David Reimer. So in the US, we learn about this story a lot in like our Psychology 101 courses in college. And so David Reimer was born in 1965, and he was an identical twin boy. And unfortunately, in 1967, he suffered a botched circumcision. So his parents actually were instructed to raise him as a female. And he attended therapy sessions for sex reassignment with the infamous John Money, who I think was in Baltimore, Maryland. And so David was then living as Brenda, but he never identified as a girl. This ended up causing him a lot of depression and suicidal thoughts. And he ultimately made the decision to live as a male. So again, speaking to the biology of gender. And then I'm not going to go through this table here, and I'm not a neurologist or an expert in all of this stuff, but there are some studies that I just wanted to introduce you guys to, that trans adults may actually have similar brain structure to cis adults with the same gender identity rather than the sex recorded at birth. So this was mostly seen in trans female data. And importantly, it was actually before starting gender affirming hormone therapy. Okay, and then objective number 3, I think we're up to, is the prevalence in the US. So on the y-axis, you have the proportion of transgender individuals, and then on the y-axis, you have year. So 2007 to 2015. And the different colored circles are just different surveys that were done in the US. And what you can see here is just that as time goes on, we're seeing more and more transgender individuals in the United States. And so there's an estimation that there's 390 per 100,000 in 2016. And this actually amounts to about 1 in every 250 adults, which usually surprises people. So there's almost 1 million Americans that identify as transgender. Okay, now the health disparities. So these next few slides are pretty depressing. But Lambda Legal, which is an organization in the US, found that 70% of transgender and gender nonconforming individuals have faced serious discrimination in a healthcare setting, which is unfortunate. And so there was a survey in 2015 called the US Transgender Survey. It had about almost 28,000 respondents. And so 33% reported having at least one negative experience related to being transgender. So they were either refused treatment, verbally harassed, physically or sexually assaulted, or they had to teach the provider about transgender people in order to get appropriate care. So in our medical school, we're trying to introduce our students to transgender medicine so they don't have to be one of those providers that don't have any idea. And then 23% of respondents did not see a doctor when they needed to because of fear of being mistreated as a transgender person. So, and then here's a slide on mental health disparities in transgender people. So this is from that same survey back in 2015. The dark blue is transgender individuals that have supportive families. And then the light blue is transgender individuals that do not have supportive families. And so I'm just going to highlight the middle bars, which is attempted suicide. So those people that had even supportive families, there were 40% of them that tried to attempt suicide, which is very high. So this population has high rates of depression, adjustment, and anxiety disorders. And there, as you can see, are pretty high rates of self-injury and suicide. So this is a vulnerable population. And then just a little bit more, this is a study in US veterans. It was done between the years of 96 and 2013. It included about 5,000 transgender vets compared to non-transgender vets. The mean age was a bit older, so 56 years old, 70% classified as male, and then 80% were non-Hispanic white. And as you can see here, that there are, I'm not going to read down the whole list, but there's many mental health and medical illnesses, and the transgender populations were at high risk for many. So I'll just highlight like depression, HIV, panic disorder, serious mental illness just in general, and then again, suicide. So again, highlighting just that this is a vulnerable population. And we want them to get health care, even though some of them have been frightened of us in the past. And then this is just a study from Amsterdam. It's looking at mortality disparities. And so this included trans women, so mean age is 31 years, and then trans men, mean age of 26 years. They had a follow-up of about 18 and a half years, and it looked at mortality. So in trans women, this population seemed to die more from ischemic heart disease, external causes, and AIDS. And then for the trans men population, there were more deaths from external causes like drug use and suicide. Okay, and then this is the last few slides on gender affirming care. So we definitely need to work in a multidisciplinary clinic with this population, as I think it's helpful in working with many patients, you know. So the transgender population, though, typically needs medical care, psychosocial care, and sometimes surgical care. And that's up to them. So with the medical aspect, endocrinologists see a lot of transgender patients, primary care, infectious diseases, speech pathology can see this population, and then reproductive endocrinology. And then our psychiatrists and social workers, psychologists, case managers, they're all very helpful in caring for this population. And then some of our patients go on to get surgeries to affirm their gender identity. So they can see gynecologists, plastic and reconstructive surgery, urology, and then ENT. So this is just a slide on the endocrinologist role for gender affirming hormone therapy. And so very basic, people with male sex recorded at birth who have a female gender identity, we're using estrogen, typically estradiol. And in the beginning, we're using an anti-androgen. In the US, we use spironolactone. From what I understand, in Europe, they use cyproterone acetate a lot, which is not approved here. And we use these hormones in order to achieve female secondary sex characteristics. And we achieve female physiologic range, serum estradiol, and testosterone. So we're following these labs in order to optimize our therapy. And then people with female sex recorded at birth who have a male gender identity, we're using testosterone to achieve male secondary sex characteristics. And we're achieving a male physiologic range, which practically speaking is a bit easier than achieving estrogen ranges. And then for this non-binary approach that I introduced you to in the beginning, this term, if you have a patient that identifies as non-binary, you really just have to discuss the goals with your patient and then figure out how you're going to treat them. And then this is a slide on gender affirming surgery, just to introduce you to what surgeries this population might be looking for. So they might want to go see an ear, nose, and throat doctor or a plastic surgeon for face and neck surgery for more feminization characteristics or masculinizing characteristics. For trans females, they'll go and they'll potentially get breast augmentation. For trans males, they'll get a mastectomy. Some trans women go for orchiectomy, and some trans males go for hysterectomy, so they don't get their menses, plus or minus oophorectomy. And then genital surgeries are available by specialists, usually plastic surgeons that have gone on to fellowship to do this. And so trans women can get a penectomy or a vaginoplasty, and then trans males can get a phalloplasty or a procedure called a metoidoplasty. And to end on a more positive note, there have been a couple of studies done looking at the regrets of this population. And so 2% of transgender women and 1% of transgender men regretted their decision to undergo hormonal and/or surgical treatment. So I would say that that's rather low. And in another study, about less than 1% had regrets. So, and then this is just a slide for resources. So the Endocrine Society has wonderful guidelines. There's the World Professional Association for Transgender Health, WPATH. Their guidelines will be, they have a new edition coming out in the next few months. And then if you just Google UCSF, they have their own guidelines that are very helpful and very clinical. And that's it. That's my email address if there's any other questions that ever come up. And thank you again for the invitation.
Thank you. Thank you, Dr. Savedio, for the excellent overview about transgender medicine, where you've given us a overview of the entire area of transgender medicine. You have actually highlighted the fact that the prevalence of the problem is to the tune of 1 in 2 adults in the US. So I think in India also we are seeing the prevalence of the transgender individuals is more and more seen in many clinics. Now we have this is an evolving specialty. And So I think we do not have any questions as yet from the audience. Dr. Kalyan wants to ask a question.
Yeah, just a couple of questions, Dr. Sarvedia.
Sure.
Do you use much higher doses? And like, for example, if you want to use an estrogen in a trans female patient, you have to use a much higher dose than what you would normally use for a physiological replacement in a normal female?
Yeah, so I compare it a lot to like my menopause population. So in them, the highest, like if I was using an estradiol patch, I would use 0.1 milligrams. And when I try to use 0.1 milligrams in a trans woman, I'm often not successful. I have to use 2 patches. I really don't, I don't have the experience of using injectables, and I really don't use pills in cis women, so it's hard for me to compare. One of the things that we really don't use is the ethinyl estradiol that's found in birth control pills in the transgender population, because we know that that can cause more blood clots. So in terms of tablets, we're only using estradiol, and typically my starting dose is 2 milligrams twice a day. And I would think that this would be higher than like if you were using pills in your menopause population.
Sure, yeah. And have you seen any like long-term side effects of this higher dose? Like having increased risk of breast cancer or in trans females?
You did show that there is an increased risk, but you did show the larger studies showing the increased risk of
ischemic.
Your own practice of these of venous thrombosis.
So yeah, to be honest, in my short career so far, I have luckily not seen any clots. But there is another great study that came out a few years ago from Kaiser that did definitely show more blood clot, more DVTs and more strokes. But unlike that Amsterdam study, it did not show more cardiovascular disease. So we just need longer studies to see what the risks are. And it's probably a low, so in terms of DVTs and stroke, it's probably a real risk, but my guess is that it's a low risk. So the trans women need to know this, but I always tell them I'm not trying to talk you out of it, but you need to know what your risks are.
And last question, there is for people who have not had a gonadectomy in either sexes and you're replacing the sex steroid with an alternative thing, is it enough to just shut down their own gonadotrophin axis, or do you need GnRH analogs in these patients at all?
So most of the time, the hormones themselves are enough to shut down the axis. Yeah. And that's also why I take a lot of my trans women off of spironolactone, because I don't know why we have to block something when the testosterone is so low.
Right.
Yeah.
Thank you.
Thank you for the questions.
Thank you for sparing your time in the evening on a Saturday evening. I think thanks a lot for spending your time. We really appreciate your presentation, and we would now like to move on to the next presentation.
My pleasure. Thank you.
Thank you. So, as we move to the next presentation, I would like to introduce our next speaker, who's Dr. Srinivas Panja, who's well known to all of us here. He's been part of several programs of Idea Clinics. He is the consultant endocrinologist at the Greater Houston Diabetes and Endocrine Center in Houston, Texas. He has done his MBBS from Kurnool Medical College and did a fellowship in endocrinology and metabolism at the University of New Mexico in the United States of America. His special interests are in the management of diabetes and thyroid nodules and other metabolic disorders. So welcome, Dr. I would request you to speak on the topic of management of eye disease.
Thank you, Dr. Sahai. Thanks, Dr. Sudhakar. Hisham, thank you. And thanks to IDA Clinics for putting up this great education session. Nice job, Vidya. I liked your presentation. Nice job, Dr. Sarvadi. It was a very nice presentation, and thank you for having me. So today's topic is thyroid eye disease. I think for so many years we haven't had a whole lot happen with thyroid eye disease in terms of treatment options, and I think it's a little exciting to see something new come up. So I think I'm not wrong. I'm sorry. Give me 1 second. Okay, I'm sorry. Give me a second here. Went way ahead. Okay, so this is objectives of the talk. Sorry about that. So kind of provide a little overview of thyroid eye disease and really the role of the IGF-1 receptors.
Panjav, you're not able to see your screen. Probably you can unshare it and do it again.
Okay. You're not able to see it?
Yeah. Can you just unshare and then do it again?
Share.
Yeah. Yeah, now it's coming up. Yeah. Thank you.
Okay, can you see it now?
Yeah.
Can you see the slide?
Yeah, perfect.
Okay. Yeah, so we'll provide a little overview of thyroid eye disease and describe the role of the IGF-1 receptor, especially in terms of pathogenesis and the new treatment options. We'll review some of the clinical signs and symptoms of thyroid eye disease, understand the significant functional and psychological burden on patients. And we'll discuss very briefly also as well the treatment options, and especially the new treatment options we have. So quick overview of thyroid eye disease, or TED. It is debilitating, it's a progressive disease, sometimes vision threatening, and it is an autoimmune disease. And the patients may experience poor ophthalmological clinical outcomes, disfigurement, sometimes very severe vision threatening complications, psychological distress, and restrictions to daily activities and ability to work. So thyroid eye disease is the most common extrathyroidal manifestation of Graves' disease. About 40 to 50% of patients of Graves' disease will develop TED. So it is, as I said, autoimmune disease. 90% of patients with TED do have concurrent Graves' disease. For thyroid eye disease, the immune cells attack the orbital tissue. It's not directly related to the high thyroid hormone levels. So you could treat the thyroid disease, but that may not necessarily improve the thyroid eye disease. And of course, Graves' disease, the goal of treatment with Graves' disease is to inhibit the thyroid production, and the autoantibodies against the thyroid stimulating hormone receptor trigger the excessive production for the thyroid hormones. Now, 10% of patients with thyroid eye disease are either hypothyroid or euthyroid. So I think as much as it is important for us to screen patients with Graves' eye disease for Graves' disease for thyroid eye disease, I think it's also important to remember that people, if they have just eye symptoms, they should be also considered for possible thyroid eye disease, because about 10% may not have hyperthyroidism. So thyroid eye disease may present before, during, or after the onset of Graves' disease. The annual incidence and some of the leading risk factors, about 16 out of 100,000 women and 3 out of 100,000 men. So it is a whole lot more common in women. 2 peaks of incidence occur in patients in the 40s and in the 60s. Some of the risk factors, smoking definitely increases the risk by about 8-fold. The risk of new onset or worsening of thyroid eye disease is about 20% more after radioactive iodine treatment. So something to consider, especially for people, to think about, especially for people who have Graves' disease and you're thinking about radioactive iodine treatment. Women are at a higher risk, but men have elevated risk for more severe thyroid eye disease. And then the odds of thyroid eye disease increases by about 17% with each decade of age. So this looks at the continuum of thyroid eye disease. It is a progressive disease, advances to chronic fibrosis, So the progressive or the active phase is also the inflammatory phase of TED, and it can last to up to about 3 to 4 years. And this is when, if you can have some disease modifying agents, you might be able to reduce some of those permanent disfigurement. The patients eventually progress to the fibrotic phase of TED, which is characterized by irreversible fibrosis. Fibrosis begins during the progressive phase and leads to lasting sequelae associated with permanent disfigurement and functional visual impairment. So this is a slide which actually looks at the pathophysiology. I think it's a slide I would like you to focus on a little bit, because the new treatment really addresses some of this pathophysiology. So thyroid eye disease is driven by autoantibody activation of the IGF-1 receptors, or the insulin-like growth factor 1 receptor. The orbital fibroblasts, which are the specialized cells responsible for tissue repair, are central to the pathophysiology of TED. IGF-1 receptor, which is a gatekeeper of the orbital fibroblast activation, is overexpressed in thyroid eye disease orbital fibroblasts. So the IGF-1 receptor, the TSH receptor form a receptor signaling complex, and they co-localize in the orbital fibroblasts. Activation of the IGF-1 receptor stimulates the release of the inflammatory markers, which in turn causes all the inflammation that you see with eye disease. So inhibiting the activation of the IGF-1 receptor should technically help with reducing the inflammatory response. So the clinical spectrum and the diagnosis of thyroid eye disease. So inflammation, tissue expansion, and eye muscle changes may lead to clinical manifestations. On the left side, you see the healthy eye and the orbital tissue. On the right side, you see the eye in the presence of thyroid eye disease. So there is eyelid retraction, eye protrusion, inflammation of the caruncle, eyelid and conjunctival redness. And then you see the inflamed and enlarged muscles due to fluid accumulation, which causes the proptosis, compression of the optic nerve, which in turn can cause blindness. And of course, there is increase in orbital tissue fat as well. So the activation of the IGF-1 receptor, TSH receptor signaling complex on orbital fibroblasts triggers an inflammatory response, which leads to the tissue expansion and remodeling in the orbit. So recognizing some of the signs and symptoms of thyroid eye disease. So, these are some of the more obvious signs. There are a lot of people who have much more subtle signs. So in the eyelid, you can see the upper eyelid retraction. 91% of people tend to have this. Eyelid swelling, there's pain, and there's lagophthalmos, which is incomplete closure of the eyelid. In the orbital tissue itself, you see exophthalmos, which is proptosis. Occurs in about 62% of patients. There is pain, deep ache, and of course, disfigurement if it progresses onto the fibrotic stage. Ongoing inflammation and expansion of orbital tissue leads to changes in the physical experience as well. So in the conjunctiva and the cornea, you can see chemosis, redness, photophobia, pain. Very commonly, they complain about having a foreign body sensation. And of course, you can have the swollen caruncle and dry eyes. For the extraocular muscles, you have the restricted ocular motility, strabismus, which is misalignment of the eyes, diplopia, double vision, and I have quite a few patients. We have quite debilitating diplopia, pain, retroorbital ache, and of course, decreased vision and depth perception. So some of the clinical manifestations are outlined here, and they do tend to be quite variable. Short-term inflammation, as I mentioned a little bit, can include the chemosis, hyperemia, edema, ocular dryness, foreign body sensation, photophobia, and eyelid retraction. Some of the longer term is retraction, proptosis, the strabismus, neuropathy, visual field defects, dryness, and sometimes corneal ulceration because of the proptosis. So, baseline assessment and routine monitoring can help identify active and progressive thyroid eye disease. The clinical activity score, we also call it as a CAS score, is used to assess the disease activity. There is 1 point that we give for each item. The total CAS score may range from 0 to 10. A score of greater than 3 to 4 will suggest, active and maybe even progressive thyroid eye disease. So the first 7, which is spontaneous orbital pain, gaze-evoked orbital pain, eyelid swelling, erythema, conjunctival redness, chemosis, inflammation. These are all clinical signs, which you could do in the office. For the 8, 9, and 10, you will need ophthalmological help. So it's not something I personally do. So these are measurements which for which you need a ophthalmometer. So the 8 is increase of greater than 2 millimeters in proptosis. 9 is decrease in the uniocular excursion in one eye with a gaze of greater than 5 degrees, and 10 is decrease of acuity on a slim line. So this is, it's good. I think the first time you see somebody with Graves' disease, probably good to do a CAS score assessment, at least to see to what degree they have eye disease, and of course for monitoring the progression. Now, understanding the significant functional and psychological burden on patients, and for any of us who have treated patients with thyroid eye disease, we can say some of them have significant symptoms. So some of the consequences can be devastating, and they can include vision impairment. So dry eye, about 65%, diplopia, double vision for about 51%, photophobia, about 33%, decreased visual acuity for about 32%, visual field defects reduction in 13%, reduced color vision 7%, and of course sometimes blindness because of neuropathy 6 to 9%. So some of the pictures about proptosis, as I said, you might need an exophthalmometer to measure the degree of proptosis. Diplopia is also one of the most debilitating symptoms. About 51% of patients with thyroid eye disease experience diplopia. It could be intermittent, inconstant, or constant. If left untreated, patients experience a decrease in vision and depth perception, nausea, headache, and limitations with daily activities. Diplopia is the principal predictor of work disability in patients with thyroid eye disease, and a grade change of greater than 1 is considered clinically meaningful when using a subjective scale. And of course, if left untreated, they go to the fibrotic stage or the chronic stage, where there is no reversal of those changes. These patients may experience quite permanent disfigurement with thyroid eye disease, and these the signs and symptoms such as proptosis, strabismus, may cause psychological distress due to profound changes in the appearance. Inability to control eye movements can lead to social disconnect, isolation, and withdrawal from human interactions. So thyroid eye disease, does have a broad implication of patients' lives. So there's significant diminution in the quality of life, and can impact the way patients see, the way they look, and of course the way they feel. So coming to the treatment options, and of course the importance of co-management, I think it is extremely important that we manage these people with, in conjunction with ophthalmologists, surgeons, and sometimes neuro-ophthalmologists as well. So there is a limited window for treatment in progressive thyroid eye disease. As I said, it's up to 3 years, and then they go into the fibrotic thyroid eye disease where it is irreversible. So once thyroid eye disease is fibrotic, damage from the inflammatory process may be irreversible, even with surgical intervention. So that's the 3 years that we have the window. So some of the thyroid treatment options, as I said, for a long time, we've had very few treatment options. So the current management options we have for thyroid eye disease. So one of them is, so the first we go to the progressive thyroid eye disease. So supportive management and symptom relief. So local measures, and that could include, cellulose drops, eye patches, anti-inflammatories. There is some studies looking at selenium as an option. I do use it in all of my patients with thyroid eye disease. Typical dose is about 100 milligrams twice a day for about 3 to 6 months. Most of the studies with selenium have been done in places which have selenium deficiency. Little tough to say if we see that not much of improvement in US where there's no selenium deficiency, but I have seen in my patients some degree of improvement. So for people with mild to moderate disease, selenium might be an option. And then of course we have steroids, both IV or oral, and then there is orbital radiation. And we'll talk a little bit about also the newly approved, FDA-approved biologic agent, which is an IGF-1 receptor inhibitor, just got approved earlier this year. And I've been fortunate enough to be able to use it on 3 of my patients. They're currently still getting those treatment right on. They're not completed all the sessions. And then there are some off-label biologics, which I will not be talking about. and then there is in the fibrotic stage, surgery itself. So steroids do provide symptomatic relief, but do have a high degree of adverse effects. So the typical doses, I have used only oral steroids. The typical dose that is recommended is about 30 milligrams a day for 4 weeks if you're using it oral. For IV, it is 500 milligrams IV once a week for 6 weeks, followed by 250 milligrams IV once a week for another 6 weeks. So it's a total of 12 weeks of treatment. Some of the benefits, quite quick onset of action, and they may reduce the inflammation for many patients. Some of the limitations, as I said, most of them need a high dose. They can have complications, as we all know from steroids. They don't stop the progression of the disease. They only provide transient relief, and of course, the risk of Cushing's, weight gain, diabetes, hypertension, osteoporosis. So steroid treatment does not necessarily improve the proptosis and may not prevent loss of vision. So we'll come to this study with teprotumumab. It's a monoclonal antibody. As I said, this just got approved earlier this year. This is the phase 3 study that was published in New England Journal earlier this year. There was also a phase 2 study. So this is the study that got the approval by the FDA. And we'll quickly go through these slides. I'm hopefully good with time. In a good example of translation research, investigators who had initially demonstrated a role for insulin-like growth factor 1 in the pathogenesis of thyroid eye disease showed that an antibody to the receptor, which is teprotumumab, which is called Tepezza as a brand name, or Tepra, produced a meaningful improvement in 83% of the patients. Pretty robust results. I'm not sure if you can see the slide very clear, but so this is the study. So 107 were assessed for eligibility, 83 were enrolled. Of that, 41 were given the Tepro IV. So the dose is usually 10 milligrams. The dose is actually 10 milligrams per kilo as the first dose. It's done every 3 weeks for 8 doses. The first dose is 10 milligrams per kilo, and doses 2 to 8 is 20 milligrams per kilo. And the initial 2 doses are given over 90 minutes, and the next 6 doses are given over 60 minutes. So 41 were assigned to Tepra, the 42 were assigned to placebo. 2 discontinued in the Tepra group, 2 discontinued in the placebo group. So approximately 40 completed both of them. The outcomes at 24 weeks were primary outcome was proptosis response at 24 weeks. Secondary outcomes were overall response, reduction in the CAS scores, mean change in proptosis from baseline, diplopia response, and of course the change in quality of life. So I have a bigger slide on these things because it doesn't show up very clearly, but all the primary and the secondary endpoints that looked at were significantly improved with Tepra. So proptosis response, almost an 83% response in the Tepra group versus only 10% in the placebo group. Also a significant improvement in the quality of life response as well. So these are some of the pictures that we have. So the top slide is the photographs of patients in the placebo group, of course, from baseline to 24 weeks, no change in the eyes. The middle slide is the photographs of patients at baseline in the Tepra group compared to at 24 weeks. As you can see, a significant improvement in proptosis and a pretty significant improvement in periorbital edema. And then the bottom slide is the MRI of that patient in the Tepra group. So from baseline to 24 weeks, as you can see, a really nice, robust improvement in the edema, retroorbital edema. So this is the study characteristics. So mostly female, most of them Caucasians, some Asians as well. The TSH on the average was 1.7, but ranged anywhere from 0.01 to almost 25. So this is the proptosis responders. As I said, this is these 83% in the Tepra group versus 10% in the placebo group by week 24. And there was an improvement at each week. Average change in baseline proptosis, almost a minus 3.3 millimeters reduction in proptosis. Diplopia, 53% response in the TEPRA group versus 25% in the placebo group. Overall responders, 78% in TEPRA group versus 7%. Some of the adverse reactions, so fairly well tolerated. None of these were severe reactions. As I said, not too many discontinuations, and no discontinuations that were different compared to the placebo. So muscle spasms were the highest, nausea, some alopecia and diarrhea, fatigue, hyperglycemia. None of them were clinically significant. My experience for the 4 sessions that I've done, some degree of muscle spasms, which are very transient, and definitely some diarrhea, which was very self-limiting. So really, in concluding the study among patients with active thyroid eye disease, TEPRA resulted in better outcomes with respect to proptosis, clinical activity score, diplopia, quality of life, compared to placebo, and serious adverse events were fairly uncommon. And then going to the fibrotic stage, surgery is the only option. Invasive surgery is currently the only option for fibrotic. So it's either orbital decompression, strabismus surgery, or eyelid surgery. So I think the key to managing thyroid eye disease is to have a collaborative approach. So delays seen in thyroid eye disease diagnosis and referral suggest that thyroid eye disease is still kind of underdiagnosed. It is not that common, but it's still underdiagnosed. Co-management by a multidisciplinary team is important, and I do manage all my patients in conjunction with an ophthalmologist. So you have to have a medical management strategy to make sure that hyperthyroidism is controlled for people with hyperthyroidism, frequent monitoring of the symptoms, addressing the risk factors, especially smoking cessation, managing comorbidities. As I said, we need ophthalmologists, maybe an oculoplastic surgeon, and sometimes a neuro-ophthalmologist as well. So really, to summarize, thyroid eye disease is a debilitating, progressive, and vision-threatening autoimmune disease with a limited window of treatment. IGF-1 receptor plays a critical role in signaling and driving the pathophysiology of thyroid eye disease. Patients may experience profound changes in appearance and vision, which can significantly affect their quality of life. Once thyroid eye disease is fibrotic, surgical intervention may be the only treatment option, and results can vary. And effectively managing thyroid eye disease requires early diagnosis and treatment, of course, active management, active monitoring, and co-management. And that really is my last slide. Thank you for the attention, and I'll be open for questions.
Thank you, Dr. Panja, for the excellent presentation. And where you've given an overview of thyroid eye disease and discussed about the newer treatment options. I think this is something which is emerging, and we all look forward to using this in our patients. I would like to ask you a couple of questions. One is about the prevalence of eye disease. I mean, in the sense that we see a little lesser prevalence of eye disease as you see in the West. So what's your comment on that? I mean, you think we are sort of, do you think that this difference is real, or is it in terms of?
I think I agree. I think it is definitely much more common in the Caucasians than I think in the Asians. And a lot of people tend to have the more milder form of thyroid eye disease, which I think a lot of times does go undiagnosed. But I agree. I don't think we see. And I think when they do studies as well, if you see the number of people they had in the study, the number of Asians were, I think, just 2 in that. Majority was Caucasians, a few African Americans.
And you are also telling us about your experience with the use of teprotumumab. And you saw that there was a good response. These patients whom you put on teprotumumab were the ones who failed to respond to steroids, or the ones, or they were not earlier given steroids?
Yeah, so one of the patients I have does not have hyperthyroidism. Actually, he's been under my treatment for hypothyroidism for almost 8 years. So his onset was very acute. We did not give him any steroids, and he's had a phenomenally good response for the 4th dose. And so he has 4 more doses left. The other 2 patients, we've already used steroids. Unfortunately, they had to stop halfway through because one of them gained a significant amount of weight, and for the others, a lot of high blood sugar. So we had to stop both of them for both of them.
Dr. Kalyan has a question. Yes, Dr. Kalyan.
Yeah, this new drug, the teprotumumab, has not been hasn't had a study head-on with steroids, right? It was just against placebo. That's all we have.
Absolutely right. So one of the things with the Tepezza or the teprotumumab is it has not been studied with steroids. So we don't know how it would stand up to steroids. I mean, compared to it is extremely expensive, so it's not something that we could that's easily available for everybody. And definitely compared to steroids, the price difference is significant.
And I just wanted to ask you one more question, because here we use generally a lot of people, a lot of doctors just use a standard omnicortal dose for 40 milligrams, 60 milligrams. And in the UK, we used to use a lot of pulsed steroid therapy. We used to give methylpred 500 to 50. Any difference in just a clinical opinion, which of this is beneficial or both are same?
So my experience, the IVs do tend to work much better. It's just that the IV is a whole lot more tougher to give. They have to come every week, and it takes about an hour, hour and a half for them to do. Whereas orals are much easier to use. I mean, interestingly, the IVs, I haven't had that much of an issue in terms of side effects as far as weight gain and hyperglycemia. I'm not sure why. I've seen a whole lot more with the orals. But yes, my experience, the IV's clinical response has been better. But it has just been, when you tell them they have to come every week for 12 weeks, they just don't want to do it.
Thank you, Dr. Panja. We had an excellent session. We had three very brilliant presentations, one on thyroid eye disease, one on obesity, and the other one on transgender medicine. So I now request my co-chair to say the final comments before we close the session. Dr. Sudhakar Rao.
Thank you, Rakesh. It was a nice interaction, and especially all the three speakers spoke very well in time, and the inauguration by Kalra was very nice. And we will go to next session, Rakesh.
Over to Dr. Kalyan.
Thank you, sir. Thank you. So we are on time. That's a very good thing to say. And we have close to 100 joinees currently, and we are expecting as the day progresses, we'll probably have around 200 joinees. So we are doing good in that aspect also. So I'm just going to share the slides for the introduction slides for the next speaker, or the next chairs actually. So I invite to take forward the next session, the first chair for the session, Dr. Ranjini Chakravarti. Dr. Ranjini is well known to us, and especially to Idea Clinics. She's an experienced histopathologist who was trained in the UK. She has a wide range of interest in histopathology, including oncopathology, lymphoma, breast, GI, and pulmonary pathology. She gives regular lectures, especially with us in our thyroid cancer. She's part of our thyroid multidisciplinary team, and she's performed research and registered more than 20 national and international publications. She has contributed a lot in pathology chapters as well. So welcome, Dr. Ranjini.
Thanks for that very kind introduction, Dr. Kalyan. Really glad to be part of this meeting today.
Thank you. So I also invite Dr. Shyam Kalavalapalli. Dr. Shyam is the founder of Idea Clinics. He's a consultant endocrinologist at Madhapur in Hyderabad. He has trained at several reputed centers in the UK, including Addenbrooke's, Cambridge, John Radcliffe, Oxford, and Imperial. He has been conducting conferences almost every 3 to 6 months before pre-COVID time, and we are very privileged to be part of these conferences. He worked as a consultant at Salford Royal University before relocating to India, and he's been with Idea Clinics. Dr. Shyam. Dr. Shyam, over to you, and Dr. Ranjini. Thank
you. Speaker?
Yeah, I'll put up the speaker.
Thank you, Kalyan. I think we are moving to the next session. The next session, we have three speakers. So they are settled in India, but they have experience outside, both in US and UK. Let me introduce Dr. Vrinda Agarwal. She's a consultant at Idea Clinics and Care Hospital. She is an American board certified endocrinologist, and she has trained in prestigious MD Anderson Cancer Center in Houston, particularly in endocrine related cancers like thyroid cancer. And she is one of our finest colleagues at Idea Clinics, very humble. So I'll pass on to her to speak on the topic thyroid cancer, dynamic risk stratifications. In fact, at Idea Clinics, we started one-stop thyroid clinic with Vrinda Agarwal, Siddharth. We have histopathologist on site. So with thyroid nodules, patients come in and same day they get the report with advice from both endocrinologist and endocrine surgeon. So over to you, Dr. Vrinda Agarwal. Thank you.
Thank you, sir. Good morning, everyone. I'll just take a minute to share my screen. So hi, everyone. So today, I feel very privileged to be a part of Idea Clinics, and thank you everyone for giving me this opportunity, to talk on, and be a part of this wonderful conference. So today I'm going to talk about the importance of dynamic risk stratification in the management of thyroid cancer, specifically differentiated thyroid cancer. So, as our knowledge and essentially our awareness is increasing, we've increasingly been recognizing that differentiated thyroid cancer is a very common endocrine neoplasia. It accounts for almost 2% of all types of cancers. The most common variant that we see in our clinical practice is the papillary thyroid cancer, followed by the follicular thyroid cancer. Now, the good thing is that the mortality from thyroid cancer remains low. And herein I would refer to it as, I mean to say differentiated thyroid cancer. So overall, the mortality from the DTC remains low with a 5-year survival of about 97.9%. What is important to note is that while the overall survival is good, the risk of recurrence is not insignificant. So that amounts to almost about 30%. So this is where it is very, very important to risk stratify these patients, because there will be some patients who will be at a higher risk, and there will be patients who will be at a lower risk of developing recurrent disease or persistent disease, and that the subsequent management and follow-up strategy should be tailored to this individual risk of the patient. So the initial risk stratification essentially starts post-operatively. So based on the histopath findings post-op, multiple staging systems have been defined so far. And based on the guidelines from 2015, the American Thyroid Association recommends utilizing the AJCC-UICC TNM staging system to best predict the risk of mortality from thyroid cancer. Now, it's important to understand that these systems essentially predict the risk of mortality. So they will tell you what is a 5-year or a 10-year disease-specific survival rate, but they're not very good at predicting the risk of recurrence or persistent disease in these patients. So to just give you an idea, based on the TNM staging system, the estimated 10-year disease-specific survival rate is to the order of 98 to 100% for stage 1 patients, 85 to 95% for stage 2 patients, 60 to 70% for stage 3 patients, and less than 50% for stage 4 patients. This is a brief overview of the TNM staging system that we utilize to predict a risk of death from a differentiated thyroid cancer. So what we see here that they incorporate a number of variables like the age at presentation, what was the size of the primary tumor, whether there was extrathyroidal extension or not, what was the extent of the loco-regional disease, distant metastasis, and then all these factors are computed into developing this staging system which predicts the risk of death. But again, as I mentioned, the risk of mortality, the risk of death does not and may not correlate with the risk of recurrence. So this was a study which was published in 2001 in JCEM. And what I essentially wanted to show that the risk of mortality is substantially low for patients less than 40 years of age. But what we do notice is that the risk of recurrence is significantly higher in the first 2 decades of life, and then of course increases again later, as we age beyond 60 years of age. So these two do not correlate. Now, this is very important to understand because the ramifications from this are huge. So there may be a patient who may be at a very low risk of recurrence, and even though he may be a higher stage to begin with in the initial risk stratification, but would he be subjected to unnecessary surveillance, unnecessary treatment modalities? And the ramifications from this may be huge for that patient in terms of healthcare cost and then the stress on the healthcare system as well. So this has what led us to think about, a paradigm shift essentially in our overview of management of thyroid cancer. So more traditionally, we used to think anybody with thyroid cancer means the patient has to undergo a total thyroidectomy. We have to offer radioactive iodine remnant ablation, and then all these patients will follow the same path of follow-up. But over time, as we have garnered more information about the management of thyroid cancers, we now understand that the management recommendations, the therapeutic decision making will change based on the individualized risk assessment. From moving from a more static approach, defined by the TNM staging, predicting the risk of mortality, we have moved towards understanding the risk of recurrence. So based on that, essentially back in 2009, the American Thyroid Association incorporated a 3-tiered clinico-pathological staging, which employed the use of the clinical pathologic features that were known to us at that point of time, which essentially categorized patients as low risk, intermediate risk, and high risk. So patients with low risk essentially meant that their disease was more located to within the thyroid, and then the surgery was able to take out the whole macroscopic disease. These patients had no evidence of extrathyroidal extension, and so they demonstrated a low risk of recurrence, 3 to 13%. Then there was the intermediate category, which basically included patients who had more aggressive histological features on pathology like tall cell, columnar cell, or Hürthle cell carcinoma. And the tumors demonstrated vascular invasion along with minimal extrathyroidal extension to the cervical lymph nodes. And this was associated with a 17 to 45% increased risk of recurrence. Then we have the highest risk category, which essentially involved patients who underwent incomplete resection of the tumor, had gross extrathyroidal extension of the disease, and may have distant metastasis as well. So these patients had a 60 to 85% increased risk of developing recurrent disease. Now, over time, of course, again, to stress upon the fact that as we've understood more about the disease, we've incorporated other features like presence of vascular invasion, number of lymph nodes involved, the size of the lymph nodes involved, presence of certain mutations in molecular markers like presence of BRAF or TRT mutations. So all these things have helped refine this ATA initial risk stratification system, which is now known as the modified risk of recurrence classification system from the ATA. And these all features tend or help to predict the risk of recurrence or persistent disease for our patients. To summarize, essentially, we started with initial risk assessment based on the AJCC TNM staging system. Now, this helps us identify patients and their risk of mortality, and then also guides us towards the initial treatment and therapeutic decision making. Now, then, as these patients come for subsequent follow-up, based on certain clinical and pathological features, this risk can be modified as the new data becomes available. And so at each follow-up point, we have to re-evaluate these individuals and our management plans. Does this patient need more extensive testing? Does this patient need additional radioactive iodine? Does this patient need any further surgical intervention? And so at every stage of follow-up, we can redefine the risk for that particular patient based on the data obtained at that particular time point. So this is what is called as dynamic risk stratification. This is an ongoing process. This is dynamic in nature, and it is bound to change. So again, now these all features, they predict the important clinical outcomes for our patients. So has their disease specific mortality changed with the availability of new data? What is the risk for recurrent or persistent disease? What are their chances of remission? Do they need additional therapy? Do they need to be evaluated for distant metastasis? Is their disease non-radioactive iodine avid? So all these decision making is bound to change, and as we re-stratify our patients at their individual follow-up visits over the course of follow-up. So how do we assess these clinical endpoints? Essentially, we follow a change in serum thyroglobulin over time. We look for serum thyroglobulin antibodies over time. Imaging involves essentially doing a neck ultrasound. If needed, radioactive iodine scanning. Other cross-sectional imaging may be done as deemed necessary, and of course, a good old physical examination. So back in 2010, and this is when I realized it wasn't too long ago. 2010, Dr. Mike Tuttle from Memorial Sloan Kettering in New York, he published a paper wherein he incorporated this term, response to therapy. So, we all talked about the ATA initial risk stratification system. This sort of helps guide clinicians towards assessing the response to initial therapy, or how should we follow up these patients, define further management strategies for, like, say, up to 2 years post surgery. But then therein he realized that the response of therapy may change for individual patients, and he essentially categorized it into 4 groups. So patients may demonstrate excellent response, whereby meaning that these patients upon follow-up have no clinical, biochemical, or structural evidence of disease. Then we have the biochemically incomplete response, where there is evidence of abnormal thyroglobulin levels, but there is no evidence of any localizable disease on, like, neck imaging or cross-sectional imaging. And then we have the structurally incomplete response, wherein we understand that there is persistent disease, or we have identified new loco-regional disease or distance metastasis. And then we have the indeterminate response group, where patients demonstrate a non-specific kind of a picture, biochemical structural findings, which we are not really confident about whether they are benign or malignant. So This is important, and essentially now to further subgroup, these response categories based on the initial treatment that was undertaken for the particular patient. So like if there is a patient who underwent total thyroidectomy and received radioactive iodine ablation, then excellent response is defined by a non-stimulated thyroglobulin level of less than 0.2 or a stimulated thyroglobulin level of less than 1 with negative imaging. Patients who did not undergo radioactive iodine ablation after surgery, it is defined, excellent response is defined by a non-stimulated TG level of less than 0.2, undetectable anti-thyroglobulin antibodies, and a negative imaging. Those with biochemically incomplete response had a non-stimulated TG of more than 1 and a stimulated TG of more than 10 in patients who underwent radioactive iodine treatment, but with negative imaging. And then for the patients who did not undergo radioactive iodine treatment, a non-stimulated TG of more than 5, or an increasing trend in the anti-thyroglobulin antibody levels associated with a negative imaging would define a biochemically incomplete response. Structurally incomplete essentially means that there is evidence of structural or persistent disease on imaging. So now, since this is amenable to change, there are patients who may begin with a high risk on initial staging system, but they may demonstrate excellent response to therapy. So over time, if we notice that their stimulated or unstimulated TG levels fall below the defined categories, then and with no evidence of persistent disease or structural disease on imaging, implies that their risk just went down. So they started with a high risk of recurrence, but over time, based on their response to therapy, they demonstrated an excellent response and their risk just went down. So would you subject these patients to unnecessary testing in terms of laboratory testing or imaging? That needs to be thought over, and that is where the importance of dynamic risk stratification comes. So like in this slide, what I wanted to say that those patients who demonstrate excellent response, you can tone down their surveillance. So they may undergo a non-stimulated TG every 1 to 2 years, and then imaging or role of neck ultrasound may be decided as per the clinician discretion. We can go lax on their TSH suppression goal to the order of 0.5 to 2. So those with biochemically incomplete response, their risk of recurrence stands at about 20%. But these patients, we can be, these patients may benefit from doing some sort of imaging like a neck ultrasound every 2 to 3 years or CT scan or a PET CT, depending on, what we observe during follow-up, whether they are showing a decline in the thyroglobulin or antibody levels, or they are showing that there is a uptrend in the thyroglobulin or thyroglobulin antibody levels. And then those with the structurally incomplete response have a much higher risk of recurrence. And so these patients, we can offer them resurgery or radiation or the use of chemotherapy or targeted therapy. So again, for these patients, we go much more stricter on our TSH goal of suppression. So we'll try to keep them less than 0.1 for our TSH goal. So essentially, to summarize what we've learned over time in terms of management of differentiated thyroid cancer is that, we've adopted a more risk-adapted approach towards management. So what that means is that at every follow-up appointment for our particular patient, we are going to reconfigure his course. This provides real-time prognosis for the patient. This defines an ongoing risk assessment that at every follow-up, as the new clinical data becomes available to us, we keep on stratifying our patient, and that is what essentially is termed as dynamic risk stratification. With this, I'd like to end my presentation. I really appreciate the attention, and I'd be open to any questions. Thank you.
Dr. Sham, have you received any questions from the audience in your chat box as a moderator? And Dr. Ranjani, your words, please.
Hello. Yeah, this is a really interesting topic. From the histopathology perspective, we have traditionally categorized thyroid cancers into three: well, poor, well differentiated, poorly differentiated, and anaplastic. Well differentiated, which is the largest category, includes follicular and papillomavirus carcinoma. So we've had this traditional distinction even in terms of histopathology. Just a couple of points. One, on vascular invasion. Yes, we've also known that this is really significant. And in fact, one of the most controversial aspects of thyroid pathology over the last maybe few decades has been the concept of well encapsulated papillary thyroid carcinoma with a follicular pattern. Right, this entity was described by stalwarts like Professor Rosai about 2 or 3 decades ago, and we earlier we were calling these adenomas with the papillary pattern, but they suggested that these should be called encapsulated follicular variant of papillary carcinoma. But Professor Rosai has himself retrenched his findings, and 2-3 decades later, he was one of the first to suggest that it's only if there's vascular invasion do these tumors behave badly. So even if it shows a papillary architecture, if it's well encapsulated and there's no vascular invasion, these tumors tend to behave in a benign fashion. So the importance of vascular invasion in prognosis in thyroid carcinomas cannot be emphasized at all. Now, histological subtypes as well. We do know that some histological subtypes of papillary carcinoma tend to behave in a worse fashion, including the tall cell variant or the Hornell variant. Also, very briefly on the molecular, again, each set of thyroid cancers, the well, poor, and anaplastic categories tend to show slightly varying patterns of molecular abnormalities. Papillary thyroid carcinoma typically shows BRAF or RET PTC mutations. These are mutually exclusive. Patients with BRAF mutations tend to have recurrences earlier. So a significant proportion of recurrent papillary thyroid carcinomas tend to have BRAF mutations. So it would certainly make sense to include at least a BRAF evaluation early in the course of papillary thyroid carcinoma to assess whether these patients are going to recur. Patients with RET or other mutations, RAS mutations, tend to have a less aggressive course. Hello.
Thank you, Ranjani, for your inputs as a histopathologist. Dr. Ranjani is a very senior histopathologist trained from the UK. My question is, as a group of endocrinologists, how can endocrinologists ensure that we have a holistic thyroid cancer care? Like diabetic foot care, thyroid cancer is, I don't know how much of the care remains with the endocrinologist. There are other stakeholders like, oncologists, thyroid surgeons. So how can we onboard this service with endocrinologists at leadership roles? Brunda, you want to advise us with your US experience?
I really think that it starts with suppose the most common entity that clinically the patient will present to you in the clinic would be a thyroid nodule. So I really think that as endocrinologists, we should at least start investing time in actually maybe incorporating use of thyroid ultrasounds in our clinic. That also gives confidence to the patient that we know about thyroid cancer management or thyroid nodule evaluation, essentially to say. And I think a team-based approach is very, very important. So what we have at Idea Clinic, essentially, the team encompasses Dr. Ranjani, a great histopathologist that we have, and then Dr. Siddharth as our endocrine surgeon. So I think we need to boost the confidence in ourselves from patients' perspective. And I think it starts somewhere by reading the ultrasounds on our own, trying to talk about or understand the histopathology on our own. So I think a more team-based approach is what is required for even because thyroid cancer is a word which is essentially scares people. So and cancer stands synonymous with oncology. So that is why I think endocrinology needs to take that management of endocrine neoplasia in their hands. And the most common neoplasia that we see is thyroid cancer. So I think doing a thyroid ultrasound would be a good place to start.
Ranjini and Vrinda.
Hello.
Are we doing a molecular markers for a thyroid in our IDEA clinics daily?
No, actually speaking, we've just started our molecular lab. So hopefully by this time next year, we should be able to offer you a comprehensive thyroid panel on FNA, cell block, or even on, I'm hoping on paraffin embedded tissue.
Right. Thank you.
Any questions from the audience? There's a big group of audience. If you have any doubts, I think this is a good platform to clarify our doubts. Even reporting of ultrasound, there is no standardized format in India. So I don't know how we can address this.
Well, recently we are seeing a lot of radiologists actually reporting the Tirads classification. So especially in the place I work in, and they have made it a standard. So I think it is rolling out. I have seen a few reports with the Tirads classification. So hopefully that should standardize the.
Sorry, can I make a comment, Shyam? Sorry.
Yeah.
Good morning. Very nice talk, Dr. Vrinda. I think, like I said in the chat box, I think the main thing is we need to make sure endocrinologists get back the care of the thyroid cancer patients. Here, what happens is after the surgery, they typically just get routed to the oncologist who treats them as every other cancer. So like you were mentioning, when we work up, I also tell my patients, come back to see me. I'll be the person following you up after a thyroid cancer surgery. I am the person who's going to be administering radioactive iodine follow-up. So the education from our part also, and maybe also on the part of the endocrinologist, I think Dr. Rakesh has mentioned that, we need to make sure that it's a very different type of follow-up after thyroid cancer. It is not like every 6 months liver function test, that type of thing does not happen. So it's a very nuanced endocrinology-based follow-up. So we need to take that back into our hands, I feel.
Thank you. I think we will move on to Dr. Jayashree's talk. Thank you, Dr. Vrinda. Very, as usual, you are our, in Hyderabad at least, you are our thyroid expert. So we look forward to your contribution much more. Now moving on to Chennai, Dr. Jayashree Gopal. She's one of the senior colleagues. She's a director at Diab Endo India, Chennai Institute for Diabetes, Endocrine and Metabolic and Lifestyle Health. She has experience from all three worlds, from the US, UK, she's a diplomat of American Board in Internal Medicine, Endocrinology and Diabetes. And she's a senior consultant at Sitapati Clinic and Hospital. So she is also Associate Dean for Teaching and Research, MV Diabetes Research Center. She has trained both in the US, UK, and now settled at Chennai. So over to you, Dr. Jayashree Gopal. Your topic is timely insulin initiation, bringing innovation close to the Indian reality. Over to you, Dr. Jayashree. Thank you.
Thank you very much, Dr. Shyam. I'm just going to, yeah.
If the oncology sessions are done, maybe I can.
Can you see my slide as a full screen presentation, please?
Yes, yes.
Okay, thank you very much.
Yeah.
So first of all, congratulations to the IDEA team for putting together such a wonderful lineup of topics, very pertinent to practicing endocrinologists. And thank you again for inviting me here today. This is my financial disclosure. I'll be talking today about the co-formulation insulin. Let me just pull up my. So I don't think any of the data that I present in my talk is new, except maybe about 3 or 4 points maybe will remain with you after I finish the talk. So we know that we are currently ranked second in the world in terms of the number of people with diabetes, and it's projected to increase to 135 million. And I was just thinking that COVID within a year has overtaken diabetes, but diabetes is just basically COVID on a very, very long scale. But if you look at the mortality, 1 million diabetes-related deaths in India annually, and just compare it with the number of COVID-related deaths, it sort of gives you the scale of diabetes and the problems that occur due to it. And of course, it's a humongous cost burden in our country where most of the care is borne by patients out of pocket. And I think more alarming is that about half of the people with diabetes do not know that they have it, and which also means that about 2 in 3 get diagnosed when they present with a severe complication. And we all know the importance of maintaining the HbA1c below 7%. We are all aware of the reduction in complications. But also we need to keep in mind that if we maintain the HbA1c less than 7% continuously for a year, it also reduces the diabetes-related treatment costs by 25%. And I thought this was an interesting way of presenting. Sorry, there is some other. Some other sort of.
Sorry, can everyone mute their mics except Dr. Jayashree, please?
Yeah, thank you. So, but this also means that the diabetes-related costs, whether it is related to the pharmacy purchase of medicines or other costs to the medical costs like hospital visits, clinic visits, comes down by 25%. And this may be one of the factors we can use to explain the importance of HbA1c reduction. In spite of knowing that we need to maintain the HbA1c below 7%, only about 1 in 5 of our diabetic patients achieve that goal. 4 out of the 5 remain at around 9%. So we are not doing very well in terms of glycemic control, whether or not people are on insulin or on OAD. So we are not aggressive enough in chasing the HbA1c goals sometimes. The RSSDI guidelines last year recommended that we consider insulin initiation if patients fail to achieve or maintain A1C after 3 OADs. Out of those 3 OADs, one of them should be a newer agent, either I'm assuming a DPP-4 or a SGLT2. However, I think there is no doubt in any of our minds, particularly in patients who appear cachectic, who have hyperosmolar symptoms, irrespective of whatever medications they may be on, insulin is the one that gives the quickest improvement and helps them anabolically also. And the other advantage of insulin is that it has the best HbA1c reduction, the highest HbA1c reduction, mainly because there is no upper limit to the dosage of insulin. We can keep on increasing till we achieve the HbA1c. So that's a big advantage of insulin. And every time we talk about the newer molecules nowadays, we think about anti-inflammatory, cardioprotective, and we need to remember that old insulin is also all of these things. It is anti-inflammatory, it has got anti-thrombotic effects, it is antioxidant, it does have some platelet inhibitory properties. But apart from all of this, I think most of us tend to think of the benefit of insulin in terms of the rest that it gives to the beta cells, and hence an improvement in the beta cell function and insulin secretion. So this is one of the major benefits of using insulin, which we will not achieve really with any of the oral agents. So what are the benefits of timely insulin initiation? To understand that, we need to keep this data in mind. And again, I think this is a slide that will go a long way in helping us convince patients about the need for insulin therapy. Even when your post-glucose, 2-hour post-glucose challenge level is around 120, you've already lost about 50% of your beta cell secretory function. So 2-hour post 75-gram glucose load, your blood sugar should come down way low. Even if it starts going to around 140, you've already lost about 70 to 80% of your beta cell secretory capacity. And of course, by the time diabetes is detected, you're down to a very, very low level, maybe around less than about 3 to 4% of the beta cell function. If you combine this with the fact that If you combine this with the fact that Indians also have a predilection for lower beta cell, maybe because we are born with a lesser beta cell mass at birth, we tend to have lesser insulin secretion. Insulin resistance is not a major, is not such a driving factor as it is insulin secretory defects. And this study compares the blue bars on Pima Indians, the orange bars are in Asian Indians. And you can see that whether we look at the fasting insulin level or the response of insulin at 30 minutes to a glucose challenge, you can see that both in the fasting state and in the post-glucose state, we make very, very little insulin. So there is a significant insulin secretory defect, which is already occurring in the Asian Indian population. So why does this matter? Because the defective beta cells further increases hyperglycemia, and the hyperglycemia further causes defective beta cell function because of the glucotoxicity. So we need to break the cycle somewhere, and insulin is one of the best ways to break the cycle. And like I mentioned, give the beta cells a rest and let it start working properly again. And in fact, this study, which was done by Dr. Mohan, among others, looked at early insulin therapy. They took just about 100 patients, symptomatic, newly diagnosed diabetic patients with a HbA1c of 9%. They were put on pre-mixed insulin for 2 months. And at the end of 2 months, they were switched over to oral agents, and then they were followed up for 3 years. And I don't think any of us can doubt the fact that insulin is going to cause a significant reduction in the HbA1c. But I think what is remarkable is at the end of 3 years, also this good glycemic control is maintained. So this is a very, very strong supportive message for early insulin initiation. And this is only for 2 months. And after 2 months, once whatever be the oral agents we put them on, their glycemic control is maintained, mainly because their beta cell has gone back to working normally. So it drives home the fact about using insulin early. And the way I explain it to patients is if we use it early, we can get away with using it for a brief period of time. If we need to use it later, chances are you're going to remain on the insulin because we cannot protect your beta cells. And the HbA1c also similar results. Even after the change to oral agents, there was a further drop in the HbA1c. And this drop in the HbA1c persisted even at the end of 3 years. So early insulin initiation is very beneficial. Now, how do we ensure that we meet the glycemic control requirements at insulin initiation? Before we move on to deciding what type of insulin, we have also, of course, have to convince the patients that insulin is necessary for them. And there are, of course, a lot of physician inertia factors, patient inertia factors. This has been talked about at several forums. I think one of the things which helps is some of the misconceptions that patients have. Will they be able to take their injections properly? And this is a very interesting thing. Patients often have a goal of reducing or eliminating medications. Unlike doctors, we feel that intensification is necessary. They feel that avoiding medicine is the goal. We feel that adding medicines is the goal. So our sort of our goal points are different. Of course, financial burden is another factor. And I think a lot of them feel that insulin therapy is the treatment of last resort, and they are already feeling guilty that they are not being able to maintain their diet and exercise. And so it is a punishment that we are imposing upon them. And of course, unrealistic fear that insulin causes harm. So it led to coining this term of psychological insulin resistance. So it does take a lot of work on the part of both healthcare providers and our support staff to overcome these barriers. So I think one of the several sort of tips that have been offered. One is to begin the discussion in a collaborative communication style. We know that the sort of an older way of communicating medical terms and medical therapy benefits, the paternalistic type does not work, particularly for the younger generation. So we need to sort of start talking about it as what is it that your goals are? What is it that you would like to achieve in the diabetes? Why do you think I'm recommending insulin? And I think the most important factor that decides whether a person is going to accept insulin or not is a doctor who believes in the efficacy of the insulin therapy. If the doctor is convinced, a lot of times we are able to convince the patients. If we are not convinced ourselves, we can never convince the patients. And of course, we discuss the health benefits of the treatment targets. Rather than saying if you don't take insulin, you're going to lose an eye or a kidney. That doesn't work anymore. And also explain, I think it always helps to say that insulin therapy may only be needed for about 3 to 6 months. Chances are very good that once your sugars come under control, we'll be able to stop the insulin and consider using oral agents if your beta cell function recovers enough. Whereas if we keep on delaying it, we may never be able to stop the insulin. So, and again, assessing and addressing each concern of the patient. What exactly are you worried about with insulin? So if we are able to pin them down to their fear about insulin, I'm scared, doctor, it's going to affect my kidney or my eye, or I'm scared of the injection. I think if we can pin them down to the concern about the specific concern about using insulin, we can address it and help them get over it. And also, I think one of the other things is that understanding that with time, over time, type 2 diabetes in some people does change, as in the blood sugar control does get worse, which means that additional medication is needed. And which means that if oral agents do not work, insulin is necessary, maybe for a brief period of time. So understanding how diabetes changes over time. So all this, of course, takes time. And in our country, because all of us are not sort of privileged to have good diabetes educators or good dietitians in our clinic who may take up this role, a lot of us face problems because we do not have time to address the patient sort of concerns and help them onto insulin. Once we've convinced the patient that they do need to be on insulin, comes the question of what type of insulin. Is it going to be a basal or a premixed? And I'm not going to debate the two. I just want to talk about the advantages when we start with a co-formulation or a premix. And of course, the biggest advantage is that you can reduce both the fasting and the postprandial if you use a co-formulation or a premix. And of course, in our country, probably because of our high carbohydrate diet, we know that the postprandial glucose has a much stronger correlation with the HbA1c as compared to the fasting plasma glucose. And all said and done, the basal insulin may not, unlikely to control the postprandial excursions to the extent that a co-formulation will, which it will control both the fasting and the postprandial. So the insulin co-formulation concept, it basically, let me just get all the graphs on so that I can point it out. It avoids the shoulder effect of premixed insulins also with the co-formulated insulin. So the green bar here is the so-called shoulder effect that would happen if we use a regular premixed insulin, which is basically a mixture of the regular insulin and the protaminated insulin. So the protaminated insulin tends to have sort of a persistent lingering effect, working partly like a short, partly like a long-term insulin, so that you may get unintentional hypos if you don't dose the insulin properly. Whereas if you use a true co-formulation, the short-acting part, this blue part, is completely separate from the long-acting part. So it works exactly like insulin is secreted in our body. You have a spike and then you have the base. So in that respect, a co-formulation is believed to mirror our body's insulin secretion following a meal closer than even the regular protaminated insulins. And one of the studies that was done in insulin-naive patients, nearly 300 patients, they were randomized to either a co-formulation or a basal insulin, in this case, U100 glargine insulin. And the criteria was that they should have had diabetes for more than 6 months, HbA1c between 7 to 10. It was an open label study. And before randomization, the sulfonylureas, DPP-4 and glenides were discontinued. The patients remained on the metformin. And the starting dose was 10 units for both treatment arms. And what was interesting was that the co-formulation was administered with the largest meal of the day. The dosing time was chosen at the discretion of the patient. The patient could decide to have it either with the breakfast or with the lunch or with the dinner, and depending on the population you're looking at. So if you look at a predominantly Caucasian Western population, they would tend to have it with the dinner time. In our country, I think most Indians would choose to have it with the lunch time, which tends to be the largest meal of the day, or maybe the breakfast time. And the glargine U100 usually was administered before breakfast or at bedtime. The timing of the dosage was not to be changed during the trial, only the dosage was allowed to be changed to meet the glycemic targets. And what was seen was at the end of about 6 months, there was much better reduction in the HbA1c with the co-formulation insulin. The fasting blood sugars reduced to a similar extent. However, the postprandial, particularly after the dinner, like I said in this study, most people chose to take the co-formulation before their largest meal, which for them was the dinner. The dinner postprandial sugar came down very well, which also probably drove the fact that that fasting also remained low. And there was a lower risk of confirmed hypoglycemia with the co-formulation as compared to the basal glargine insulin. So multiple benefits with using once daily co-formulations, including a better reduction in the HbA1c with a lower risk of hypoglycemia. And the reason why the co-formulation may be a better choice for Indian patients, of course, are very high carbohydrate diet. So we have big spikes after every meal and the higher postprandial glucose levels. And of course, we need the convenience in insulin therapy. We are not going to, basal bolus can be a bit of a challenge for patients, particularly if we are initiating them initially. And I think one of the major advantages of using a co-formulation is the ability to subsequently intensify with convenience. So this is a table which compares the advantages and disadvantages of co-formulation versus basal insulin. And of course, I mentioned about the fact that co-formulations give better control of postprandial. Both are probably equal for fastings. This may be better in case of delayed insulin therapy, where you might have a much higher spike in your postprandial, whereas earlier on, you might just have a raise in the fasting alone. And I think this is a really good factor because they already have the pen and we just tell them, okay, you're used to taking it in the morning, now just take it in the night. Or you're used to taking it in the afternoon, now instead of just in the afternoon, make it morning and night. So the subsequent intensification with the convenience of using the same pen without needing to learn, though they're all very similar, but without the ease, the comfort factor, familiarity. You're already familiar with the pen, you're already familiar with that. So that subsequent intensification becomes very convenient. And we should not discount this when we are choosing the initial insulin. The current RSSDI.
We are getting late. We can
yeah, this is my last slide. Okay. So the RSSDI does consider using insulin either with a basal, pre-mixed or co-formulations. And it is a good insulin to begin with. And the basal and bolus components help offer total control with reduction of both fasting and PP. Thank you. And thank you again to the IdeaCorp. Sorry, to the organizers. Thank you.
Okay. Let me begin by asking, as we had the previous talk on obesity, how much of a burden is insulin causing towards weight gain to our patients?
I think if we can achieve, so there are two types of weight gain. I always tell patients that the initial weight gain that happens because of better blood sugar control, do not worry about that. The better blood sugar control, we can accept about a 3 to 5 kilo weight gain initially, if it means your sugars are under better control. Once the sugars come under control, we will work on reducing your weight. Do not worry about it. In the long term, if we can achieve a good blood sugar control without causing recurrent hypos, in other words, avoiding glycemic variability, I think it is much easier to avoid these hunger pangs and a sort of a combination of a relatively lower carb, relatively higher protein and a good high fiber diet. Avoiding these ups and downs means that the patients do not need to gain weight. So I think that is really a thing of the past, apart from the weight gain that occurs initially with better sugar control.
Any questions from the audience, please? I think, thank you, Dr. Jayashree, for your
thank you very
interesting
much.
Talk on insulin, something we use day in and day out. I think we'll move on to the next talk, which is again on insulin. The topic is redefining insulin therapy by Dr. Jaydev Sudagani. He is based out of Vijayawada in Andhra Pradesh. So he is a consultant endocrinologist at Shanti Endocrine and Diabetes Hospital. He's also an assistant professor at PIMS Vijayawada. He has done his research in the molecular genetics of type 2 diabetes from the UK. And over to you, Dr. Jaydev. Thank you.
Thank you, Dr. Shyam. Thank you to Idea Clinics and Professor Sudhakar Rao sir and to Dr. Rakesh Sahai sir. And good morning, doctors. It was an interesting talk. I don't want the audience to be confused about the type of insulin therapy that needs to be started when we are thinking about insulin therapy in type 2 diabetes patients. But I'll try and show slightly different take on the insulin therapy and redefining insulin therapy. So I just want to confirm that the voice is clear and you can see the slides clearly.
Yes, all good.
Yeah, thank you. So redefining insulin therapy, and from what Dr. Jayashree Gopal has clearly highlighted, insulin therapy is something which is going to be almost inevitable for type 2 diabetes patients, and we have to initiate insulin therapy at some stage to get excellent glycemic control. So the talk is mostly on type 2 diabetes, and this talk is through Sanofi team, and you can recognize the kind of insulins that they promote. And what I'm going to highlight is the kind of insulin adoption which has happened in India and what has been changing over the years. And then I'll try to talk about this high HbA1c and postprandial glucose control. And can we get down postprandial glucose by just getting down the fasting glucose to target ranges, as is done in the clinical trials with glargine, which is the gold standard basal insulin, where the fasting blood sugar is aimed to be at around 100 milligram per deciliter. Does that help in bringing down the postprandial glucose with it? Does it draw it down as well? And then to talk about why basal insulin is needed and how can we get the patient started on basal insulin, and what do the patients think when it comes to basal insulin therapy. And eventually there are 3-4 slides on the new basal insulin from glargine, the U300 glargine, which is available, the ultra long acting basal insulin. So what is being shown here in this slide, compared to a study in 2011, DiabCare by Professor Mohan's group, which was published in IJEM, there are a lot more patients who are taking premix insulin compared to basal insulin therapy. As the years pass, you can see the study and this poster presentation in ADA last year. You can see that there is clearly basal insulin usage has gone up. It is not to say premix insulin usage has gone down any significantly. There is a lot more insulin usage again. And there is also usage of injectable GLP-1 receptor agonists and prandial insulins, which are being used in this new study, which was conducted relatively recently. And what is being highlighted is the fact that as far as the guidelines go, there is a lot of stress of giving basal insulins in type 2 diabetes management. And that is being reflected in the care which is being given to the patients in the Indian context as well. And what are the barriers which are there? The barriers for basal insulin use in Indian patients, is it the right choice for our population given the very high HbA1c that they may have when we are thinking about starting insulin? Does premix insulin is the only one which is giving the postprandial glucose coverage? Can we get that with basal insulins as well? And I'll show you trial data which is there. These CGMS AGP based studies which are showing the relative contributions of glucose is important, but when we initiate insulin therapy around that mark of 8, 9 or 10% HbA1c, or even around 7.5, the patients are not reaching target with adequate oral hypoglycemic agents, there is still a significant contribution of fasting blood sugar which is contributing to the A1C. We are not arguing that the postprandial glucose is not contributing to A1C, but trying to get this fasting sugar from a high value to a fasting blood sugar of 100, 120 milligram per deciliter, can it bring down the postprandial glucose values? And these are the various trials which are lasting from a duration of 24 weeks to a maximum of 36 weeks. These are glycemic control trials based on glargine therapy, glargine U100, trying to get HbA1c to less than 7% by just targeting a simple fasting blood sugar target of less than 100 milligram per deciliter. And most of the titrations can happen by the help of the researchers, and there have been studies where the patients themselves have adjusted the insulin dose to get a fasting sugar below 100 milligram per deciliter. And you can see the histograms here before entry into the study and after the end of the study period. Clear A1C reductions are there in all these studies, suggesting that this is a good treatment choice for type 2 diabetes patients to get the HbA1c to target by just targeting the fasting blood sugar. Obviously, the patients will still be on oral agents, whether it be metformin alone or a metformin plus secretagogues, or the new agents like SGLT2 inhibitors or DPP4 inhibitor therapy. So you can combine the basal insulin with almost all the oral class of anti-diabetic drugs which are available to get the blood sugars under control. And this is Origin trial is a trial which included newly diagnosed diabetes patients and also pre-diabetes patients. But just by targeting a fasting blood glucose of 100 milligram per deciliter, there has been significant postprandial glucose levels which have been addressed as well, and those control was maintained without any significant risk of hypoglycemia. And this was a cardiovascular outcome trial where Glargine 100 showed that it didn't cause any excess cardiac events in patients using insulin therapy. And this was one of the important trials when it comes to insulin and cardiovascular outcome trials. It didn't show any benefit, but it didn't show any harm either. And the basal insulin decreases the postprandial glucose. This is the evidence. This is a study from Dr. Agarwal and Dr. Wadhwa's group, which has been published. I know it is a standalone study which I'm highlighting, but what is being highlighted is from the baseline at the end of 12 weeks, if you get the fasting blood sugars down significantly by using basal insulin, you can get the postprandial glucose levels down as well. And the HbA1c, obviously the improvements are noted. So targeting fasting normoglycemia with basal insulin lowers postprandial glucose in premix uncontrolled patients. So in those patients who were not controlled on premix insulin, whatever be the reason, whether the doses were not addressed adequately or the oral therapies were not adequate, but this is a proof of concept study trying to change from premix to basal insulin, give adequate dose of basal insulin, targeting a fasting blood sugar of 100 milligram per deciliter, and you're getting more patients getting to target levels at the end of 20 weeks period by switching over to Glargine 100, suggesting you have to have a regime in your diabetes patients which is simple to use, give once daily therapy, preferably at bedtime. That is what my practice is, and I believe most of the doctors who are doing basal insulin therapy give insulin Glargine at bedtime and target the fasting blood sugar and achieve glucose control just by reducing the fasting blood sugar levels. So if we are convinced that we have to use basal insulin in type 2 diabetes patients, why should be the reason? If we just look at our RSSDI guidelines from our country, you can give basal insulin alone or in combination with metformin as the most convenient initial insulin regimen. So there are clear-cut guidelines suggesting this is a good therapy option in diabetes patients. If you look at the ADA, they are mostly in favor of basal insulin, but they also talk about escalation of therapy when they go towards the premix insulin therapies. IDF concept is interesting. They have suggested basal insulin can be preferred or should be preferred, and it also can be temporary. I think this point was raised by our previous speaker, Dr. Gopal, as regards to giving insulin right at the beginning, get excellent glycemic control, and then maintain the patients on oral agents. But if we just look at the other end of the spectrum, if there is a long duration of diabetes and the patients have got high sugar levels and they require insulin therapy, trying to get them on insulin, which is easy to use, is probably convenient for the patient. And it may also be easier for us or our diabetes educators in the clinic to address the dose titrations that are obviously needed to get the glucose into good control. Again, this is a study from the Origin trial again, outcome reductions with Glargine, which was published quite some time back again. So long-term use of insulin Glargine compared to that of standard therapy, you see the percentage of patients who achieve a A1C of less than 6.5%. It is much higher in the Glargine group compared to the standard group of therapy, which encourages compliance, and also the better glycemic control is leading to hopefully prevention of microvascular events in the long run. Macrovascular benefits were not seen in this trial, nor was there a harm in giving the basal insulin to these patients. But long-term data may be difficult to achieve and to extrapolate based on this study alone. But there is suggestion that if you get excellent glycemic control within the first 1 year of therapy, you can prevent macrovascular complications. And this study by Dr. Kamlesh Kunti's group has clearly highlighted that extremely good glycemic control within the first year should be aimed for for majority of our newly diagnosed type 2 diabetes patients, rather than just being lax with therapy in the beginning stages of their disease. I think you can look at this data in whichever way it is trying to compare glargine once a day with ida-gasp, and the HbA1c levels almost similar. And at baseline and at the end of the study, you get a slightly better fasting glucose reductions with insulin glargine, but you get a slightly better postprandial glucose reductions with the once daily ida-gasp, which is given with the biggest meal of the day. So you can look at the data whichever way you should look at these things, but insulin dosing and adequate titration is the way to go. Starting therapy is not going to be adequate to get the patient to goal as regards to glucose control. And how does basal insulin compare with co-formulation, which is the ida-gasp? Confirmed hypoglycemic events, they are much, much lower with all these insulins. With the novel insulins and the long-acting insulin analogs, they are excellent and they are much lower. But just comparing between these two in this study alone, which was published again, it is suggesting that ida-gasp had a higher hypoglycemic events compared to the other ones. But there are other data suggesting almost on par and not major differences in the hypoglycemia. But the risk is lower compared to the conventional insulins with these insulin therapy. There are studies which are suggesting basal insulin is going to get a better A1C reduction compared to premix insulin. This was published quite some time back, again 2005, and there are studies suggesting the ease of use. Hypoglycemia event rates are much lower with glargine compared to premix insulin. Weight gain as well is lower with glargine compared to premix insulin, and the doses required is lower, the total daily dose compared to premix insulin. All in all, with a positive p-value, what is being shown in these studies, look at glycemic control in type 2 diabetes, is these therapies with glargine, titrating the dose to get the fasting blood sugar below 100 milligram per deciliter, is going to get excellent glycemic control, reduce the risk of hypoglycemia, reduce the risk of weight gain, which is going to happen with insulin, and also the dose requirements can be well lower than the premix insulins. Interesting to note, the amount of glargine dose which is there in this study is around 51 units by the end of the study, the mean dose, suggesting you have to titrate the doses adequately to get good glycemic control. So how do we start basal insulin therapy? There are various calculations. I'll not go into too much detail, but what is being highlighted is you can ensure that you give adequate insulin dose based on the patient's body weight and the baseline A1C, or you may wish to start with a standard dose of around 12 to 18 units and titrate the dose based on the glucose levels. So there are no hard and fast rules. You don't necessarily have to just follow this algorithm of giving 0.2 unit per kg start, because you never know the sensitivity of the patient. This patient may have quite significant insulin sensitivity, and this patient may be insulin resistant. You wouldn't think that would happen, but it can happen in clinical practice. So there is no harm starting at lower doses and gradually titrating the insulin dose. And the dose adjustments are easy to follow. And if the levels are slightly higher than your recommended target range, you just add in an extra 2 units. If they are significantly higher, you can go by an extra dose of 4 to 6 units. And because these patients may be much more insulin resistant, so you can dose titrate. And these are based on self-monitoring of blood glucose or clinic monitoring, as it happens in some instances. And then you adjust the dose targeting the fasting blood sugar levels. So how about the patient outcomes with basal insulin? This is the treatment satisfaction questionnaire. On the left-hand side is glargine, on the right-hand side is premix before and after starting therapy. The patients are much more satisfied when they are on once daily glargine therapy to twice daily premix insulin therapy with oral antidiabetic drugs. And this is patients who have switched from premix to basal insulin. And you can see that the perceived hypoglycemia risk or hyperglycemia risk, the risk scores are lower in those patients who are on glargine compared to those who have been on premix insulin before. And these patients are recommending insulin to others in a higher percentage of time. They are finding it more convenient and they are finding it more satisfactory. So what is being highlighted is the ease of using glargine 100, and it has been a gold standard therapy for basal insulin for quite some time. Treatment adherence with basal insulin also very high because the patients are finding it comfortable. Again, a study, Zhang et al. Published in 2014, you can see the treatment satisfactory questionnaires again. that if the patient is adherent and they are finding it convenient to use, they're more likely to get glucose to target and HbA1c to target. So how about the advances in basal insulin? Glargine 100 has got a half-life of 12 hours. It is a 24-hour acting insulin, but the half-life is 12 hours. But you've got a concentrated form of glargine, which is glargine 300, which has got a much longer half-life and reaches a steady state within 2 to 3 days. And it is slowly released and it gets glucose control maintained over a prolonged period of time. This is the BRIGHT study. It had 2 phases, the initial treatment phase, the titration phase, and then the maintenance period. During the titration phase, where the glucose levels were trying to be achieved to a stricter level, the incidence of hypoglycemia or the event rates, the total event rates, were lower in the glargine 300 group compared to the IDEC 100 group. Overall, there was no difference, but while titrating, the hypoglycemia risk was lower. So you can assume it is probably not right way to do. Assumptions are not good in clinical practice, but you can assume if the patient is going to have lesser risk of hypoglycemia, they are more likely to be compliant with therapy. And these hypoglycemia risks were no different in the maintenance period. This is again a sub-study looking at based on renal function in these patients who were on glargine 300, and you comparing with IDEC, again a sub-study of the same BRIGHT studies which were done. If the kidney function is good, both reduced A1Cs to similar good levels with low risk of hypoglycemia. The hypoglycemia risk was very low with these therapies. But if the renal function was moderately impaired, there was slightly better A1C reductions with glargine compared to IDEC. You can see the baseline values and the reductions at the end of this study, week 24 values. If the renal function was poor and they were in CKD stage 3, the A1C reductions were much, much better with glargine 300. There was no real explanation given here, but the likelihood about how glargine may work well when there are differences in the acid-base metabolism was suggested. But this was the outcome which was seen in this study, that there were better A1C reductions the worse the renal function in a type 2 diabetes patient. So in elderly population, it is always safe to give good insulins with low hypoglycemic risk profile. I think both these tick the boxes as regards to safe insulin therapies in these patients. But you can see here comparison between glargine 300 and IDEC, you had higher A1C reductions with the glargine 300 group in the elderly population. Again, a sub-study in the BRIGHT group. So overall, the summary, I'll close my talk here. Insulin is going to be needed at some stage in type 2 diabetes management. The adoption of basal insulin is increasing in the Indian population. Basal insulin definitely provides good glycemic control. Both fasting and postprandial glucose reductions can be achieved by targeting fasting blood sugar alone by titrating the dose of basal insulin. Without compromising on safety, the hypoglycemia risk is low. It is very convenient, and it has been advised that we use this basal insulin therapy by global and Indian guidelines. You can individualize therapy. You can start on a flexible dose of insulin, easily up titrate based on the glucose levels, and you can achieve good glycemic control by adjusting insulin dose. And in clinical practice, you can go up to 0.5 units per kg body weight up to the maximum limit of the basal insulin, or even slightly higher. In the trials, they are going to doses of around 0.7 unit per kg body weight by the end of the study as a single insulin dose with oral agents as well. Ease of use is there. We are familiar with this insulin, basal insulin, and it helps improve the patient adherence. If you are thinking about newer insulin therapies, you've got glargine 300 as well, which is providing excellent glycemic control and much lower risk of hypoglycemia compared to the previous generation glargine unit 100. So I finished the talk here, and I thank the organizers, Idea Clinic and Dr. Shyam, for giving me this opportunity.
Thank you, Dr. Jaydev. Very interesting talk. The one query, while we wait for the audience to put up their questions, they can type their questions on the platform. In the meantime, we all agree that basal insulin is very convenient for our patients. How should we manage in the post-COVID when we have to remotely titrate doses? How effectively can we manage insulin dose titration or initiation without subjecting our patients to clinical errors?
Yeah, it is a very important question, and I think basal insulin therapy is probably going to be extremely helpful in this scenario, because you've just got to rely on one major glucose target, the fasting blood sugar, and you've got the oral therapies which you can use along with it, like a DPP-4 inhibitor and the full dose metformin. Both of them are going to be helpful for the patient because of the coronavirus induced insulin problems and also the steroid effects. You can cover both of them along with basal insulin. So even in patients, you can definitely cover them with a DPP-4 inhibitor and basal insulin. There was an excellent study, the SITA in-hospital study, which was showing you can get good control in hospitalized patients by giving once daily sitagliptin and once daily glargine. Glargine was the most commonly used basal insulin in that study. So all in all, I think we can achieve good controls, and multiple doses basal bolus regime may be a bit difficult because not many clinicians are going in for ward rounds 3-4 times, or the nurses can't go in each time checking the sugar levels. But I believe we can definitely achieve good control with the basal insulin therapy in the COVID affected patients as well.
Okay.
Shyam, can I make a comment?
Yeah, Dr. Mukherjee, welcome.
Good morning. I've been listening in the background to all the talks. Thank you very much. See, regarding insulin, I just gave this talk yesterday in Trendo about initiation and intensification of insulin. My humble request to all those people who are logged in and listening to us, both to Jayashree and to Jaydev, I mean, please start insulin. In India, we do not start insulin. We start insulin very late. We do not give adequate amount of insulin. Once we start, we don't titrate. Once we titrate, we don't intensify. So with folded hands, please start insulinizing our patients. We all know, set your HbA1c target and then 2 or 3 drugs. In India, we procrastinate. We wait for 4 drugs, 5 drugs before we go on to insulin. And after that, we just had a debate basically of co-formulation premixed versus basal. Both Jayashree and Jaydev presented the data very well. It's always a debate. There are certain points which favor basal, which were very nicely illustrated by Dr. Jaydev, and there are certain points which favor a premix or a co-formulation, which were very nicely shown by Jayashree. So basically in India, we are a premix market because we start, there's only one reason for me. All the other reasons we gave, I think are not valid. The only reason India is a premix market is we start insulin very late. We start insulin when HbA1c is 9, 9.5, 10. Then basal loses out completely, as Dr. Jaydev shows. Basal is a very early insulin. Origin trial, majority of them were pre-diabetics, a few, 15-20% were diabetics, early diabetics. So if you are starting basal early on, this concept that basal will fail in 6 months, of course in India it will fail in 6 months because we are starting it so late. If you start early, as Origin trial shows, you can maintain for 6-7 years with just a basal insulin alone, along with your OHA, including sulfonylurea. So just these 2-3 points I wanted to get across. First is stop blaming the patient, start blaming yourself. There's a huge psychological inertia amongst us physicians, many reasons, time being one of those. And once you decide, start something. Something is better than nothing. I'll stop here. Back to you, Shyam.
Good, very good suggestion. I think Dr. Jaydev and Dr. Murli, I have a query now. See, Murli came back recently from the UK. In the UK, it's the patients who can self-titrate. In India, Jaydev might agree, patients expect doctors to titrate the dose. So what is the best way for dose titration? Should we leave it for patients or should we take up that responsibility? Over to you both from Vijayawada.
Murli, do you want to take it?
You're the best. Go on. Okay. So, titrating, obviously in England, it's a complete different scenario. We have diabetes nurses who...
Dr. Murli, sorry to interrupt. I think there's a lot of disturbance in your...
Can you hear me?
Yeah, we can, but there's a lot of disturbance coming from your mic. I think the mic is the problem. So if you can just probably hold the mic a little farther away from your shirt or something, maybe.
Can you hear me better now?
Okay, please try. Go on.
So in England, it's a different matter, mainly because education levels and the understanding and the support they have and diabetes nurses and education is a little bit better compared to Indian population. But I think we can actually do exactly same even in India for the right patient. So the patient is good enough to understand how each insulin works and how to titrate. Also, if they know when to contact, and most importantly, now we have this platforms where they can actually contact via WhatsApp or something like that. I think it can be easily done. I don't see a big problem as long as you educate the patient.
I think it is a relevant point. The only way I ask the patient is to adjust the dose just by 2 units. I don't ask them to do too much and give them the target range between 80 to 120. And the patients do it over a regular period. But for the first 3-4 visits, which happens every weekly, either by a physical consult or a phone contact, the doctor does it. I tend to adjust the dose, but they will see the readings as well. But afterwards, I ask and request the patients to adjust the dose, and they are very comfortable doing it. We just need to take time to explain it. And if there are concerns, they can always get in touch with us. Glucose targets are always mentioned, especially in gestational diabetes patients. Obviously, they require a lot less insulin. It's very easy to manage. But type 2 as well, once they get a hang of it, the patients are very comfortable adjusting insulin dose.
One observation which I would like to make is that our patients also titrate the doses, but they often down titrate rather than up titrate. Even when we give them the freedom to titrate, they would rather down titrate rather than up titrate. Even when the levels are high, they would be hesitant to up titrate, but they are very quick at down titrating the doses. That's my observation. I don't know. I would like to know from others what they see.
Yeah, whenever they complain of a symptom, sir, I think whenever they feel a hypo symptom without a actual hypoglycemic episode, they probably get concerned and start doing it. That is probably a practical thing that they're doing. But most of all, I think they do manage well. Glucose monitoring has taken up. Patients are monitoring. They may not record as diligently as they do it in the first few weeks, but they do maintain a good glucose record and try and achieve it. So,
for example, sorry, can you all hear me better now? Can you all hear me?
Yeah.
Okay. First of all, I do Daphne on WhatsApp with my type 1 diabetes patients. And that could be one good example. And also, Jaydev highlighted GDM patients. If the right amount of education is given, it can be done even with people who don't have much education as well. So it's all the confidence between the doctor and the patient. But again, there are patients, no matter what you do, they don't understand a thing. I think the safest thing to do is those patients to try to play on the safety of hypoglycemia rather than the strict control. I think it's all based on the patient, I believe.
Rakesh, in response to your statement, this is JJ, during pregnancy, they never down titrate, man. In pregnancy, they are so on the ball. They get the insulin so right. HbA1c is up to 5.6, 5.7 I've seen on rather high doses of insulin. So it's basically, I think, what is at the end of the race, you see, if it's a nice, prize, then people get more involved in it. And if it's something which you say 10, 15 years later, you will lose your eye, lose your limb, they generally don't see that. And then I think my experience is a little bit like you. I tell them fasting 80 to 130. The moment the fasting hits 100, they start reducing their nighttime dose. So it's difficult. I mean, we have all sorts of patients. You see, some who do, some who don't. But pregnancy, my experience, I don't know what you all will say. Uniformly, I mean, they do well.
So thank you, Dr. Shyam. I think we'll end the session. Unmute.
Thank you all speakers. It's been a good session on a common entity. Dr. Vrunda talked about thyroid cancer, and Dr. Jayashree and Dr. Jaydev elaborated on diabetes care with insulin perspective. I think we'll move on to the next session. Thank you again, Kalyan. You take over.
Okay. So without further delay, I'll just quickly move on to the next session. We are very privileged to have as the chair for the next session, which is endocrine emergencies, Dr. J.J. Mukherjee, who's a well-known senior consultant in the field of diabetes and endocrinology. He's an eminent speaker in a lot of conferences. He has finished his training at St. Bart's Hospital under the godfathers of endocrinology. He's been a senior consultant in Singapore for 10 years, and his chief interests are in pituitary and adrenal disorders and hypertension, along with neuroendocrine tumors. He has more than 55 publications in high-impact journals and more than 15 chapters in various textbooks. He's also an editor and associate editor in some very renowned journals. So thank you, Dr. Mukherjee, for joining us. Please chair the session, and please feel free to interrupt me. We'll be very valued with your experience in appreciating your inputs in this interesting topic, which will be the endocrine emergencies, which is more a clinical topic. So I will be your moderator for the session. I am Dr. Kalyan. I'm a consultant endocrinologist practicing at Idea Clinics. We'll start off with the first session, which will be Dr. Murali Ganguri. So Dr. Murali Ganguri is a consultant endocrinologist practicing at Vijayawada at Manipal Hospitals in Vijayawada. He's a CCT returned from the UK. He has multiple presentations in many national and international diabetes and endocrine conferences, and he has a few publications on his name. So over to you, Dr. Murali Ganguri. You can share your screen now.
Okay, thank you very much. Let me start. So can you see my screen, please?
Can you make it full screen now?
Yeah, can you see it? Yeah?
Yeah, it's all clear. Thank you.
Full screen, please.
It is full screen.
Yes, it is full screen. Please go on.
Yeah, go ahead, sir.
Okay. Thank you very much for inviting me to give this talk. My topic is pituitary apoplexy, one of the rare endocrine emergencies. So today I'm going to basically talk about a case which will form the basis for the discussion, and then what is pituitary apoplexy, and the conservative management versus surgical management, and a little bit about triple phase response in managing sodium, and then a few words about prognosis and summary. So this is more of a clinical topic, so less of evidence and papers. So it's more of a clinical topic. So this is one of those cases, a 40-year-old gentleman who was brought into hospital with sudden severe headache, and he vomited twice and had nausea, and he also complained of visual field disturbances, and there was no focal limb weakness or speech disturbances. So when somebody comes with this kind of history, I mean, obviously there are a few differences that you might be thinking about. So on initial assessment in ER, the temperature was noted to be 39, and he had decreased visual acuity and photophobia was noted. His Glasgow coma score was 15 out of 15, and BP was noted to be 100/60. He had right third nerve palsy. And then initial worry was to whether it is subarachnoid hemorrhage. Obviously, doing a CT scan immediately when there is a subarachnoid hemorrhage is suspected is the right thing to do, which they did. And obviously, they excluded subarachnoid hemorrhage, and they were planning to do a lumbar puncture after 12 hours to ensure that there was no xanthochromia. And meanwhile, they managed to get some more information that this gentleman had history of hypertension and diabetes, which was being treated for 1 year. Was also seeing a surgeon for altered bowel habits as well as weight loss. And he was also under an endocrinologist who diagnosed him with acromegaly, and he was waiting for an MRI scan. So based on this information, immediately the focus shifted from subarachnoid hemorrhage to pituitary apoplexy given the presentation. So an urgent MRI pituitary scan was arranged, and he had endocrine panel checked for anterior pituitary along with electrolytes, complete blood count, clotting profile, liver functions. And he was noted to have low cortisol, which was inappropriate for the stressful situation that he is in, and low ACTH, low growth hormone, low prolactin. PT4 was normal. His sodium was noted to be 125, other electrolytes being normal. CRP and complete blood count were completely normal, and prothrombin time was normal. He was noted to have bitemporal hemianopia, so this is an example. It's not the original MRI for my patient, but this is just taken up from internet. So just to give you an example. So you could see this patient had
Just a minute, Dr. Murli. I don't know why you're going on mute. Mintu, can you please check?
Can you hear me?
Yeah, I can hear you now. Okay. Please just present your full screen again, and then we'll.
Can you hear me? Okay. Sorry, there's some technical problem. I don't know what it is. So it basically shows that pituitary apoplexy. So he was later shifted to neurosurgical high dependency unit, and he was started on intravenous fluids, and he was given status of IV hydrocortisone followed by regular hydrocortisone. After 48 hours, he developed intense polyuria, almost passing 200 to 300 ml of urine per hour, and sodium quickly went up to 150. So he had a good thing. He got a very good GCS along with a very good thirst. So he was allowed to drink free water as per his thirst. Meanwhile, we checked urine osmolality, serum osmolality. Urine osmolality was noted to be inappropriately low. So we started him on desmorphine. Sodium normalized, the symptoms resolved, and DDAVP was slowly weaned off after 5 days. His Glasgow Coma scale stayed stable throughout his hospital stay. Third nerve palsy slowly started to improve, and his visual field defects also slowly started to improve. His hydrocortisone was changed to oral doses and was discharged home after 7 days. And he was readmitted with vomiting, unable to keep his hydrocortisone low, his sodium was noted to be 114. He was confused, disorientated, and however, there was no focal neurology. Serum osmolality was noted to be low, urine osmolality 600, high urine sodium, and SAADH was diagnosed for this gentleman. And because he was symptomatic, he was started on 3% saline, and he was later changed to tolvaptan once his symptoms became better, and he was discharged home. So the progress afterwards, he was after a few weeks, he had short synaptic tests which showed that he probably had permanent corticotrophic deficiency. However, his hypothalamic thyroid, hypothalamic gonadal axis were intact. Most importantly, his growth hormone levels and IGF-1 levels were normal, and his acromegaly was basically cured by apoplexy, which was a good thing out of this whole episode. And diabetes and hypertension improved. And unfortunately, despite all this, he was later diagnosed with colorectal cancer, and he passed away after 1.5 years, which was a sad thing. So what is apoplexy? I mean, obviously in this case could have gone completely different. His GCS could have been worse. He might have had much more severe neurological deficits, and where things could have gone in a completely different way. But that's what we're going to talk about. So apoplexy, what is apoplexy? The apoplexy is basically, it was first described in 1950. This is an abrupt infarction, and then maybe including hemorrhage or followed by hemorrhage, and sudden increase in the size of this pituitary mass, compressing on surrounding structures, causing the clinical syndrome of basically visual field defects or problem with visual acuity. If it is pressing on optic tract, again, there could be other things. And also, if there is any compression on the cavernous sinus or even carotid artery, there could be cerebral ischemia and vasospasm, and even patient can mimic strokes. There could be extravasation of blood into the subarachnoid space and cause meningism. So it's more common in non-functional tumors, and because of this reason, 3 out of the 4 patients who come into hospital with the suspected apoplexy don't even know that they had a pituitary tumor. So that is, and the course could be completely variable, and prognosis is completely variable depending upon when the patient presented, where the patient presented, how the patient managed. So what are the precipitating factors of pituitary apoplexy? So hypertension is one of the things that was proposed to be one of the precipitating factors. But coronary artery bypass surgery or prolonged orthopedic surgeries, which can result in labile BP during perioperative period, can cause infarction and followed by apoplexy. Anticoagulation therapy was implicated, and bleeding disorders. And one thing which is not uncommon to see are pregnant women, particularly when there is already natural history, the pituitary gland gets bigger during the pregnancy. But if they had a previous prolactinoma, for example, and if the particular macroprolactinoma, and if they stop taking cabergoline, it can get bigger and bigger and may bleed into the pituitary mass. So head trauma is another one. So management, CT scan can make, although it can pick up 80% of the pituitary masses, but it can only pick up 20% of the apoplexy. So MRI is the investigation of, radiological investigation of choice. But if the MRI is not available or MRI is contraindicated, dedicated CT pituitary scan can be done. And every patient needs good endocrine evaluation, baseline anterior pituitary hormones, and empirical steroid treatment can be initiated instead of waiting for the results to come back. And most importantly, sodium management and other electrolyte abnormalities need to be carefully looked at. And regular input and output are extremely useful because of the dynamic nature of this problem. People developing diabetes insipidus followed by SAIDH and then diabetes insipidus. So it is very, very important to monitor these input-output charts along with the daily weights, and electrolytes needs to be, even sometimes needs to be done more than once a day. And most importantly, regular, particularly if the patient is managed conservatively, Goldman or Humphreys perimetry and establishing the visual field defects would be very, very useful. And it will help in 2 ways, basically to see if the patient is getting better or if it is worsening. It will also help you decide if the patient needs neurosurgical decompression. So steroid needs to be continued until you are sure that the patient doesn't have any steroid deficiency. So conservative or surgical, obviously it needs to be a multidisciplinary team decision. The aim of the treatment is basically to make sure the patient's symptoms get better and relieve the compression from the surrounding neurological structures, and hopefully no regrowth of the tumor, and save as many future hormones as possible. But while this is very ideal to have everything, but this is all dependent on how bad the patient came in with to start with. Because on one hand, we have patients like the patient I just mentioned who come with little bit of apoplexy and very minimal neuro-ophthalmic symptoms and not much of a GCS problem. And on the other hand, you could have patients coming into hospital within hours becoming really, really unwell and hemodynamically unstable with adrenal insufficiency and severe hypotension, and also worsening GCS, and they may even die. So this is the and most of the patients can be between these 2 extremes, and sometimes they can come very stable and get worse, or they may come very, very bad and they may start to get better. So the most important thing is monitoring and making sure that all the things are done in a right way. So daily neuro-ophthalmic assessment, that is daily visual fields, and monitoring the GCS, monitoring electrolytes, and making sure the patient gets steroids. And on the other hand, if the patient goes to the surgery and there is a risk of CSF rhinorrhea and permanent diabetes insipidus as a consequence, And then there is a removal of normal pituitary, which may even make them permanently hypopituitary in the future. But this could also happen even in conservative approach if the pituitary is destroyed. So we have to balance both the things, and there are multiple studies comparing conservative approach as well as surgical approach, but these were not controlled studies. These are retrospective analysis, and obviously there will be a selection bias. So I don't think we can decide one way or the other and saying that this is the best way. The best way to manage in these patients is to basically discussion between pituitary surgeon as well as the endocrinologist, if need be a radiologist or ophthalmologist, because some of these things can be very difficult to assess if the patient GCS is very, very low or if the patient is confused. So we have to take these things into consideration, and it has to be a shared decision. Obviously, patient needs to be involved either way, the conservative or surgical approach. And a brief mention about triple phase sodium response, which you can see most commonly in post-operative pituitary patients, but it could also be present in patients who have pituitary apoplexy. I think around 5% or 10% patients this could be seen. As you could see that the patient may have initially requiring DDAVP. I mean, the patient needs hypotonic IV fluids or DDAVP, and then slowly that starts to get better, and then patient starts to develop SAIDH. This is very, very tricky situation, tricky scenario. The reason is some people prescribe vasopressin on a drug chart. So the nursing staff do not have any clue. They will just keep giving and giving. They don't have a clue what happens to these patients few days down the line. So when they develop SAIDH few days down the line, if the patient is already getting vasopressin on regular basis, this is only going to get worse. So this needs to be very, very, that's why what I would recommend is do not prescribe vasopressin as a regular drug on a drug chart. You give on a daily basis based on the regular sodium. And then once the SAIDH sets in, sometimes patients can develop permanent DI. So that needs to be monitored as well. So again, giving tolvaptan at that time will not be very helpful. So the close monitoring of this aspect is very, very important, because very high sodium and very low sodium can also cause serious problems. So prognosis is very, very variable, and it all depends upon whether these patients knew any previous hormonal deficiencies or what hormonal deficiencies they may develop after the apoplexy. And endocrine outcomes, again, it's quite variable. And most of the patients will have some kind of hormonal deficiency. Recurrence of tumor, again, I think, again, there are multiple studies looking at both surgical and conservative approach. I don't think there is any particular approach is better with the recurrence of tumor. So it's very, very variable. So it's one thing. So most importantly, you need high index of suspicion. Anybody coming with the hospital with sudden headache. Patients who have adenoma, if they're going for any surgery, particularly CABG, or for any orthopedic surgery, or if they're going to have a anticoagulation for a DVT or PE, they need to be warned. This is a small risk, but that they need to be aware. And also, if they have a patient, non-functional pituitary adenoma, who is not going for surgery, who is being monitored because there is no urgent need to intervene, we need to inform them there is almost 0.2 to 0.6% of pituitary apoplexy happening in these patients. So the thorough initial assessment is very, very important, and close monitoring, steroid replacement, sodium management. These are very, very crucial steps in saving these patients. And again, surgery versus conservatory, it needs to be an MDT decision. It need not be a single person deciding on which way the patient should be managed. And most importantly, this patient needs a long-term endocrine follow-up. So thanks for the opportunity. Any questions, I'm very happy to answer.
Thank you, Dr. Ganguri. I don't see any questions from the audience, so I'll probably just take the first question. I think from what we can see from the guidelines, the pituitary apoplexy guidelines, they are UK-based guidelines. They do suggest quite a conservative approach, but providing the real-time practice that we see, we cannot always rely on the Goldman perimetry charts to be available in all hospitals. There probably is no neuro-ophthalmology review for these patients regularly. So can I suggest that we probably have a very low threshold for any visual problems happening in this patient, to just go ahead, have a very low threshold for surgery, considering the Indian scenario? And I'll have your opinion on this, Dr. Murli, and also Dr. Mukherjee's opinion. Thank you.
Murali, you go ahead first. You presented the case.
Can you hear me?
Yeah,
I can hear you.
So yes, in Indian scenario, it's very, very difficult. I think most of the time this patient.
Can you hear me?
Yeah, please go on now. Yeah.
Okay. So in Indian scenario, the difficulty is the patients don't actually coming to us. Most of them are being sent to neurosurgeons, and even patients who are known to us, once they develop a bleed in the brain, either even small one, they directly refer to neurosurgeons. And some of the neurosurgeons do not have experience in managing pituitary tumors. Even by going by guidelines, these tumors should be managed by pituitary surgeons who have at least experience of doing five surgeries for a certain period of time every year. So even if they go for a neurosurgical intervention without having a good neurosurgeon, that's not going to help in the long run.
Dr. Mukherjee.
I will take my take, Kalyan. Basically, I echo what Murali says. Unfortunately, when a patient like this presents to the emergency in India with headache, a little bit of meningeal signs, nausea, vomiting, CT scan shows something, the patient is referred to a neurosurgeon. Now, I'm a very firm believer in conservative management. I mean, these are rare cases. Unless and until you're working in a very big center, you will not be seeing too many of them. In our individual practices, you in your IDEA clinic, I mean, even in Apollo Gleneagles, Kolkata, even in Vijayawada, where Murali is working, we don't get so many cases of apoplexy as opposed to what we used to get when we were all in UK, USA working in big centers. So these patients generally are first referred to a neurosurgeon, and I don't know what happens in the government hospitals. If somebody is here from the government hospital, they can share in the pitch in. But the private hospitals, once a referral goes to a neurosurgeon, it is the patient is in the lion's den. Getting him out of the lion's den is very, very difficult, you see. I've managed some of them. I've managed a few prolactinomas who came with apoplexy. I've managed to get them off my neurosurgical colleague. So by default, what you are suggesting, low threshold, it happens even without major visual field defect, even without major loss of sensorium. They are put under the knife, which I'm very against. I'm very much in favor of conservative therapy. I would rather wait for 24 to 48 hours. You don't lose much in 24 to 48 hours. Just see which way the sensorium is going. GCS3 becomes GCS6, 8. Visual fields, I mean, you can just do the visual acuity. You can carry a pocket Snell's chart. You can just do the visual acuity. If visual acuity is not too damaged, the fields will recover with time. So I'm very much in favor. You don't need Goldman's perimetry in the emergency room. You don't need that. Just make sure that he can see the Snell's chart. Then you can probably wait. But in real life scenario, we do lose out a fair few of them to our neurosurgical colleagues, and there's no randomized controlled trial data we know. But whatever little retrospective data we have, it's now showing that unless and until patient is really grossly blind or has bad sensorium, surgery doesn't have that much of a different outcome as opposed to conservative management. So I'm still in favor of conservative management. In India, becomes a little bit difficult if you can develop a rapport with your neurosurgeon in your hospital, and if you think that you can go to the lion's den and come out with the meat, then go ahead. Otherwise, they unfortunately get knifed. Back to you, Kalyan.
Yeah, true, sir. True. I agree. Any other questions on this or comments on this topic? Otherwise, we'll move on.
No, my comment is the management of the hyponatremia. I disagree. I think Murali also disagreed with it. I think it's not his patient. I mean, I am strongly against using 3% NaCl unless and until I am pushed to use it. Because once you see one osmotic demyelination, you have to just see one in your lifetime. You'll be very, very hesitant to use 3% NaCl. The only time when I'll be considering 3% NaCl is if my patient is absolutely in deep coma or is fitting, is having convulsions. Other than that, I'll be very careful because as you rightly showed, the triphasic response, the 3% NaCl tolvaptan was probably an overkill here.
True, and a lot of the times we see the neurosurgeons use both. I mean, before I get the referral, sometimes I don't get the referral as well. They are already on 3% and the 12-valproate already, so it's difficult for them. Okay.
Can I just request something?
Sure.
Anand and Karthik, I also are there. Apparently, Usha has to go somewhere, and she wants to go earlier than other speakers. Can, if it is okay with Anand and Karthik?
Yes. Yeah. Okay.
Before we leave, congratulations, Murli. I think you did a good job. Very nice presentation. Thank you.
Thank you so much. Okay.
It was an excellent presentation. Thank you.
Thank you.
So then we'll just skip to Dr. Usha's slide here. Dr. Usha Ayagari is a consultant endocrinologist. She's currently in Chennai. She's trained in diabetes and endocrinology at Oxford University in the UK, and we are privileged to have her here. Thank you, Dr. Usha. Over to you. You can start presenting now.
Thank you very much. And no, it's not that I have to go somewhere. It's just that at 12:45, I have a slightly different commitment, and I was due to speak now in any case. So I just sort of juggled, and the time schedule is a little tight. That's all it is. Not that I want to go before the other speakers or take away from their time. Right.
No problem. Please carry on.
I've been asked to speak about the management of pheochromocytoma. It's a fairly broad mandate, but I know that we are in this sort of acute endocrinology setting. Just for our more junior colleagues and for people like me who've forgotten these pathways, we go down the dopamine, norepinephrine, epinephrine pathways, and these are the main secretory hormones that give us the symptoms of pheochromocytoma. These are derived from chromaffin cells, and 30% approximately occur as part of hereditary syndromes, classically within VHL, MEN2, and NF1. There are about 10 now, increasing to up to 18 identified mutations, but there are quite a lot of families in whom we have yet to identify the mutations. We know that there are extra-abdominal and extra-adrenal tumors, which are paragangliomas. And we know that these extra-adrenal paragangliomas have a higher potential for malignancy. As endocrinologists, we say this 100,000 times, but I think it's a message we have to cascade out very vociferously. Imaging studies only after biochemical confirmation. Otherwise, we end up chasing our tails on an incidentaloma of some sort or other and of dubious significance. Now, as I said, dopamine, norepinephrine, epinephrine. So what are we measuring? We're measuring 3-methoxytyramine as a metabolite of dopamine, normetanephrine, and metanephrine. And the reason we are doing these rather than BMA is because their sensitivities, their positive predictive value in a patient in whom you have an index of suspicion, what you want is a more sensitive test. You're not screening, so the specificity doesn't matter so much because you don't really want a high negative predictive value. You already have a clinical suspicion. So plasma-free metanephrines have the highest sensitivity, but please remember that POs can be episodic, and therefore the plasma-free metanephrines, which have a shorter half-life, may not be giving you the correct answer. Urinary fractionated and total metanephrines do last longer, and certainly the fractionated approach the sensitivity of plasma-free metanephrines. The rest really we shouldn't be doing, and I'll stop at that. If you look at other things, there are a lot of drugs, including antidepressants, that can interfere. But more than drugs, what we should be worrying about is things that our patients take in their daily diet, especially in South India: coffee, tea, bananas, the green bananas, plantains, chocolate, cocoa, citrus, fruits. A lot of things can interfere, and all the walnuts and things. So it can have a 2 to 3-fold effect on certain. So for example, dopamine can be affected, giving rise to the 3-methoxytyramines, but not so much on the normetanephrines. So you need to pick the test and pick the combination of foods. I just give my patients blanket instructions: avoid this list for 48 to 72 hours before you do your 24-hour urine collection. Much easier rather than trying to figure out what I want to measure and what I need to tell them to avoid. Imaging, as I said, only after biochemical confirmation. CT abdomen, if the tumor is a centimeter or larger, has a very good accuracy for picking it up. MRI, in those people for whom you wish to avoid radiation exposure, And we know that certainly for intraadrenal pheochromocytomas, there is that light bulb sign on T2, which is diagnostic of pheos in MRI. Functional imaging and scintigraphy really much rarer and for hard to identify and not yet localized, but biochemically confirmed tumors. So if you have biochemical confirmation and you're now hunting, then you go on these scans. PET scanning mainly in those places where you suspect extraadrenal or metastatic spread. So remember, in syndromic presentations, you would want to look at other additional studies, including PTH, red proto-oncogene screening, and other angiomas, including retinal angiomas for VHL. So Murali asked me to base this around cases that I've seen. First case, female 51, looking at pre-existing type 2 diabetes, was diagnosed with hypertension 5 years ago and is presenting to the doctors about every year or so for her annual full yearly checkup for diabetes and hypertension, has always been documented as being suboptimally controlled, various juggles, dose adjustments, and hasn't really progressed much. So more recently, she's been complaining of dizziness, headache, nausea, sweating, feeling unwell, feeling feverish, feeling anxious. And given the age, she's been put down to having anxiety disorder, menopausal symptoms, been recommended HRT, did the rounds for her abdominal pain and nausea, had an upper GI endoscopy. Finally, she presented to ED one day with palpitations where she was picked up by a cardiologist. Now, the point I want to make here is, we know this triad, the headache, sweating, palpitations, typical, but a lot of pheos don't present with these. The other symptoms, including tremor, nausea, weakness, vague abdominal symptoms, anxiety, paroxysmal hypertension, it's not even consistent, or weight loss, fever, pallor, these are the more non-specific symptoms, and it is only by having a high index of suspicion you would be able to pick up that one symptom that gives you an idea. In her, it might have been that poorly controlled hypertension whenever she comes, despite dose escalations and drug juggling. So she then ended up with the cardiologist, as I said, and was referred to me. She had a textbook biochemistry, and we found her pheo on adrenal imaging. So no problems thus far. After about 5 years down the line of hypertension, we found her pheo. Now, she had a textbook preparation. We alpha blocked for 10 to 14 days, and then we took her to surgery. Now, in terms of alpha blockade, phenoxybenzamine is the oldest and the drug with the most experience, and certainly JJ will agree with me. Those of us who trained under Ashley Grossman and John Voss, under their tutelage, this is our standard. We start with 10 mg every 6 to 12 hours. So TDS 10 mg, and then increase up to 30 to 40 milligrams, up to a maximum dose of 240 milligrams per day. It is irreversible. It blocks both alpha 1 and alpha 2 receptors, but it does have implications for post-operative management because the receptors have to regenerate, and that takes 48 hours. And therefore, you might see a higher incidence of post-operative hypotension with phenoxybenzamine use. Prazosin and doxazosin are absolutely acceptable. Doxazosin, being longer acting, is amenable to once or twice daily dosage, and the advantage is that this post-operative drug refractory hypotension, which you see with phenoxybenzamine, is much less significant with doxazosin. Recommended regimen, this is from the Endocrine Society guidelines. So you start phenoxybenzamine or doxazosin 10 to 14 days before surgery, add in a calcium channel blocker as necessary in addition to PrEP1, the blocker after 3 to 4 days of preparation. This then takes them through to surgery. You can then use, as I said, CCB as an additional drug. You're aiming for a target sitting blood pressure 130/80 or less, and not more than a 10 millimeter systolic standing increase. Ensure adequate salt and water intake to minimize post-operative hypoglycemia, but also, hypotension, but also to optimize your preparation pre-operatively. So you then can switch to IV phenoxybenzamine to the point where the patient has postural hypotension, is what Professor John was always taught us. He wanted the patient to get to the point of postural hypotension. Continued alpha blockade will give you persistent vasodilatation and the risk of hypotension. So you weigh fluid load perioperatively. You may need a vasopressor infusion. As I said, you can have these complications with phenoxybenzamine for up to 48 hours post-operatively. So looking at hypertension, hypoglycemia, all of these post-operatively is very important. But also remember, where you're doing total adrenalectomies for pheochromocytomas, post-operative hypotension may represent considerable adrenal insufficiency. So please keep that in mind. Now, this is a case that goes really well. Perfect preparation gets through surgery. What are the other scenarios? This is a gentleman I saw recently after my return to India. 58-year-old, hypertension on ARB and CCB, came in because of obesity for a knee replacement under spinal anesthesia, had a routine preoperative, and the anesthetist made a note that there would appear to be some tendency to LVH on the ECG, and the echo confirmed LVH. Gets put on the table, gets his spinal anesthesia and muscle relaxants, and the BP shoots up to 190, 110. With sinus tachycardia and ST segment depression on the ECG monitor tracing. With this, the operation gets cancelled and he's intubated and shifted to CCU. They give him calcium channel blockers. This goes into hypotension. The anesthetist fortunately switched on and thought, hang on, could we be dealing with a pheo? And I got a call. So before we put up anything else, we sent his plasma metanephrines. And remember, they have a very high sensitivity in this kind of a scenario where you're in the middle of this kind of a crisis. So we sent his plasma metanephrines and we started IV fluid loading, because in an acute situation, that's the best you can do, get their fluid load up. The second patient is a 49-year-old male, came into ED with headache, nausea, vomiting, and confusion, with again hypertension and tachycardia. He was started as per our protocol on an oral CCB, wasn't controlled, started on IV GTN, shifted to CCU, labeled as a hypertensive emergency. Suddenly his blood pressure dropped and he started, they started aggressive IV fluid resuscitation, went into LVF and pulmonary edema. So the entire team, cardiology, ITU, everybody was around his bed. And eventually they found that he had a history of borderline hypertension, told 3 to 4 years ago at an employment health check. He checked it on and off a few times since. It's always been variable. So every time he goes, yeah, now it's normal. Last time it was high. Why don't we wait till next time? Now it's a bit high, but look, you've had 2 normal readings in the last 6 months. So why don't we just recheck it and see? And this kept going on, stopped and started antihypertensive therapy various times in the past. And remember what I told you in the signs and symptoms, 50% of hypertension can be episodic. So this guy ended up with a pheo crisis, unrecognized because of his stop-start kind of presentation to various doctors. You know, they go doctor shopping, once at an employment health check, once at an office clinic, once at a physician's, and he ended up with us in ITU. Pheochromocytoma crisis is a potentially fatal presentation. About 40 years ago, this was labeled as pheochromocytoma multi-system crisis, having 4 components: severe hemodynamic instability with hyper or hypotension, which can be very labile, leading to circulatory collapse, hyperthermia, encephalopathy, and multi-organ failure. About 5 years ago, this was updated to say, look, apart from asymptomatic and symptomatic pheos, in crisis, not everybody presents with all 4. They can have a limited crisis limited to hemodynamic instability with some renal impairment or some cardiac impairment, one end organ. Or you can have circulatory collapse and shock with multi-organ dysfunction. So they've now divided it according to severity. And then how do we prepare it? Why does this happen? We know pheos handled, unhandled for any number of reasons release catecholamines. This stimulates your alpha-adrenergic receptors, leading to profound arterial vasoconstriction, leading to hypertension and a relative reduction of intravascular volume. This is why you need to fill them. This is why you need fluid resuscitation. This leads to end-organ perfusion being reduced, tissue ischemia, and end-organ failure. The alpha-adrenergic receptors, we block them, leads to vasodilatation. Now, if you haven't fluid resuscitated them, the combination of intravascular underfilling and vasodilatation leads to hypotension, potentially circulatory shock. But this hypotension, even when well managed, can give rise to reflex tachycardia, which is why you need your beta blocker on board at this stage. So fluid resuscitation, alpha blockade, beta blockade. The pathophysiological basis for this is this. So treatment goes in this direction. What can be involved? Your brain with ischemic or hemorrhagic strokes, encephalopathy, seizures, and dissections. Your heart and lungs with MI, arrhythmia, myocarditis, PEs, ARDS, hemoptysis, the gamut of presentations. Bowel ischemia, paralytic ILS as part of the crisis. You can also have peripheral involvement with vascular spasm, thrombosis, and embolism. You can have rhabdomyolysis because of underperfusion of your muscles. Metabolically, they can have DKA, hyperglycemia, or lactic acidosis. They can also present multisystem failure, as I said, with renal and hepatic impairment. Spontaneous can occur, but usually something precipitates these. Our man who presented, the second guy to ED, was a spontaneous. Now, drugs, and in the first case, it was muscle relaxants and anesthetic agents, but a lot of drugs, the list is out there in the guidelines. Management is primarily supportive intravenous fluids, followed by alpha blockade, followed by beta blockade. Additional to alpha blockade, nicardipine, beta calcium channel blockers give you good antihypertensive management. IV magnesium sulfate works as a functional calcium channel blocker, but also as a vasodilator, so counteracting the vasoconstrictions from the alpha blockade. Mechanical support in those with circulatory collapse, and there is some discussion about the timing of surgery. Previously, it was thought that these crisis patients needed to go straight to surgery, but now we know that they actually do better when they're optimized and taken to surgery 10 to 14 days later, unless they don't stabilize. If they stabilize with medical management, postpone surgery till they're well stable. Case 3, I want to tell you how not to manage paragangliomas. All over the country from 2014 to 2019, with 3 different neurosurgeons presented with a right neck mass, dissected, taken out. Histopathology says paraganglionoma. Surgeon is happy, I got it, case closed. Presents with a recurrence to, so Delhi, then Bombay with, they wanted a better center, better doctor with a recurrence. A year later, it was embolized because it was highly vascular, same site recurrence. Came to 2019 to Chennai, where now doctor shopping, both sides masses. And then when you look at the old images, there is actually a left-sided skull-based mass on the 2014 presentation. Why was I involved? Because on the PET scan, they found an incidental thyroid nodule. None of the neurologists, neurosurgeons involved an endocrinologist until they found the incidental thyroid nodule, at which point of case I was invited to play with the big boys. Luckily, above neck are parasympathetic and generally non-secretory. Below the neck paragangliomas, on the other hand, are secretory and tend to secrete the gamut of adrenaline, noradrenaline, and dopamine. And these are the ones that can precipitate a crisis if you go in and handle them. My patient was extremely lucky. But where he was unlucky is that there is a huge risk of malignancy. And there are no histological markers for malignancy. This guy had histopathology. Malignancy is defined by metastasis, and now he's in the stage of metastasis. There is no clearing the entire burden, tumor mass from this guy's neck now. How do we do this? This is again an endocrine society algorithm. If they have a syndromic presentation, target genetic testing. If they metastasize below neck, sympathetic ones are generally going to be SDHP. Above neck, parasympathetic ones, the rest of the succinyl dehydrogenase gene. If you have non-metastatic, again, dopaminergic, noradrenergic, adrenergic, depending on that, there is a flow chart. And you can look at this. I never try to remember this. As in when I see a patient, I open the guidelines and then have a look at it. We see them so rarely that I'm not going to try to memorize the entire algorithm. So paragangliomas, please remember that as a group, they are the most strongly inherited. They're associated with the clinical syndromes. And as I said, SDHB for sympathetic and all of them for parasympathetic paragangliomas. Take homes, please. If you prepare them adequately, the mortality is less than that of a cholecystectomy. It is less than 1%. Remember, you have to prep both asymptomatic and normotensive patients, not just the hypertensive patients. For crisis, there are no evidence-based, but there are consensus guidelines. And experience and management, the more you do of these, the more confident you get, and they're best managed in a center with multidisciplinary care where you actually liaise ahead of time with your cardiologist and your anesthetist. Take home 2 IV fluid loading in a critical setting, but OP setting alpha followed by CCB if necessary, followed by beta blockers. In crisis, involve your ITU team. And the role of emergency surgery is only if they don't stabilize. If they stabilize, it's much more widely accepted that the risk is less to get them back. And ideally attempt surgery after medical stabilization has been achieved. And like in my last patient, please don't miss the syndromic presentations. This makes the difference between complete cure and failure to the patient. Many thanks for your attention.
Thank you very much, Dr. Usha. That was an excellent presentation. I think we had a very good summary of pheochromocytoma for all of us who very rarely see these things. So any questions? Or I'll start off with the first question if anybody else has. So in clinical practice, how freely are these urine fractionated metanephrines available? Because near me, I couldn't find many centers. What about you and Dr. Mukherjee also?
So I always say this, I'm an outlier for any Indian-based practice. I have the luxury of practicing in a metro, in a corporate hospital that provides me everything. I ask for it, it's available, including plasma metanephrines. They will spin and freeze it for me from main to freezer in 15 minutes. But having said that, Lister Metropolis, one of the nationwide chains, does provide access to all of these, as do a few. I don't hold shares in Lister, as do some of the other chains, right? So it is available. Some of the cities collect, spin freeze and transport. So some of the tier 2, tier 3 places may not analyze on site, but they will spin freeze and transport to Mumbai or Hyderabad. Certainly available. You just need to find who is willing to spin freeze and transport in your area. JJ will recognize a lot of what I said because it comes from the playbook that we've both been trained by.
I think the phenoxybenzamine is out. The number of years that I'm back in India, I'm not using phenoxybenzamine anymore. I have downgraded myself to doxazocin and prazosin. Having said that, I'm not seeing hundreds and thousands of feos anymore as opposed to seeing them in Barts or Oxford. Mm-hmm. I do get them sporadically now, but I do get them. And with regards to managing, Dr. Kalyan, you have to first get your lab sorted out, because you cannot do endocrinology without a lab which is going to do the hormones for you. So between the plasma mets and urine mets, I rely more on urinary fractional metanephrines because they're much more stable. Much more easy to transport here, there, everywhere. And the plasma metanephrines are not easily available. Usha is lucky; she is in a metropolis, and Usha is Usha. You know, whatever she asks, people run around satisfying the lady. So we are not so lucky. So for us, we have to work hard. So I rely more on the urinary fractionated metanephrines. Another comment about pheo crisis. I haven't seen many, but the ones that I've seen have been uniformly fatal. We had a couple in Barts. No matter whatever you do, and I had a couple in Singapore. I don't know. Nothing works in them. Once they go into this hypotensive area and you start ventilating them and start filling them fluid, etc., it doesn't work. So a pheo crisis is a really bad thing. So it's our duty that if you have diagnosed pheo, the case in Barts was a familial pheo. The brother had it. The sister was being followed up annually, and in between that one and the annual follow-up period, developed the crisis and died. The one in Singapore we had, the patient was detected to have an adrenal mass, suspected to be a pheo, was planned for admission a week later into the ward by my colleague. Unfortunately, in the weekend came to the emergency, and this is where good training is required. You see, the patient was given IV phentolamine in the emergency because blood pressure was very high, and once that went in, it was absolutely a downward spiral from then on. So pheos are very exciting tumors, and I think pheos should be managed by people who are specialized. I don't know how many of the people who are listening to us are hearing. They should hear that if you find somebody with an adrenal mass, please refer to an endo, and not to a surgeon. Same thing we said for the pituitary session with Murli. Same thing I'm saying for the adrenal session. Unfortunately, in India, there is this thing that if there's a mass in the adrenal, it has to go to the surgeon. Should not. Let the endocrinologist work it up first for you, and then of course we will put it on a plate for the surgeon. So please allow us to put it on the plate. But otherwise,
and patient outcomes, mortality outcomes, and perioperative outcomes depend on that preoperative workup. An adequately prepared patient saves the surgeon's reputation and the surgeon's life as well. You're saving your colleague's reputation life as well. So let us prepare them and put them on a plate, as JJ said, for the patient. The other thing I'd like to say, Dr. Kalyan, even plasma mets need to be spun and frozen, door to freezer time. So they need to be spun within 15 minutes, into the freezer within another 10 to 15 minutes. But urine can be stored at, they say room temperature, they're talking room temperature of the Western Hemisphere. For us, in a cool AC room or in the bottom fridge door shelf. So ideally 24 to 28 degrees. So please remember that even if you're transporting urine metanephrines, they can't be left in the hot car sitting all day till they get to the lab. Transport is very important if you want to have adequate processing. And I always say, please, for the endocrinologists in the audience, the first thing I do whenever I go to any place, and this I was taught by my boss, go make friends with your biochemist. The first person, I don't go meet hospital management. I go say hello to the biochemist, go look at the platforms that they have, go have a chat with the assays in the lab, and they're my best friends in the hospital. I talk to them every week and I give them sweets every Diwali just so that they're nice to me.
Okay, now we know some of the secrets why she gets things done.
What about IV phentolamine? I had difficulty getting this. I mean, I never needed it, but it was difficult for me to procure this. Have you ever used it? I mean, it was never required, Dr. Mukherjee.
I mean, one line answer: never, never, never use it. If you need in a crisis situation, IV nitroprusside is the best. If you ever come to that situation where a patient's got a real crisis with 300, 140, 300, 160 BP, we have seen those. Sodium nitroprusside works the best there. IV phentolamine, I told you this one case we saw. The emergency consultant gave IV phentolamine in the emergency, and it was a disaster. It's there.
The other reason is if you use nitrates, they have a short duration of action. Even if they cause vasodilatation, it gives you time to fluid load these patients. You give them something long acting, and you have to. The vasodilatation is what causes the hemodynamic collapse. So you want something that gets the blood pressure down, but is manageable enough for you to fluid load the patient and keep the fluid going. Ideally, if you recognize it, fluid load, then start the IV agent. But at the very least, you want something that will allow you to control the vascular collapse.
Shutdown.
The one thing that I miss in India is the genetic part. You see, now PO and PPGL syndrome has completely become personalized now, precision medicine now. If you hear Carol Pachak speak now, what he used to speak 10 years ago and what he speaks now, his talk is now completely become personalized. So the moment they come in, blood goes for genetic analysis. As Usha was mentioning, there are 18 different gene defects now. And gone are the days when we used to say paraganglioma, bilateral and pheochromocytoma. We used to say 10% had, we had a 10% rule, only 10% have. Now it's changed. Now probably as much as Usha showed, as much as quarter will have some kind of a genetic defect, if not more. So it's become much more precision medicine. Now that is something which I miss in Calcutta. Whatever little I see, I don't have the access to all the genetic analysis. I don't know whether Usha, with all your charm, do you get all the analysis?
Only by sending them away to Delhi.
Delhi, where?
Only by sending them to either Bombay or Delhi, but most, yes.
Okay.
Okay.
Great.
Thank you. Thank you, Dr. Usha, for that lovely talk, and we had a great discussion. We will.
Thank you very much.
Thank you. We'll end that talk, and then we'll quickly move to the next talk, which is by Dr. Anand. Dr. Anand Kumar is a consultant endocrinologist at Ashwin Specialty Hospital in Madurai. He's an MRCP in endocrinology diabetes from UK. He's also has MPhil and FRCP to his name. So over to you, Dr. Anand. I'm going to stop my screen share and you can start yours.
Thank you very much for the kind invite. Before I just start, I just hope that you can hear me clearly.
Yes. You can see you, hear you, you can see your slides. Good.
Perfect. Thank you very much. Thanks again for having me here. It's a fantastic session. I think we're probably running a little bit late, so I'll just try to kind of, highlight the most important factors of this fascinating topic, which we often see compared to the other endocrine emergencies. These two are pretty important. So diabetic ketoacidosis and hyperosmolar non-ketotic states. So I'll kickstart with a case. This is a 38-year-old male who presents to the emergency department with a 2-day history of confusion, disorientation, altered sensorium. He is someone with type 1 diabetes, is on insulin, with poor adherence, and he's been unwell and fatigued for the past 4 days. These were his lab markers, plasma glucose being very high at 580, pH of 7.1, and a bicarb of 9.4. And this typically is DKA, that's diabetes. You've got high sugars, ketosis, you've got presence of ketones, and you have acidosis, all manifest over here. So acute metabolic complications, these are the two things we're going to talk about specifically, but we should remember that hyperglycemia is a very, very important thing to consider also, independently and also with these two disorders. The definition of diabetic ketoacidosis would include someone with ketonemia, with specifically serum ketones or significant ketonuria, with a blood glucose elevation at greater than 200, with bicarbonate of less than 15 and or a pH of less than 7.3. But remember, euglycemic diabetic ketoacidosis exists. And it's important to understand that identification of ketosis is based on ketones, including 3 particular ketones, importantly 3 beta-hydroxybutyrate, the 3-BOB, which is the predominant ketone, but you also would look at acetone and acetoacetate. And your typical urine nitroprusside test, so your urine test would actually not look at the 3 beta-hydroxybutyrate. So in a severe DKA, you may be sometimes fooled depending on the method you're using, and you may basically have an elevated beta-hydroxybutyrate alone, which basically swamps the acetoacetate and acetone, and you may have a false negative. So the ketone meters, the portable ketone meters, are important bedside tools, which now are very, very ideal, and it's an important advancement, not just in recognition, but in importance of management and also sequential management of diabetes per se. So DKA, as I mentioned, is the triad of hyperglycemia, metabolic acidosis, and increased ketone, and HHS or HONC is in relation to high sugars and high osmolality with dehydration without ketoacidosis. So DKA is more common in type 1, whereas HHS is more common in type 2. And in terms of the metabolic alterations and in terms of the symptomatology, it's pretty short in DKA, whereas HHS can take several days or weeks to actually happen. The other important difference is in relation to the incidence and prevalence. DKA actually occurs as far as 4.6 to 8 episodes per 1,000 patients with diabetes. The mortality rate is less than 5%. With HONC, it's much more rarer, but the mortality is as high as 15%. What precipitates DKA? It's important to note that you may not show any precipitating factors at all. But in terms of common causes by frequency, the most common frequency is in relation to infection, particularly in relation to an pneumonitis or a urinary tract infection or sepsis. This results in relation to absolute or relative insulin deficiency, and this can present as formifruste when you have new onset diabetes. With important to note that you have to always consider cardiovascular disease, particularly ischemic heart disease and myocardial infarction. There are loads of other common causes as far as HHS is concerned. We need to understand that drugs, specifically in the COVID era, with corticosteroids, it basically can precipitate a DKA, and impairment in terms of renal impairment, and also certain endocrine causes can also cause it. Signs and symptoms, I mean, I'm not going to run through this. This you'll find in any classical textbook, but it's important to understand that the signs and symptoms are very acute or very short in terms of DKA, and it takes weeks to develop in terms of HHS. A short note on pathogenesis, it's in relation to the absolute insulin deficiency or the relative insulin deficiency. In DKA, you have an absolute insulin deficiency, so you have increased lipolysis. Along with that, you have increased counter-regulatory hormones. So you have increased free fatty acids and increased ketones, and the increased glucose is in relation to the insulin deficiency, along with the increased gluconeogenesis substrates, increasing the blood glucose. Whereas with a HONC, you have a relative insulin deficiency, so you have sparing of basically increased lipolysis, so you basically don't have an elevated ketones, but you have very high sugars with hyperosmolar state accompanying with it. Now coming back to our patient, so apart from the DKA, there are certain things which we need to note in this particular individual. So I've highlighted them in terms of potassium. We have a potassium of 3.1. Now this is a very important thing to recognize. And also the anion gap, which is at 17, which is high. So remember, DKA is a high anion gap acidosis, and importance of identifying the potassium at the outset is very important. And by doing a formal serum electrolytes is very important. it is noted that the stores of body potassium are severely depleted in DKA. So you need to note this in terms of correction prior to, approaching with other approaches, which we normally do. The serum osmolality and anion gaps have to be calculated. You have now in the digital era, you have loads of applications which you could use, or you could just use your routine formulae, with serum osmolality being calculated with sodium and potassium multiplying by 2 and adding the urea and the glucose accordingly. So remember, if you have serum osmo at around 300 plus, close to 320, it is a pretty high serum osmo. And if the anion gap is high, remember that basically this is typical of a DKA. Now, free water deficit, you could do a rule of thumb, or basically you could actually calculate it again. You again have lots of applications to do it. But again, stressing the salient differentiating points between DKA and HHS. Now, it's important to understand that DKA is more common in type 1, as I mentioned, and HHS is more common in type 2. The alteration of sensorium is actually common in both. So it's not particularly that one precedes the other. And the other important aspect is the amount of insulin basically is much more in terms of correction for a DKA. But in a HHNKC, although you have basically a very high glucose, the insulin correction probably is going to be a little bit lower. Classification of DKA, you have the mild, moderate, severe, based particularly on the pH and bicarbonate, with less than 7.3 and between 7.3 and 7.25 is mild, and less than 7 being very severe. So coming to the crux of the issue. So it is important to understand that when you're doing a DKA correction, you're not correcting the diabetes per se. That's a very, very important thing to understand. You need to correct the fluid balance and restore the intravascular volume. The body deficits of water and electrolytes are the primary thing which we need to correct. So always remember, there are two systems which the body has in terms of adaptation. One is blowing it out through the respiratory tree, and the other one is through the kidney. So you have these two systems which will assist you in correction. So it is very important that you actually have a good urinary output for successful outcomes in terms of DKA or HHNKC treatment. So the dehydrations with DKA can be as high as 6 liters, and with HHNKC it could be close to 9 to 10 liters. And this needs to be taken into the equation when you're actually restoring these volume deficits. Remember, you're correcting the intravascular, also correcting the interstitial, and also the intracellular volumes. So you need to correct these particularly carefully. So another important thing which a lot of times I see particularly in certain ICUs is DKA management is actually being corrected with sodium bicarbonate to reduce acidosis. Now, that is not correct, because basically by doing so, you could actually be counterproductive. The most important aspect, as I stressed, is in relation to aggressive fluid replacement, and that is particularly holds precedence in relation to correcting the acidosis rapidly with sodium bicarbonate. So the goal of therapy in terms of correction of acidosis is by intravascular volume expansion, and that basically would restore lots of things in terms of correction. So this is a medical emergency, and the diagnosis and treatment should commence simultaneously. So again, in terms of what we should do, isotonic saline of 0.9% sodium chloride is preferred, and is primarily infused at a rate of either 1 to 1.5 liters during the first hour, or you could go with a weight based of 15 to 20 ml per kilogram body weight per hour. And once the serum sodium deficit is corrected, you could go on to a hypertonic saline with half normal saline at 250 to 500 mils per hour. It's always important that you assess the patient in terms of cardiac, renal, and mental status, and because that basically is very vital to prevent iatrogenic fluid overload. And fluid replacement should ideally correct the deficits within the first 24 to 36 hours. And remember that you basically have to convert your fluids from saline to 5% dextrose once your plasma glucose has reached 250 milligrams per deciliter in relation to someone with a DKA, and once it's 300 in HHNKC, this should be replaced with a hypertonic solution. So the typical fluid replacement regimen, so you use close to 1 liter over the first hour, and then another liter over the next 2 hours, another liter over the next 2 hours, and sequentially you're going to replace around 4 to 6 liters over the next 24 hours. It is always important that you reassess the cardiovascular status at 12 hours, and the further fluid management has to be reviewed from time to time based on serum electrolytes, which is preferably monitored every couple of hours. So as far as potassium replacement, we'll come to it shortly, but remember the first fluid you're going to put in, you need to make sure that you have a good urine output. So, you need to be cautious. You need to know what the potassium is before replacing potassium. So never, ever put in a potassium as a routine protocol in the first fluid. The first fluid is always, you use isotonic saline. You can infuse it, but don't give it with potassium. Make sure that basically you know the potassium before dealing with it. Another word of caution in terms of children, the overall volume deficit in children is typically between 5 to 10%, and fluid repletion should be done very carefully. Now, from my particular view, I always involve an intensive pediatric neonatologist or a pediatrician when I'm doing correction with children, just to make sure that we have someone supervising us that we're doing the right thing. And remember, the infusion of 10 ml per kilogram over 1 hour is the preferred one. The second bolus, you do not always give it for children, because that could actually result in a rapid fluid correction with increased cerebral edema. So the second dose, be very, very careful. I think generally the 10 ml per kilogram over 1 hour of isotonic saline or Ringer's lactate for children is much more suffice. So as far as maintenance for children, it depends on weight again. Remember, for someone who is basically obese with 20 to 80 kilograms, they would require only up to a maximum of close to 2.5 liters per day. Whereas someone with a weight of less than 10 kilograms, you're going to use 100 ml per kilogram for 24 hours. So with insulin therapy, so remember, insulin therapy doesn't have precedence. A lot of times, people jump in with insulin. Now, that's not the primary aim of therapy. Insulin is important, but the fluid balance and the restoration of the vascular volume is going to take precedence as always. The most important effects of insulin are in relation to ketone suppression, blood glucose reduction, and the correction of electrolyte disturbance accordingly, with the correction of glucose. The bolus in dose, I generally don't use. We basically would go with an infusion every hour with monitoring of blood glucose every hour. The preferable regime would be 0.1 units per kilogram per hour. And you would aim for the reduction of blood glucose of between 50 to 75 milligrams per deciliter per hour. It must not be too rapid, nor must it be too slow either. But with an HHN-KC, remember that a slow correction is much, much better. And you do not need to kind of be, doing a racing car approach in terms of correction of the glucose. It is okay for the glucose to come down slowly. Remember, again, good urine output, good electrolytes, good intravascular volume expansion, good electrolyte control is the most important aspect. The insulin infusion rate can be decreased once you reach close to 200 or 300 in DKA and HHS correspondingly. And you could go down to 0.02 to 0.05 units per kilogram per hour. And as mentioned, the IV fluid maintenance converts to dextrose saline with 200 in DKA and 300 close to in HHS. So this is a typical insulin dosing protocol. Now, in most ICUs in the West, especially in the UK, we would administer the routine basal subcut insulin. This is a very, very vital thing to do, just to continue and just to make sure that you don't get a rebound hyperglycemia as you're transitioning into subcutaneous insulin later on. And this is a vital thing, which is very, very importantly forgotten most of the times. So you could use a dynamic insulin protocol as per your center. I mean, various centers use different insulin protocols, but it is important to understand that this is not the first thing to do when you're treating the DKA. The most important aspects are, as I mentioned initially, is in relation to the electrolyte balance. The potassium replacement, the potassium should not ever be administered before urine output occurs. And this is very, very vital. Remember, I said that the kidney basically is your very good friend, and that basically is going to help you in terms of excretion of, unnecessary, imbalances in the DKA. Potassium replacement is initiated once potassium serum levels are at the upper limit of normal, close to 5. You generally would use infusions of 20 to 30 milliequivalents of potassium along with each liter of infusion fluids, with maintenance of potassium in the normal range and also depending on pH. If you have someone with significant hypokalemia, potassium less than 3.3, remember, insulin treatment has to be delayed, and you would need to replace potassium immediately with fluid therapy first before you're ever even going to contemplate about insulin. And this is very vital, and this would prevent arrhythmias and actually would also prevent respiratory muscle weakness and also respiratory arrest. So in summary, potassium is important to be checked. If it's less than 3.3, hold the insulin, administer potassium at 40 milliequivalents per hour, and then check it frequently before actually initiating insulin. If it's greater than 5, do not administer potassium, but check potassium for every 1 to 2 hours. If it's between 3.3 to 5, you administer 20 to 30 milliequivalents in each liter of IV normal saline. Now, bicarbonate therapy. So bicarbonate therapy, I would think, it should not be used routinely. Now, most of the intensive care units are tempted to use bicarbonate before, physicians, endocrinologists, diabetologists are called in. Someone in the ICU has already given them bicarbonate. And that basically can lead to increased risks of hyperkalemia. It could result in cerebral edema and actually could cause paradoxical central nervous system acidosis. All these could worsen outcomes. And severe acidosis, as you know, can impair myocardial contractility, cause cerebral vasodilatation, and cause complications with neurological impairment, and also can predispose people towards myocardial infarctions. If ever you're going to use sodium bicarbonate, as I mentioned, this is not something that should be routinely done. Even with very severe acidosis, with your fluid correction, it would correct. If it is pH of less than 6.9, that is the particular time I would actually consider it. With my ICU colleagues, we would actually administer sodium bicarbonate cautiously in this situation. So at that time, you use 2 ampoules of sodium bicarbonate. Remember, each contains something close to 44, and then you administer that over 2 hours, monitor the pH, and then take it further. So again, there's no need to aggressively correct this, because if you correct your fluid balance, this would automatically take care of itself. The next step is the resolution of DKA and HHS. I think the most important aspect is the clinical improvement. So is this person peeing well? Is this person being is better in terms of how he is generally? Is he eating and drinking? Is he talking to you? Now, these are the most important criteria. Now, from the biochemical criteria, the resolution of ketoacidosis includes blood glucose of less than 250, with at least 2 other criteria, with the improvement of serum bicarbonate of greater than 15, a venous pH of greater than 7.3, and an improved anion graph greater than 12. So you need at least 2 of this, along with basically glucose correction. But remember, the clinical improvement is very vital. As far as resolution of HHS is concerned, you would need to ensure that the osmolality is normal, and the mental status, which is a pretty important aspect in HHS, because people come with confusion, stupor, coma in relation to this, and that is very vital. The insulin infusion is continued until acidosis is resolved and the anion gap is no longer present. So as I mentioned, the identification of ketosis initially with the ketone meters and actually measurement with serum ketones is very vital, and the resolution of this is actually very, very dependent on where we are in terms of the best practice in monitoring response to treatment. So this has potentials of actually reducing emergency department stays, hospitalizations, and actually leads to a very quick recovery and potential of saving money. Now, transition to subcutaneous insulin therapy. So again, this needs to be done gradually. The best option is to look at the past 6 hours of insulin requirement. You multiply that for the past 24 hours and convert to a basal bolus regime. Remember, you've already given your bolus initially, so that needs to be titrated accordingly. And that is better to start it early, because that would prevent a rebound when you come to this stage. And always an overlap of a couple of hours is recommended between the discontinuation of IV insulin and the administration of subcutaneous insulin to prevent the rebound hyperglycemia again. So in an insulin-naive patient, if you're just looking at a weight per kilogram dose, you could use 0.5 to 0.8 units per kilogram per day. But as I mentioned, for each individual, it is best you look at their insulin infusion requirement. You look at the past 6 hours when the glucose is stable, and that's important, because if you take for the first 24 hours, the initial period, they're going to require a lot of insulin, because the hyperglycemia would actually promote insulin resistance. And once that glucose starts coming down, the insulin requirement comes down and they become more sensitive. So it's important to look at the past 6 hours and then calculate it for the 24-hour period, and that's a better aspect. And sliding scale insulin should be avoided at all costs, and that is very vital. So as far as hyperglycemic, non-ketotic coma, we spoke about it simultaneously, but remember, the blood glucose tends to be very high. These people are more prone for thromboembolic events. They're prone for renal impairment. Their pHs are generally greater than 7.3. The bicarbonates are generally greater than 15. They do not have ketones, or if at all they have mild ketonuria or ketonemia. But the most important aspect is the serum osmolality being very high, greater than 320 milliosmoles per kilogram. And this is very vital, because this is going to cause all problems. So again, here, there's no rush in terms of bringing the sugar down. It is important to understand that you need to make sure that they're peeing well, they're making sure that the electrolytes are getting corrected gradually, and then you address the insulin. So again, here, in terms of IV fluids with HHS, the hydration status has to be looked into. If they're hypovolemic, you could actually use a plasma expander or 0.9% sodium chloride at 1 liters per hour as per the DKA. But if basically they do not have hypertension, you look at the serum sodium, if the serum sodium is high, you use a half normal saline with, again, a slow, gradual correction and in comparison to when the serum sodium is actually normal. Now, if the serum sodium is low, then is basically, when you consider for maintenance of 0.9% sodium chloride. And remember, when the glucose reaches 300, you actually convert to dextrose. So your aim is not just looking at I want to get it down to hundreds or 150s. The importance is to get the sugars down slowly but effectively, but correct the fluid and electrolyte imbalance. So I keep harping on this, but this is very, very important. And as far as the insulin is concerned, you could use more conservative dosing in terms of reduction of glucose, because remember, you don't want the sugar to drop from 600 and then immediately to 400 in the next hour. And that causes a lot of flux between the cells and a lot of electrolyte disturbances, which you do not want. So you would need bring the blood glucose down slowly. So you go with a very, very small dose of insulin as far as intravenous insulin correction is concerned. Potassium corrections are similar. And as always, remember, you have to measure the potassium with serum electrolytes prior to actually, infusing potassium. Don't use potassium routinely in your first hour. Your first hour fluid is preferably given without potassium. So coming back to our patient, this patient had a potassium level of 3.9. So we actually administered 40 milliequivalent per liter of potassium with isotonic saline. And this basically was corrected prior to initiating insulin infusion. So the fluids were corrected with normal saline and then sequentially converted to half normal saline. So the treatment-related complications are something to look into. So we're using insulin. So insulin is associated with hypoglycemia, while bicarbonate therapy, which I said we should not be using, can result in hypokalemia. So with the current insulin therapy, this should not occur, but this is why this is important to understand that the blood glucose monitoring has to be for every hour. Some ICUs, they tend to try to cut cost and they do it once every 2-3 hours. That is very, very dangerous. You have to do it every hour. And remember, when your sugars are at 250 with DK or when it's around 300 with an HHN-KC, you should start 5% dextrose, because you're trying to correct first the intravascular volume, then you need to correct the intracellular volume, and for which you would need a hypovolemic fluid. Cerebral edema generally is not seen in adults, but however, with hypertonic corrections and also with overzealous corrections, you could get this. This is more commonly seen in children, but with the current era, we hopefully and we generally don't see this a lot. Other issues, acute respiratory distress syndromes is a rare complication of DKA, and this again is in relation to increased water in the lungs with reduced lung compliance, which again can be corrected with gradual fluid correction and gradual electrolyte correction appropriately. Vascular thrombosis, more so common in relation to people with HHN-KC. So it is important that we actually give a low dose of low molecular weight heparin therapy as prophylaxis for these elderly people who predominantly present with HHN-KC. And remember, these people are dehydrated, they have contracted vascular volume, they already have diabetes, they have poor control, they have low cardiac output. This increases blood viscosity, and this predisposes to atherosclerosis and vascular thrombosis, including myocardial infarction. So these things need to be kept in mind. So the checklist of DKA management, it's a phased approach. The initial phase, remember, the initial phase is in relation to fluid correction. You basically check the potassium and give the potassium accordingly. Phase 2, you basically change the isotonic fluids to hypertonic based on blood glucose levels and also on the sodium levels. And you generally adjusting the insulin infusion rate as per hourly blood glucose monitoring. And then phase 3 at 12 to 24 hours, you're planning next for transforming this person from the IV insulin to subcutaneous insulin, and you're looking at all the markers for resolution and ensuring that this is there. And remember, make sure that the basal insulin is on board. So to conclude, the acute metabolic complications of diabetes includes DKA and HHS. I've not mentioned hyperglycemia here because we're looking at more of hyperglycemic complications in this talk. But remember that there are differences in relation to corrections. And as always, as I've been stressing throughout this talk, correction of fluid electrolyte balance, restoration of intravascular volume, ensuring a good urine output holds precedence in comparison to using insulin and actually getting the sugars down. So I thank you very much for the opportunity. I hope I was not too quick. I just wanted to save time. Thank you very much for the opportunity once again.
Thank you, Dr. Anand. No, you've been right on time. Thank you for your lovely talk. It's been very clear. Luckily, we have good guidelines for us, both in terms of DKA and HHS that we all follow. I echo every practice of whatever you have mentioned. I don't have any doubts from the audience. We have about 150 doctors, I've been told, who have joined this session. please do put your comments, put your questions in the comment box, and we will try to answer it quickly. We're just about 20 minutes late, so we'll finish off with just some final comments from Dr. Mukherjee, and then on to the next section.
I'll just give two comments. First is, Anand, it was a fantastic presentation. You covered a whole lot of stuff in 20 minutes, and you were absolutely clear, crystal clear. Every slide was crystal clear. I really enjoyed it. Second thing is, all that we describe, first 6 hours, next 6 hours, is very good for us endocrinologists, diabetologists, but unfortunately, many of the times the DK in HHS is managed by our internal medicine colleagues, by our primary care physicians. So I think what you said is a very good take-home point for them, that they should try and follow what you said. The last comment I would say is, this is something which I saw when I came back to India, is using analog insulins intravenously. I think I would very strongly put my foot down and say, when you're giving intravenous insulin, please give the human simple insulin, whichever variety you want, and not the analog version. I think if you want to comment on that, Anand, please comment.
Yeah, I completely agree, JJ. I think I think, so I also would like to comment on the, usage of, this intramuscular insulins and subcutaneous insulins. So I think we should do away with all that. Although there are certain studies, I know certain companies have got studies in relation to that. That's not really safe, and that's not really ideal. So as you say, I think, regular insulin, you've used it for so long, you know its efficacy in terms of the absorption with the tubing, pretty well what it doesn't do, and it's very safe to actually do that.
And more than that, I think the difference between a human and an analog is when you give it subcutaneously. You see, by the time that you're giving it intravenously, it doesn't make a difference whether it's simple insulin or any kind of analog insulin.
Correct.
Rakesh, do you have any comments on that? Do you use the analog IV? Have you seen it being used intravenously, Dr. Sahai?
I've seen that, and so time probably people who are already using that, they can continue with the same insulin. But I think, as you said, it doesn't make any difference, and just adds to the cost, and it adds to confusion. I think it's best to stick to the regular conventional insulin as IV preparation, and then keep the analog only for subcutaneous use.
Thank you. Back to you, Dr. Kalyan.
Thank you very much, Dr. Anand. Our next session will be with Dr. Karthik Balachandran, who is a consultant endocrinologist from the Sri Ramchandra Medical Center in Chennai. He's done his DM from JIPMER, and he's more than 20 publications under his name. I've looked at your CV, Dr. Karthik. It's very impressive. I'm sorry we had to wait for 1 hour before we could start your talk, but over to you now.
So the screen is visible, and am I audible?
Yes, everything's good. Please carry on.
The standard first question in any webinar. So first of all, I would like to thank the IDEA team and Murali sir for this opportunity to speak on thyroid storm. This is a fairly rarer emergency compared to DKA. So in order to understand how to manage this emergency, we'll be looking at 3 cases. Case number 1 is a 56-year-old female. She's a known case of hyperthyroidism. She was diagnosed to have Graves' disease elsewhere, where she had presented with weight loss, palpitations, and tremors. After the lockdown, she was lost to follow. And subsequently, she developed fever and sore throat. And in the lockdown period and in the ongoing pandemic, the first thing that comes to mind in the phase of fever and sore throat is COVID-19. She was tested not once, but twice, and both times she was negative. She is also a breast cancer survivor, for which she was operated 7 years back. She doesn't have any cardiac history. With those complaints, and because she developed breathlessness and tachycardia, she was admitted to the ICU. She was noted to have an unimpressive goiter, nothing major about it, and no jaundice was seen. The basic labs were done. The labs confirmed what we already know. She was having hyperthyroidism. Her electrolytes were normal, but surprisingly, her total count and absolute neutrophil count were low, and her ALT was a little bit on the higher side. The first question was, could it be a storm? A patient who is on thyroid medication could she develop a storm was the first question, because she had been on and off with the follow-up. So the first thing that we want to understand from this case is that in any sick thyroid patient, any sick hyperthyroid patient, a storm must be suspected. And the most important thing to remember is that there is no clean cutoff for T3, T4, or TSH to differentiate standard thyrotoxicosis from storm. Many times the name, sort of biases people to think that storm must be having very high thyroid levels, but that is not often the case. So when do we say somebody has a thyroid storm? A patient with thyrotoxicosis develops some degree of worsening of complaints. It could have some systemic manifestations of thyroid excess. And sometimes we may be able to get a trigger. The trigger could be an infection, it could be stopping medications, it could be a variety of other things. So this trifecta is what we look for in a thyroid patient who has become suddenly sick and comes to us. Does the patient seem to have thyrotoxicosis? Is there any systemic symptoms? And was there any trigger? So in this case, we find two things. There is a potential for storm, and then by definition, an absolute neutrophil count of less than 500 would qualify her to have agranulocytosis. So this patient has two problems. Number one, it could be a storm. So how do we know if something is a storm or not? Surprisingly, unlike a DKA where you can do an ABG or ketones, there is no biomarker to tell this is storm and this is not storm, which is why we have to rely on clinical scores. Now, these clinical scores add a layer of objectivity to what we clinically see, but the bottom line is, even if the scores don't really match the thyroid storm, or a score of more than 45 would be called a thyroid storm, even then we would be safer to treat it as thyroid storm. So these are the individual components of the score. Each is scored, and thermoregulatory dysfunction, CV manifestations, GI or hepatic dysfunction, CNS dysfunction, and a precipitating history. This is called the Birch-Wartowski score. Now, hyperthyroidism is a little uncommon compared to hypothyroidism. In hyperthyroidism, storm happens in less than 0.5% of patients. So it is a really uncommon situation. And because it's an uncommon thing, we cannot have big randomized control trials or anything to guide our management. So it is more of case series and individual case reports. So this patient seems to be having a double trouble in the form of storm and agranulocytosis. So we return to the records to see what drug the patient was taking and at what dose. So this is important because both propylthiouracil and methimazole can cause agranulocytosis. But in addition to agranulocytosis, propylthiouracil is a more nasty drug. It can cause higher risk of hepatotoxicity and also ANCA positive vasculitis. But whatever said and done, if either of these drugs cause a serious side effect like hepatotoxicity or vasculitis or agranulocytosis, we can't give the other one from the same class, which is why we return to the drug record. She was taking carbimazole at 10 milligrams thrice daily. So now that the diagnosis is more or less clear, and as Dr. Anand pointed out, in any medical emergency, diagnosis and treatment has to go hand in hand simultaneously, not in series, but more in parallel. But we need to understand the principles of treatment here. The problem here is that thyroid hormone is in excess, and we need to get rid of that thyroid hormone. The 4 ways in which we can do that is to stop the production of thyroid hormone, stop further release of already produced thyroid hormone, stop action of already released thyroid hormone, and finally, to take care of whatever actions that have already happened, meaning mop-up action and supportive care. So at each step, we can intervene and do something. So to production, release, action, and post-action. So we have a list of drugs which we normally use in thyroid storm, not just in thyroid storm, in any severe thyrotoxicosis. These drugs basically are the ones which work through these principles. Methimazole or carbimazole work to stop production. Propylthiouracil is similar. Potassium perchlorate is a very uncommon drug. Apart from the a diagnosis of dysharmonic goiter, it has very, very little role, but it can also stop production. Iodine, which can be given as saturated solution of potassium iodide or Lugol's iodine, prevents release of thyroid hormone. Lithium can cause both stopping of release and stopping of production to some extent. Cholestyramine prevents the thyroid hormones from going back to the gut and getting recirculated again and again. Beta blockers stop the peripheral actions of thyroid hormone. Steroids give a similar action. So these are the drugs which we have in our menu from which we can choose to treat this patient. Now, as I said previously, when one thionamide causes serious toxicity, we can't use the other one. And the perchlorate is basically out of question because it has two problems. One is it's not very commonly available. Second is it itself can cause aplastic anemia. In a patient with agranulocytosis, that wouldn't be a good choice. And iodine or lithium, both can be given separately, but given together, they don't have any extra advantage over giving just iodine alone. Apart from these drugs, we also have certain non-pharmacological options, which is plasmapheresis and charcoal and resin hemoperfusion. Plasmapheresis is not the bedside plasmapheresis that we think about. It's the large volume plasmapheresis. It removes TBG with bound hormone, also removes the antibodies in antibody-mediated thyrotoxicity, that is Graves' disease. It removes about 20% of the T4 pool and even less of the T3 pool during the procedure, so it's not hugely effective, but we need to do it again and again because its effect is also transient for 24 to 48 hours. So it is directly taking out the hormone. So going back to our patient, she has impending storm, agranulocytosis, possible sepsis, even though the blood culture was negative. We don't know if she has a sepsis or not. Based on the mechanism of action and the kind of drugs that we have access to, we could potentially give these drugs, lithium, cholestyramine, steroids, beta blockers. Apart from that, most importantly, supportive care. It is extremely important to remember that supportive care is the cornerstone of management, and attempting to do this in smallish nursing homes or things like that is highly, it should be discouraged because this is a serious problem and poor supportive care can result in mortality. So what do you mean by supportive care? Anti-protein, antipyretics, paracetamol, external cooling can also be given in some situations. We need to check for access if oral, rectal, IV access is available so that we can deliver the drugs. Broad spectrum antibiotics and fluid management, we prefer dextrose containing fluids because in thyrotoxicosis there's a glycogen depletion. And if the patient is possibly thiamine deficient, because we are giving dextrose containing fluids, we need to supplement thiamine as well to prevent Wernicke's encephalopathy. This is more for men with thyrotoxicosis, especially alcoholics. In this case, she is a 56-year-old woman, so it doesn't really apply in her case. One thing to remember is that salicylates should not be given because they decrease protein binding of the thyroid hormone and raises the free hormone levels, which can again worsen the situation. So in her case, the first thing to do is the removal of offending drug, which is methimazole, which she was taking. Instead, we gave lithium 300 milligram 8 hourly, dexamethasone, propranolol. One thing to remember is that the T4 to T3 conversion blockade of propranolol manifests only at much higher doses, about 160 milligrams per day, not in standard lower doses. So if we are looking for that, we have to give some higher dose. She was also given broad spectrum antibiotics. Apart from that, she was also given filgrastim because for agranulocytosis. She was also having neutropenia, sepsis, possible sepsis. So we wanted to get her counts up very fast. The plan was to do definitive treatment, either surgery or radioiodine ablation after stabilization. By 5 days, the patient had improved. Her counts had come back to 8,000 per microliter. Beta blockers had been tapered. She was shifted away from the ICU to the HDU. And the next day, she developed this rhythm. This is a scary looking rhythm. It's called polymorphic ventricular tachycardia, also known as torsades de pointes, which is basically twisting of points. This should be distinguished from simple, just artifacts which can be seen in hyperthyroid patients, which is due to tremors itself. This is a normal patient with simple tremors, and this is to be differentiated from polymorphic VT. So what went wrong in this patient was that the GCSF caused a rapid expansion of cell pool, which led to hypokalemia, which was in the background of tapering of beta blockers and high levels of thyroid hormones and catecholamines resulted in an arrhythmia. So this patient luckily was caught at the right time. The electrolyte abnormalities were corrected. She was managed in close relationship with the cardiologist. She was given the option of surgery and radioiodine. If the patient has been given SSKI or Lugol's iodine, the chance of radioiodine working is pretty low. So in some situations, surgery may be a better choice. She decided to go for radioiodine ablation at a later date. After 3 months of follow-up, the patient is better. Now, what we can learn from this case is that just like any other medical emergency, treating that emergency doesn't stop there. We need to be prepared for second-order complications of that emergency. So that brings me to the second case. This is a 30-year-old male presented with weight loss and hyperdefecation for several weeks. Symptoms had deteriorated and he was playing cricket match, and after that he had developed some degree of confusion and he was brought to emergency. His past history is significant in that he has been taking methimazole, but he stopped 7 months back. He underwent wisdom tooth extraction 4 weeks back, and his younger brother also has type 1 diabetes. So coming to examination, his pulse is 140 beats per minute, temperature of 101, respiratory rate is 25 beats per minute, and he has Graves' ophthalmopathy as well. So the labs were much similar. As I said before, there is no FT4 or FT3 cutoff for thyroid storm. So in the setting of a thyroid storm talk, it's easy to diagnose such a thing as thyroid storm, but then again, we need to suspect that in the first place. One clue was the presence of systemic symptoms, especially confusion in this relatively youngish male. Again, we applied the Birch-Watowski score. There's also something called an Akamizu score, which is derived from patients in Japan, but this one is much more commonly used in India. Total score came out to be 80. As I said before, we look for 3 things. Is there thyrotoxicosis? Is there any systemic symptom? And can we identify a trigger so that we can take care of the trigger? So in this case, the trigger was stopping of the thyroid medication and possibly the recent changes, including the stress of dental procedure. So what we need to learn from this case is that young patients can also develop storm. It's not a disease of old ladies. Stopping drugs is a very common precipitant, and any presence of a systemic symptom gives us an easy clue for us to consider the presence of thyroid storm. So that brings me to case number 3. A 60-year-old male with fever, weight loss, and fatigue. He is a known case of chronic lymphocytic lymphoma or leukemia, for which he has received treatment with bendamustine and rituximab, admitted to ICU with febrile neutropenia. As his examination shows, temperature is 102.5, pulse is 132 beats per minute, and physical examination shows a left-sided neck swelling, which is tender on palpation. Labs again confirm what we already know, that he has hyperthyroidism. Apart from that, his total count is heavily elevated with the 66,900 per microliter total count, and almost all of it is monocytes, 98%. So the patient has febrile neutropenia and thyrotoxicosis. Imaging shows a lymphomatous nodules in the lung, spleen, liver, and kidney. But his thyroid gland itself is normal looking on a CT scan. He is treated with the standard methimazole therapy and the whole bunch of things, methimazole, beta blocker, steroid, supportive care paradigm for thyrotoxicosis. But this patient does not respond to that therapy. In fact, his thyroid hormone levels continue to worsen and increase day after day in the ICU. So he's not showing much response. So we go back and see if there is anything else happening. The CT is repeated, which shows the progression of lymphomatous resistance, infiltration of the thyroid gland. And the situation here is not that the thyroid gland is keeping on producing more and more hormones, but that is getting slowly and but surely destroyed by the lymphomatous lesions. So stopping the production of the gland by giving methimazole is not really much helping him, and we need to take out the hormone itself from his circulation, for which plasmapheresis is planned. The patient, remember, has a lot of metastasis, high risk case, but before everything could be done, the patient succumbed to the illness. So what we can learn from this case is that any patient with thyrotoxicosis and neutropenia does not necessarily mean the patient has agranulocytosis. In this case, it is due to his hematological conditions and the medications he is receiving for that. So we cannot blame always the anti-thyroid drugs for any hemat issue that we see in a thyroid patient. Cause of thyrotoxicosis matters. So the vast majority of thyroid storm occurs in patients with Graves' disease, because hyperthyroidism itself is mostly Graves' disease. About 80% of them are harboring Graves' disease. But in some cases, there could be unusual causes which we need to take care of. And this is an emergency, and untreated thyroid storm can have a mortality up to 90%, and therefore time is life, and diagnosis and treatment must happen simultaneously. So to summarize these three cases, we look at whether the patient has thyrotoxicosis or not. That is, and we also look for the cause of thyrotoxicosis. It could be even exogenous intake of thyroid hormone to a molar pregnancy producing hyperthyroidism, to all sorts of fancy causes. But in most cases, it's just Graves' disease. Then we look at systemic features. If there is any systemic feature, we go ahead and do the Birch-Wartowski score. And even if that score is not commonly, you couldn't do the score. If there is any doubt, consider the patient to be having thyroid storm, because we err on the side of caution. Then we also look for any trigger and then neutralize that trigger. Usually the common triggers are infection, infarction, and stopping of medications. Infarction in the sense any kind of blood vessel blockade anywhere. So these are the three things which we want to do for diagnosis of thyroid storm. Out of all these things, the most important step is clinical suspicion itself. Any hyperthyroid patient, thyrotoxicosis patient, showing sudden worsening with any systemic feature is a high risk case for a thyroid storm, and it must be suspected and then ruled out later on. Coming to treatment, we have the principle of treatment is stop the production of hormones with methimazole or PTU. Methimazole is much more commonly used. Stop the release of hormone with lithium or iodine. Stop the action, peripheral action of the hormone with steroids or beta blockers. So this is the principle of treatment. We need to be open to the complications of both the trigger as well as thyroid storm, and also anything that might be happening as a second order complication of treatment itself. So supportive care and anticipation of complications is very important in these patients. And finally, definitive treatment must be planned for these patients. So they should not be just discharged with no plan for definitive treatment. It could involve either ablation or surgery. And if the patient receives leucocytine or SSKI, surgery would be a better choice than ablation in the coming months. So if we understand these principles of treatment and diagnosis, we can save majority of these patients. But the most important thing that we must remember is that the fundamental way to manage thyroid storm is to first suspect it. And if there is any doubt at all about your setup, this requires some sophisticated setup for management. If there is any doubt at all about setup, please refer to your neighborhood endocrinologist. Thank you so much for listening. I once again thank the IDEA team for the opportunity. Thank you.
Thanks a lot, Dr. Karthik. You've illustrated thyroid storm very well through a series of case presentations. We are very fortunate that we see very less of this thyroid storm. I've probably seen only one. My colleague team was sorting him out. Dr. Mukherjee, do you have any experience on thyroid storms?
I mean, yes, I have a fair experience, unfortunately. I think Karthik presented everything very nice. First case was a double whammy. It was ATD-induced agranulocytosis, and then the patient was thyrotoxicosis was present. I totally agree with you. Diagnosis is always a question of semantics. I think if somebody who's got roaring thyrotoxicosis comes with fever and even one system dysfunction, be it gastrointestinal, cardiovascular, or CNS dysfunction, I would jump in and manage him aggressively. Putting a thyroid storm in inverted commas is just a semantics, basically. Your third case, I don't think it's a thyroid storm. I think your third case is probably infiltrative kind of very rare, very rare. We described the case of anaplastic thyroid carcinoma presenting with thyrotoxicosis. That's not a thyroid storm really, because the patient had other issues. Management-wise, the first patient is again a nightmare to manage. You can't use an anti-thyroid drug. So I think that you wish for your professor. If you get that, you pass it on to your professor. It's very hard to manage. But for the general audience who are listening to us, I think for you the message would be: I think seeing a thyroid storm will be quite rare for you, unless and until you're working in a tertiary level hospital. But the message for you would be to, whenever you start an anti-thyroid medication, our general physician colleagues, please write one line in your notes that you've explained to the patient about agranulocytosis. You may see one or two in your entire career, but those one or two may be enough to cause severe problem for you if you don't have it documented. So it's a very practice of very low return really, but unfortunately you have to keep writing that I've explained the patient about agranulocytosis. And if a thyrotoxic patient gets any kind of the symptoms that Dr. Karthik mentioned, then probably refer directly to a trained endocrinologist. But I totally agree with Dr. Karthik that this requires a little bit of what you call proper intensive care, supportive management to get the patient out of it. That's all I want to add. It's a rare condition, and I don't think many of us would have seen so many of thyroid storms. Back to you, Dr. Kalyan.
Yeah. Dr. Srinivas, you had a comment.
We lost one case of thyroid storm in my post-graduation time, Usmania. Patient is regular follow-up of the hyperthyroid patient. She's taking antithyroids. The drug called antithyroids, so that time used to be then. I don't know now company people are promoting or not. Medical staff fellow has given a thyrox. Instead of giving antithyrox, medical staff fellow has given a thyrox. So in the emergency, Usmania emergency, we lost that patient, young, around 30 years, so female. So one of the Karthik well presented, and case presentation is always welcome by speakers. We love to learn from case-based presentations. Very well presented, Karthik. So sometimes medical staff can kill the thyroid storm patient.
Yeah, and another thing I noticed is stopped using block and replace since I came to India after I received a shock of my life. When I put the patient on block and replace, they ran out of drugs for blocking medications, and then continue to take thyroxine.
So that's also a learning point. That Dr. Karthik's slide should be there. You know, I think avoid block and replace in India because they will run out of pneumocazole. They will stop it and they'll continue with the thyroxine, as was the experience.
So thank you very much, all the speakers for the session. Dr. Mukherjee, thank you so much for your valuable insight into a lot of complications that we discussed. So with that, I'll conclude this session and we'll move on to the next session. All the speakers in the chairs, you're welcome to stay on for the next couple of sessions. Thank you.
Thank you. Bye-bye.
So for the next session, we have So for this next session, I'll introduce the chairs for the sessions. We are very fortunate to have Dr. Abhay Kumar Sahu, who's an eminent endocrinologist from Odisha. He's practicing as an associate professor in endocrinology at IMS and SUM Hospital in Bhubaneswar. He takes care of a lot of educational programs for medical students, and we are privileged to have you, sir, as a chair to our clinic, to our clinical meeting here. Thank you very much for joining.
Thank you.
Thank you, sir. So we also have Dr. Srinivas Rao, who is a part of Idea Clinic's team. He's a consultant endocrinologist at Suchitra. He's also an associate professor of endocrinology in Gandhi Medical College, Hyderabad. He has a lot of academic interests, especially in endocrinology, growth, puberty, and thyroid diabetes. Welcome, Dr. Srinivas Rao.
And thank you, Kalyan. And this session, I think 3 topics are there. Moderator is Jayasima Reddy.
Yeah.
I think lucky of digital conferences, there's no lunch session. But I think everybody can take lunch because lunchtime is happening. Enjoy the talks and along with lunch. Jayasima Reddy, please take over.
All right, thank you. Thank you. We all welcome you for this interesting sessions. So I think it's back to, we have 4 topics. I think it's first is back to Dr. Kalyan Chakravarti for talk on early and precocious puberty. Very challenging topic that needs a lot of input from this. So back to Dr. Kalyan.
Thank you. So precocious puberty, it's one of my favorite topics. I have seen a lot of girls, especially precocious puberty girls in the last few years. And currently I have around 4 to 5 under my treatment. And it's it's not challenging, but it's very fruitful to treat these patients. And it's very fruitful in terms of how they respond also. So let's go into the outline. So my talk will involve mainly what is the normal puberty? How do we define a normal puberty? What is the definition of precocious puberty? Where do we call it a precocious puberty? Where do we call it an early puberty? What are the various causes of these, the early puberty, the precocious puberty? When to investigate? What is the initial workup like? And once we have all the initial workup done, generally it is going to turn out as it is going to turn out to be an idiopathic precocious puberty. And so once it turns out to be an idiopathic central precocious puberty, what do we do then? How do we do a stimulate testing? When do we treat? And what do we treat them with? So just going quickly through what is the normal pituitary axis, what does it do, how does it look like? If you see on the left, this is the hypothalamic pituitary ovarian axis, and on the right, it is a hypothalamic pituitary testicular axis. So you have a puberty is a clock where it starts at around the age 10 to 12 for the girls and maybe 12 to 14 for the boys. And you have a clock that starts ticking in. There's signals coming from the hypothalamus, mainly through the kisspeptin gene. We don't know what kisspeptin hormone, but we don't know what stimulates the kisspeptin. It may be that it may be the genetic factors where the parent has had a menarche at a certain age. The girl will also have menarche, and boys follow suit too. And there might be also genetic, the body fat and leptin influences. So because we are now a more well-fed societies, we are seeing girls mature earlier than what we used to do before. And there is also an advancement in the menarche age in the Afro-Caribbean American group also. So once you have a GnRH pulse stimulator, which stimulates your gonadotrophin cells to secrete LH-FSH in the females, you have the FSH, which continues to stimulate the follicle, which leads to an ovum production, leading to ovulation. And the LH mainly stimulates the theca cells to produce androgens, along with other functions, and it starts with the production of the estradiol. The estradiol then goes and develops the breasts, does a growth acceleration and skeletal maturation for the women, for the girls. And estrogen and progesterone both are responsible for the menstruation. Now, it is important to note that estradiol is the main hormone which closes the epiphysis, both in the boys and the girls. In the boys, testosterone is converted to estrogen. In the girls, the estrogen levels are significantly high after puberty, and therefore they have a sudden high growth, and then the growth stops suddenly. Whereas in boys, the testosterone gets converted to very low dose of estrogen over a certain amount of time, and the growth of the epiphysis, the growth of the long bones is for a longer time, and the epiphysis close very late. Therefore, we have a sustained growth in the boys. Now, in the boys, the same GnRH pulse stimulator stimulates the gonadotrophin cells to produce the LH and FSH. The FSH is responsible for the proliferation of these seminiferous tubules, and the main the main function is the production of sperm, whereas the LH mainly stimulates the Leydig cells to produce testosterone, which has again a negative feedback to the GnRH stimulator. And this is the male version of things. Of course, the testosterone will then start to increase the penile growth, increase the muscle mass, deepens the voice in the boys, and is responsible for hair growth, also responsible for erections. The estradiol that gets converted through the aromatase in the peripheral adipose tissue may lead to a little bit of development of gynecomastia in the boys, which is generally transient. It causes the growth acceleration, and it causes the skeletal maturation. This kisspeptin is a very important hormone during the puberty. we don't know what stimulates the kisspeptin, but we know that people or patients who have idiopathic hypogonadotrophic hypogonadism have a deficiency in this KIS1 gene, which encodes for the kisspeptin hormone. So kisspeptin plays a very important role and has actually a therapeutic benefit in patients who have delayed puberty or have this loss of this gene. So the next important slide is the sequence of puberty. This is a very important slide because the sequence will tell us whether the progression of a puberty in a girl or a boy is normal or abnormal. If it is a normal sequence of puberty, you can assume mostly that it might be, of course, it will require biochemical evaluation and all that, but you can 50% assume that it is actually coming from the pituitary. So what is the normal sequence? Normal sequence of puberty is consonant. That means it follows a specific pattern. There is a predictable sequence and chronology of the events of puberty. If you take girls start with the breast bud. Of course, they have a slightly high growth spurt just at the beginning of the breast bud. The breast bud, which is B2 of the Tanner staging, that is the first change in the girls. It starts with breast bud. They may develop pubic hair before because of adrenarche, which is another simultaneous event during puberty. But you generally see pubic hair in and around that breast bud advancement stage. And then the growth spurt continues for almost about 1.5 years. And you see that the menarche is like the tail end of the puberty for the girls. Once they achieve menarche, the growth spurt stops. They don't grow much beyond that, and that's when their puberty ends. So the menarche is almost the final stage of the girl's puberty. So if you see a girl who has suddenly has some period but has not developed any breast bud or any pubic hair, or you see the breast bud is the breast development is not, so it might have developed B3 or B4 by the time they've developed menarche. The breast is still in B2 stage and they've developed menarche. It means that they are getting high amount of estradiol from a peripheral estrogen secreting tumor or something else. So the sequence is very important for us. In the boys, the penis growth, yes, it starts from a very late age, about 13, but penis growth is not taken into account when you're looking for Tanner staging, which is the main staging we look at to assess boys or girls advancing in puberty. So the testicular size is one of the most important parameter in the boys. We measure it generally with the ml, some measure with centimeters. If it is anything beyond 4 ml, when you measure with the Prader orchidometer, if the boy's testis has reached 4 ml or more, he has gone into puberty. And the advancement can go all the way up to 25 ml. The pubic hair again will start around the same time, and they start to mature. It will be the grading between T1 to T5 based on the Tanner staging. So the Tanner staging mainly takes into account, for the girls, it is the breast, and for the boys, it is the external genitalia, which is the external genitalia and the pubic hair. The external genitalia in the females is generally not considered much of a significant in terms of staging. And of course, we hardly happen to see the clinical advancement in girls because of social situations. So in India, they have done a few studies. This is all from Pune-based team, and they have seen what what the Indian boys have their average stretched penile length, which is what we measure in a 1-year-old, 10-year-old, and an 18-year-old. If you see that the penile length is about 5 centimeters, which is prepubertal, and it can reach all the way up to 10 centimeters by the time they are 18. The testicular volume, as you can see, prepubertal is 3.3 ml. Beyond that, 4 ml and up to 25 ml is a huge advancement during the pubertal stage. And on the right side, this is a report from 2006. They have measured what is the normal age at which, or what is the normal parameters at a certain age of girls who have at breast stage 1, 2, 3, 4, 5. So we have measured an ovarian volume, uterine length, fundocervical ratio, and endometrial thickness based on what the breast staging is. So I just want to highlight the second stage, because lot of the times we measure only whether the girl is prepubertal or pubertal. So if she's breast stage 2, she has had a breast bud, that means she has entered puberty. What all we have to, other parameters that we can check is the ovarian volume, which has reached beyond 1, you can say, because prepubertal is 0.5, so anything beyond 1. But the main sensitivity for puberty is the uterine length, which is above 3.5 centimeters. The fundocervical ratio is above 1.29 in these patients, and the endometrial thickness keeps progressing as the breast stage progresses. So the prevalence in India is unknown, whereas the Danish registry, which had about 10 years of data, almost 10 years of data, found that the prevalence was about 0.2% for girls, but much lesser in boys, it is 0.05%. But there are certain studies, certain data which suggests that the girls have much higher prevalence, almost 70 to 80%, which is what we see in clinical practice. Almost every patient that comes to me in our clinic is a girl with precocious puberty. So when do you call it a precocious puberty? It's very easy. It used to be previously at a higher age, but now it is boys less than 9 years age and girls less than 8 years age. So any boy less than 9 years age developing secondary sexual characters, or a girl less than 8 years age developing secondary sexual characters, is a precocious puberty and needs investigation and treatment. What are the causes of it? Generally, not of the time, 80 to 90% of the time, it is idiopathic. We don't know why it happens. It is generally, it is seen in girls or boys which are just close to their natural pubertal age. It is just slightly obese girls. They might be having much higher body fat. That's why they are developing early puberty. And sometimes in boys also. The other causes of central precocious puberty, which is a gonadotrophin dependent, which means the problem is with the pituitary, either the pituitary starting off or the GnRH pulse starting off by itself, or there might be another pathology in the pituitary, which is like the hypothalamic hamartoma or other CNS infections and tumors. But hypothalamic hamartoma is the second common thing described in the literature. It is a benign tumor which is above the close to it is in the hypothalamic region, and it causes a disinhibition of the pituitary, hypothalamo-pituitary axis, leading to activation of puberty. Generally, these tumors are benign; they are not operated on; they are left just to be followed up, and the patients are just treated as you would treat with an idiopathic gonadotrophin-dependent puberty. The peripheral puberty, which is peripheral precocious puberty, which is a gonadotrophin-independent puberty, which is because of the peripheral stimulation of or a peripheral production of steroids, sex steroids, either estrogen or progesterone in girls or boys. So the most common thing we see here is the congenital adrenal hyperplasia, where in girls it secretes testosterone, and that can lead to peripheral precocious puberty. Other tumors are all very rare, and some tumors secrete the hormone of the opposite sex. So the boys can have tumors which can secrete estrogen. The girls can have tumors which can secrete Leydig cell tumors, like they can secrete testosterone. So these tumors can give contrasexual puberty, leading to opposite sex secondary sexual characteristics. Of course, there are benign variants. These are all actually very commonly that we see in our clinic, because there are girls who develop just a slight breast bud, but do not have any other signs of puberty. They might be premature adrenarche with just body odor, axillary pubic hair, but no other signs of puberty. And some girls have a slight vaginal bleeding, spotting, but with no evidence of any pubertal progression. Even in India, there was a study done in 2020. It was just retrospective analysis of about 55 records. They found that idiopathic central puberty is the most commonly found cause of precocious puberty in India too. But there have been other problems like hypothalamic hamartomas and CAH also that have been detected. And hypothyroidism is one of the very rarer but documented causes of precocious puberty. Then when to investigate? What are the signs of puberty? So when do we know whether this is an abnormal thing or not? Of course, as we mentioned earlier, in boys, a testicular volume of more than 4 ml, a stretched penile length which is more than 5 centimeters, but it is quite variable. We cannot always rely on that. Voice change, spontaneous erections or nocturnal erections, and facial hair. So these are the signs in boys. In girls, a breast bud is a definite sign of progression of puberty. Labial folds forming, menarche, of course, uterine length on radiologically measured uterine length of more than 3.5 centimeters or a volume of more than 1.8 ml is definitely diagnostic of a precocious puberty. A fundus-cervical ratio of more than 1 or maybe 1.2, an ovarian volume of more than 1 centimeter cube is also suggestive of precocious puberty. In both sexes, we can see pubic hair, axillary hair, growth spurt, advanced bone age, body odor, and changes happening, which can be signs of puberty, not by themselves, but as a conglomeration of all the symptoms. So how do we initially work up? We have to firstly look at the oxology. What is their height? What is the height been? What has the growth velocity been? The growth velocity in puberty is about 10 to 12 centimeters in girls and 12 to 14 centimeters in boys. So they advance at a very rapidly quickening pace. So if we happen to have their previous records, if they're not having any much of a growth spurt, you can actually safely assume that this is not puberty. An X-ray of the left hand for bone age. So bone age gives us a very good estimation because of estrogen. The bone age is quite advanced. So precocious puberty is a hallmark of precocious puberty is advanced bone age, because your bone age advances because of high estradiol concentrations in both sexes. And it should be more than 2 standard deviations for that, or 2 centiles more than what is required for that age. So the bone age should be almost 2 centiles more than the chronological age. You can just check for the thyroid profile to rule out hypothyroidism, and you can do an ultrasound pelvis to look for the measurements of uterus and the fundus-cervical ratio. And then we have to stop. We should not go ahead to an MRI or LH unless we find clinically that there is a precocious puberty. Then this is time for the endocrinologist or the pediatric endocrinologist to come into picture. What then we do is, if we are convinced that the patient has, in fact, signs of puberty, she has advanced bone age, she has a growth spurt, and she may not have basal sex steroids or LH-FSH, which give us a clear picture. There might be in peripheral precocious puberty, they might have very high estradiol and suppressed LH-FSH, which is diagnostic of a peripheral precocious puberty, but that is very rare. Generally, we see a LH-FSH which is very low, and the estradiol also, which might be on the lower side. And then we need a stimulated LH and its sex steroids. So what we do then is to stimulate a natural sequence of the GnRH pulse and try to stimulate LH and sex steroid to see if we can induce a pulse of these sex hormones. Then the next step is an MRI of the pituitary or a CT abdomen pelvis. Well, depends. If the ultrasound has not picked up any ovarian tumors or any intra-abdominal lesions already, and if the patient has signs that this is a central precocious puberty, we go ahead to do an MRI of the pituitary. And if we don't need to do a CT abdomen pelvis, that is only for the surgeons if they want a further surgical evaluation for any intra-abdominal tumors. Otherwise, it is just for an MRI of the pituitary. And that too, we just want a plain MRI. We are not concerned with the pituitary microadenomas, because we only want to rule out hypothalamic hamartomas or something suprapituitary. And therefore, a plain MRI would probably do if the patient is less than 6 years old. So anything more than 6, generally they say that the MRI is not indicated if there's a clear sequence of puberty, and because there's mostly going to be an idiopathic central precocious puberty. So the guidelines only indicate to do an MRI. There's no guidelines actually speaking, but the evidence clearly indicates that it might be just less than 6 years old who develop a pathological cause for their central precocious puberty, not an idiopathic cause. So I just want to show you a growth chart example. So this girl has had, she's been on the 10th centile for 25th centile for her growth. This is the target height for what she should have achieved, which is the 25th centile. And then suddenly she starts at the age of about 7 or 6, she starts having a growth spurt. She crosses the centiles, goes up, has a huge advancement in growth, almost 15 centimeters in 1 year. Probably an exaggeration. This is a made-up chart. So, but you can see that at this time, if they have come for the evaluation, this is the chronological age, and I do an X-ray and find that her bone age is around 10.5 years. So clearly, she has more than 3 or 4 centiles crossed her her bone age for the chronology. So the bone age is not equal to chronological age. She has advanced bone age, a high growth spurt. It's very indicative that this patient has a precocious puberty. But what happens if I leave this patient here? This bone age will advance, and the final height is actually determined not by the chronological age, but by the bone age. And therefore, the bone age, if we leave it like this, she will lose almost 10 centimeters to her target height. It might be even smaller than this, because the bone age, if it quickly advances, she might be even shorter than what the predicted height is. So bone age is very easy to calculate. I'm just going to give you a brief summary of how we calculate the bone age. Radiologists, unfortunately, there are some good reports, but sometimes they give an age range of 8 to 15 years, which doesn't help me. So there is a very good atlas that we can follow. There are multiple atlases available. I follow this. The quick learning points. The quick thing to see is a pisiform bone. The pisiform bone is the small bone that is just on top of the ulnar bone, and the pisiform bone develops pre-puberty. In boys, it develops around 12 to 13 years of age. In girls, it develops around 10. So if the pisiform bone has developed, definitely the bone age for the boy is 13 years or more. And the other thing to see is the gap between the metaphysis, the long bones, and the epiphysis. The epiphysis, as they close, you see that the gap closes much quicker. The peripheral bones close quicker than the long bones, and the long bones will take almost another 2 years to close by age 18. So how much is the gap between these bones, and what is the width of the epiphysis in relation to the metaphyseal plate? So here you see that it is not reaching much to the full width of the metaphysis. Here it is reaching to the full width, but it is not full. And as you see, the age advances, it becomes more dense. The epiphysis becomes more dense, and it starts to fuse. So once you start seeing, because you see in the atlas, there will be 1-year-old, 2-year-old, 3-year-old. As you keep looking at these X-rays, you will become more and more clearer as to what. So what we do is we get the patient's X-ray and we look at the atlas and just correlate, saying, rather than telling you have a very good visual representation. You can just see and say, oh, okay, this patient is 12-year-old, 30-year-old. It's very easy to actually diagnose these things. In the girl, you see that the pisiform will develop at the age of 10, and the girl has much more advanced development of the bones, and therefore the bones close, the epiphysis close almost by the age 14. So these are the quick clinical differentiators. I just want to spend a little bit of time on this slide. The age, how do you differentiate between all these three variants? Generally, the central precocious puberty tends to be of very close to the physiological age, whereas the peripheral precocious puberty can develop very early in childhood. Whereas in the benign variants, it again tends to be of close physiological age only. The isosexual secondary sexual characters will be generally seen in the central precocious puberty. They may be contrasexual in tumors secreting the opposite sex hormone in the peripheral precocious puberty group. And in benign variants, it's usually isolated secondaries. It's either a isolated breast development, isolated period, or isolated pubic hair, but none other will have a progressive. So this is non-progressive. Whereas in the central precocious puberty is generally consonant. It's a sequential, and the growth spurt is generally seen in both variants, but in benign variant there will be no growth. And again, bone age, it follows the growth spurt. They will be much advanced in the central and the peripheral precocious group, but in benign variant there will be no deviation from the chronological age. The hormones. So a baseline hormones will show a suppressed LH and FSH with high sex hormone groups. It is definitely suggestive of a peripheral precocious puberty, and you generally don't need to do a stimulated LH. But where you have a low LH, low FSH, and low estradiol, you have to stimulate with a GnRH analog and confirm whether it's a central precocious puberty. And in benign variants, they will be prepubertal. Everything will be prepubertal, and based on the clinical, what your clinical analysis, you can avoid doing a stimulated test in these patients. The treatment is generally a tumor excision in peripheral precocious puberty, and in case of CAH, that's a different ballgame with steroids and everything. But whereas the mainstay of treatment in central precocious puberty is GnRH analogs. In benign, you can always wait and see. You can always follow the patient up in 6 months to see if they've developed a growth spurt or the bone age advances. If it doesn't, you can leave it alone. Just a simple example of hypothalamic hamartoma, which is just advancing from the posterior part of the pituitary into the pituitary stalk. This is a large ovarian tumor. These are both cases causing peripheral precocious puberty. But lot of the times we exclude everything. A lot of the times it is mainly the idiopathic central precocious puberty that we conclude, that we get a conclusion. So everything is normal. It's just that the patient has started developing puberty. Then what you do? So then we start to do a GnRH stimulation test. The concept is that because the pituitary drives the puberty through a pulsatile LHRH endogenously, we try to simulate the same by giving a GnRH analog and try to stimulate the pituitary. We take a basal sample at 0 hours for FSH and LH, administer injection leupride. This is what we commonly use, but we can any sort of GnRH, short-acting GnRH analog, not a depot. And you can use, some people use 10 micrograms, some people use 20 micrograms. But the best thing to do is to use half a cc. It is a 1 ml small vial. You just use half a cc, which generally amounts to about 20 kgs, 20 micrograms per kg. And you check for a 4-hour sample. There have been multiple there is no set guidelines of what to do this. I've just reviewed some papers and put up what we are commonly following in India. So with 4-hour samples for LH-FSH and a 24-hour sample for testosterone and estradiol. 24 hours because it takes a longer time for the actual sex steroids to start increasing. Whereas LH-FSH can go up immediately, 30 minutes after you give a GnRH analog. Then how do you interpret? If the 4-hour LH is more than 3.3, or some people say a 3-fold rise from the basal LHS, as long as you're able to stimulate the pituitary with some GnRH, the problem is with the pituitary. If the patient has not gone into puberty, no matter how much ever you stimulate, you will not be able to increase your LH. And the 24-hour serum testosterone level will be high in boys, and the estrogen level will be high in girls at 24 hours. So when to treat? Why and when to treat? If it is a precocious puberty which meets the clinical definition, if it is less than 8 years for girls and less than 9 years for boys, you treat. There is no question about it. If it is an early puberty, if a lot of patients bring to the clinic a fourth grade girl or a 3rd grade girl who's about 8 or 9, just on the borderline, and they really don't want this girl to actually have puberty. So this is a chart I just drew. If we leave this girl untreated, they will fail to develop their predicted height. If we leave them, if I stop the GnRH at this, if I start the GnRH, I slow down the growth, and then when I stop the GnRH, I allow the puberty to resume, and they will reach their target height. So it is predominantly about the height, but also about the social circumstances. A 3rd grade, 4th grade girl may not be much aware of how to handle all these sex hormones that are coming, and or how to handle periods. So it will be a social problem for both the girl and the parents. And generally, if the mother is in favor of hormones, I generally give the GnRH analog. And of course, there are other risks when they are adults that, patients who have had precocious puberty have metabolic syndrome, dyslipidemia, dysglycemia, and other problems. So what is the mechanism of action of these? So the mainstay of treatment is GnRH analogs. So you would argue, if the GnRH analog is stimulating the pituitary, why would you give it as a treatment? Well, the GnRH, if you give it as a pulse treatment, you stimulate the LH to secrete pulses. So that is how the pituitary is designed to actually respond to pulses. Whereas if I give it as a depot injection, you see a transient rise in the LH-FSH, but over some time, the pituitary hormones sort of tend to be undetectable. The LH becomes almost undetectable. There are 3 sorts of preparations available in India: leuprolide, triptorelin, and goserelin. Generally, endocrinologists use triptorelin or leuprolide. You can use either a monthly injection or a 3-monthly injection. There have been several studies which have said that 3-monthly injection is as good as a monthly injection. So to avoid the risk of multiple injection or avoid the pain of multiple injections, generally we give 11.25. It may need to be doubled with 22.5. I generally start with 22.5 mg if the girl is a little on the obese side, and then we can probably tone it down as per our response. The side effects, the only side effect they can have is a local depot injection, depot site reaction. But other than that, generally it is very safe. The girls are expected to have some vaginal bleeding because of an transient increase in the sex steroid before they go down. The boys can have a transient increase in erections. But other than that, they have extensively investigated about PCOD, weight gain, metabolic changes. There are some studies which shows that there have been some increased evidence of PCOD in these girls, and some studies which have said there is some weight gain in these girls during and after treatment, but some studies have not shown any changes. So there is inconsistent evidence. For bone mineral density, there is no evidence to show that it causes any reduction in the bone density. Menarche, usually this is one of the common questions that the mothers ask: will the periods resume? We have good evidence, and clinically we also see that within 1 to 2 years, generally the average is about 16 months as per the studies. Average of 16 months, the girls start having periods, and there is no effect on their ovulation or fertility. So in summary, the GnRH analog is a safe treatment. And monitoring, how would you monitor? You every 3 to 6 months, you check for height velocity development. You check an X-ray for bone age every 12 months, and you do the sex steroid and the LH only if required. Clinically, it's good enough to evaluate generally. And the duration of treatment is generally dependent on what the mother wants. Once we have optimized the height on the growth chart, and once the peers are starting to develop secondary sexual characters, we can leave it for the mother to decide, or an arbitrary age of 11 years for girls and 12 years for boys can be taken. Normal puberty resumes 12 to 18 months after cessation of treatment. So in summary, precocious puberty is a common condition that we see for girls who are less than 8 years and boys less than 9 years. We should have a very low threshold for treatment in early puberty, people who are not not precocious puberty, for height, because it's a safe treatment and we can maximize their height. Oxology, the height measurements and bone age are very vital in workup. The sequence of puberty is very vital to remember, because it will give us an idea whether it is a normal or an abnormal puberty. The clinical differentiators are important in finding out the cause of what is the cause for this puberty. The GnRH analogs are the only treatment available, and they're very safe. And with that, I conclude my talk. Thank you very much for listening. Dr. Jayasima, you're on mute, sorry.
Yeah. Thank you, Kalyan. It's a beautiful, nicely presented talk. And anybody who comes with precocious puberty, initial clinical examination is utmost important. Yes, with initial clinical examination, just you see what are the secondary sexual characters and what is the testicular size, particularly in male, and also simultaneously the breast and development of the pubic hairs, all those things in the female usually plays a critical role. Once we have evaluated clinically, then of course, as you have discussed clearly, that bone age is one of the important factors which should be done. Then subsequently, we should go for hormonal evaluation, do a GnRH stimulation test, and that GnRH stimulation test gives us idea whether it is peripheral or central. Of course, during clinical examination, particularly in the male, if testicular size is very less, then probably we are dealing with a peripheral precocious puberty. And if testicular size is good size and pivotal testicular size has already attained, probably we are dealing with a central precocious puberty.
Yes.
So, of course, again, we have clearly discussed that what are the causes, and majority time it is, particularly in female, it is idiopathic is the most common cause. Of course, In male, you might get some secondary causes or some malignancies or some tumor, anything you can get. But ultimately, these people respond well. If you are detecting early, if you are treating properly, then probably these people respond very well. We can achieve their adult height if you are detecting early. And the most important part is that as we have discussed, whether you are going to 3 months injection or 1 month injection, there is a school of thought that if you are going 1 month injection, probably if you are giving, when you are going for 3 month injection, at that time towards the end, probably the effect of GnRH is actually coming down. This is the reason why some people are going for 1 month injection, but studies has clearly shown there is not much difference between both the type of injections, whether you go for 1 month or 3 months injection. It is purely your convenience. So nicely presented, Doc. Thank you, Kalyan.
Thank you.
Kalyan.
Yes, sir.
Well presented. I have seen one interesting case of precocious puberty along with my professor, my teacher, Professor Rakesh Sahai, when I am doing my residence program. One skin exposure of the estrogens happened with a 6 years girl. How it is exposed is his grandfather used to work in a oral contraceptive manufacturing company in GD Matla, Hyderabad. He used to come with the same dress and he used to play immediately coming with the granddaughter. With exposure of that estrogen, so 6 years child got a peripheral precocious puberty.
Okay.
So interesting case, we reported in the journal also. And the grandfather has a gynecomastia.
Okay.
So the skin exposure of estrogen causing a precocious puberty.
Yes. Peripheral exposure. Interesting.
Kalyan, just a quick question. Is there monitoring wise, is there a biochemical monitoring that will help, sex hormones or the gonadotropins?
Yeah. So we can do a LH, FSH, and estradiol just before the next injection is due. Some people suggest a stimulator. So you just like what you would do in a patient who is naive, or before starting a treatment, you stimulate it with just a small LH injection, and then do a test 24 hours later to see if the estrogen is suppressed.
Yeah. The other way of doing it is also when you use the depot preparation, it has some amount of free LH. So that serves as a stimulus. So you do 2 hours after the depot injection.
You do.
Fine. Okay. So we get a it's like a stimulation test.
Okay.
Kalyan.
Yes, sir.
I have one query. Is it time for us to have super specialist clinics like, puberty clinics, or I don't know, or should all endocrinologists be treating all conditions? Should we have exclusive condition specific specialty now? Is it the right time?
It's always helpful, sir, but because we practice in Hyderabad where there are so many endocrinologists, I don't think we'll have much of all the endocrinologists do practice this precocious puberty, and it's very easy once you know the concept to treat it. So I don't think we'll get much success by putting a specialist. It's a good idea, but I don't think we'll.
Okay. Thank you. If there's no further questions, we'll go to the next topic. I think the next topic would be regarding short stature and growth hormone. Will be talked by Dr. Mohan T. Shinoy. He's a consultant endocrinologist at Sri Gurukulam Medical College, Trivandrum, Kerala, and he's editorial board member of Indian Journal of Child Health, ICJH, and he's a reviewer of Indian Journal of Endocrinology and Metabolism. And he has special interest in pediatric endocrinology and diabetes research. Over to Dr. Mohan Shinoy. Thank you.
Good afternoon, everybody. I hope I am clear, so I will share the screen.
Yeah, you're clear. Yeah.
Is it full screen now?
Yes.
Okay. Thank you, IdeaCon, for giving me the opportunity. I thank the organizers for the extensive endocrinology workshop, sort of digital workshop. So we are discussing next topic would be on growth hormone and short stature. So firstly, I have no disclosure to make. I don't have any shares in any growth hormone company, or I am not any ad board member. So the topic, how is it important in the modern scientific spectrum? now we are interpreting the stature as not only a personal and professional health, it's also important for our social backup and even later on for the sexual life. And basically it's also giving a well-being, because the self-confidence and the physical health that conferred by the height is one thing which we always have a lot of fascination about. So let me start with a case. So this is a child who was brought to me for evaluation of short stature. Usually we take a date of birth because that is the one way in which we know the exact age of the child. So biological age is 6 years and 8 months. And of course, he was brought because the parents felt he is short, and because the sibling actually had overgrown him. And the girl child 1 year younger than him is now taller than him and is now shortest in the class. No past history of any significant illnesses. His height is 102 centimeters. The corresponding age of the age would be 4 years according to the height age. And the weight is 24 kilogram. And I will show you the growth chart which I have plotted. The body mass index comes to 23.07. I will also highlight this in the growth chart. Look at the height of the biological height. That is, the father's height is 174 centimeters. Mother is 152 centimeters. The mid-parental height or the genetic potential is coming to 169.5. So this is the way we plot in the growth charts. Of course, now we have got mobile apps which do the same. So this is the mobile app developed by IAP, developed by Dr. Vaman Kadilkar and group, latest IAP 2015 chart. And you can see where the height is falling in. It's falling less than the 3rd centile. For the beginners, you can see that there is 3 zones mentioned here, 3rd, 10th, and 25th. And above that, we have the 50th centile, then 75th centile, and above that, 90th and 97th. So the child's height, according to this chart, is coming to below the 3rd centile. And you can see the target height plotted is also there. So besides the height, we also to mention the weight. In this, the weight comes to the 50th centile, nearby 75th centile. So also the BMI for the age, we show that it is actually in the obese range. So point to note is that in children, we have got the IOTF, that is the International Obesity Task Force recommendations. And we can see the weight has gained. That is why the height also is important to be measured. So we can just brush our memory regarding the IAP recommended cutoffs. So this child is belong to the 5 to 18 years age group. That is a revised IAP growth chart has to be used. And below 5 years of age, we are supposed to use the WHO IAP simplified growth charts, which is also having a comprehensive outlook. So we can see, according to the growth status, we are plotting the charts here. I'll just use the pointer. Give me a minute. Yeah. We can see underweight here, and it is less than 3rd. It is the weight. And we can see the height is what we are plotting here. That is less than 3rd. It is called stunting. And this is the way in which you calculate the probable areas. And we can also see the Z-score because it's a large population-based study and we have a shorter narrow ranges. That's why we used to use the normalized curves, that is the Z-score. So less than -3 means significantly bad. So I have already mentioned the reason why the BMI charts are important. The new IAP growth charts also depict the 23 and 27 as adult equivalent definitions for overweight and obesity, the same as that of the International Obesity Task Force. So dear friend, this is a clear case of endocrine short stature, but we have to also consider other conditions which may have a mimicking nature. The first, we have to also remember the familial short stature, and then the delayed puberty, which is not in this case, but generally as the spectrum is advancing, you have to remember all these spectrum. And small for gestational age group is also one thing we have to ask in the birth weight. In this case, the birth weight was normal, that is more than 2.5 kg. And the chronic illness, this is one thing we have to highlight because anemia, chronic illness, all the other illnesses like cardiac disease, GI tract abnormality, celiac disease, these are all silent in spectrum. Chromosomal anomalies and syndromic natures are also important in genetic short stature, and not to forget the bony dysplasias. For this talk, we'll focus on the endocrine aspects. So what are the factors you generally consider when the child is having short stature? The first and foremost is the genetic height potential. The second is the age of starting treatment. Any treatment, index of suspicion, age is very important. And then the next to consider is the pubertal tempo. There is a reason why we mentioned this because the girls catch up early because they have a puberty early, but they finally end up with a shorter height than the boys because the hormonal effect of estradiol is important. Next important is the psychosocial environment. The child has to have a proper nutrition, proper upbringing, and proper motivation to continue it. Next comes the familial finances. Of course, when you start treatment, you of course know that growth hormone is an expensive treatment, but financial aspect is also an important thing because we have also government sponsored schemes. Actually in Kerala, there are many schemes which have got government cooperation. Other comorbidities and growth factors have also been important. And finally, the peak growth hormone response to provocative test. I will mention in the next few slides. So what is the height velocity? So we have mentioned briefly the bone age and all these, but remember that height velocity is actually depicted by the Bateson's principle of the ICJP curve. By this, we mean the fetal life, the infantile life, the childhood, juvenile, and puberty. There is an interplay of various hormones across the lifespan. We can see human beings are one of the few creatures in the species which actually have a long childhood period. And this is the area where you have the influence of growth hormone or IGF. Of course, thyroid hormone is a universal all-rounder because it involves across the spectrum. And the adrenal androgen, because there is a mini puberty level in the infantile period, but definitely adrenal androgen period is definitely highlighted in the juvenile and the pubertal period. And the influence of nutrition, insulin is all important because this is an interplay. And in CAH, there is an influence of glucocorticoids. Definitely the previous speaker highlighted on the precocious puberty also. All these are an interplay between height velocity across the age point of the child. The schematic overview, because you have an erudite crowd here, not to highlight much, just to see that the growth hormone synthesized from the pituitary, circulated and in this bloodstream is actually having a binding protein. And beyond that, the receptor and post-receptor, there is a signal interpretation is also important. And there is a ternary complex because there is an acid labile subunit, IGF-1 binding, and the IGF-BP3. This is a complex which is very important because once the signal has been interpreted, the release of growth hormones follows a pulsatile pattern, and secretion depends on the way in which nutrition, sleep, and the sex steroids all interplay. So what is the growth hormone mechanism? The mechanism of growth hormone acts on 3 levels. The mainly the liver is through the IGF, that is the indirect effects, and then the muscle level. Muscle level is the peripheral action, that is by increased amino acid transport, increased protein synthesis, also influencing the glucose transport. So we all know that when the child is growing in puberty, there is also a risk that the child is having increased chance of developing pubertal synthesis. Another point is the adipose tissue, because there is a direct effect of adipose tissue because growth hormone deficient individuals have a different makeup than the growth hormone normal individuals. So what are the oxological criteria which demand urgent evaluation for growth hormone deficiency? The 3 main features are severe short stature, that is height less than 3 standard deviation, or when you have height less than 3 standard deviation with height velocity on follow-up over 1 year has a progression of less than 6 centimeter per year. And you can see height velocity also less than 2 standard deviation over 1 year, that is less than 10 centimeter per year is also significant. Any neonate with symptoms and signs of growth hormone deficiency or multiple pituitary hormone deficiency, or any child with cellular supracellular mass should urgently be evaluated for growth hormone deficiency, irrespective of this criteria. In addition, any other short child with all symptoms and signs of intracranial lesion should also be urgently evaluated. So with this, I also highlight the pathological short stature. We have to remember that upper limb, lower limb ratio is also important because chronic diseases most often have a proportionate short stature. I alluded to the chronic illnesses. They include the heart diseases, the chronic kidney disease, the chronic respiratory failure, as well as the celiac disease or GI disease. Malnutrition, of course, has got obesity as well as undernutrition. Both are also involved in the proportionate short stature. Chronic parasite infection. Remember that this infestation is also one thing we have to highlight because anemia can also be perpetuating. We are focusing on the endocrine diseases. Among them, growth hormone deficiency, hypothyroidism, and Cushing syndrome are the major highlights. They also include the pseudo-hypoparathyroidism, which is very rare as well. Genetic syndromes are coming into Turner, Down, Silver-Russell syndrome, and Prader-Willi syndrome. These are the main highlight classical spectrum of genetic diseases. Not to forget the psychological and emotional deprivation, also the SGA with failure to catch up growth. Regarding disproportionate short stature, we remember that there is a disproportion in the upper limb, lower limb ratio and upper segment, lower segment also. We can see that the achondroplasia is the prototype, also includes hypochondroplasia and spondyloepiphyseal dysplasia and mucopolysaccharidosis. These are known to have less response to growth hormone, but they are not sufficiently because they need genetic workup regarding this. And the highlight of this is also rickets because they need vitamin D substitution. So what about the baseline workup? The previous case scenario I described, we definitely have to have a full blood count, inflammatory markers like ESR, CRP, the renal function, that is creatinine, and abnormal bicarbonate is very important because renal tubular acidosis is one of the major reasons where you are chronic short stature. Hepatic function can be abnormal in celiac disease. We have to do celiac screening when you are in a population appropriate areas. Of course, in South India, there are very less incidents, but in North India, like Punjab and northern states, definitely celiac screen is mandatory. And thyroid function, basic medicine. Then you have to remember that bone profile, vitamin D, bone age, calcium, phosphorus, all important. Also to highlight, PTH may be abnormal in some cases like pseudo-hypoparathyroidism. IGF-1 in resource good settings can be used as a marker of growth hormone production because it requires an age-related reference range. I have taken this from a recent publication by Cheetham et al. It highlights the role of karyotype also as in any other cases. And this is the cranial MRI scan of a patient with combined pituitary hormone deficiency. We can see I've highlighted the small pituitary size, the poorly developed stalk, as well as the ectopic posterior tight spot. I am not giving much time to this because there is a lot of workup required in these cases. The previous speaker also mentioned regarding the hand bone age. This is a major reason why we are highlighting this. Advanced bone age is a feature in precocious puberty, whereas delayed bone age is a classic feature in hypothyroidism, systemic illnesses, then growth hormone deficiency, Cushing's syndrome, and constitutional delay of growth hormone puberty. Normal bone age can be seen in Turner syndrome, familial short stature, IUGR, and other syndromes, also with skeletal dysplasia. This is a very good book, Digital Atlas of Bone Age, which can be used in a very resource good settings as well. And bone age assessment, basically the previous speaker made my job easy. Dr. Kalyan also mentioned regarding the various zones. Actually, we did not discuss because we would have avoided this slide if that was already presented. Just to show you that we are comparing the degree of maturation of various epiphyses in X-ray with age-related standards. Of course, we have got Caucasian standards being used in various Grulich-Pyle atlases, but mere assessment and appearance of centers is a crude method because counting the carpal bones may not be even settings. But of course, when you have a skeletal maturity, we can usually use as a cost-effective tool, as a good easy method to assess the growth disorders, pubertal disorders. Serial measurement is essential for follow-up to assess the response to treatment. Also, when you have got a formula like Bailey-Pinot method, this can be used to predict the final height because delay in the bone age can reflect the delay in the disease process diagnosis as well. So computer-assisted softwares are also available because these are using digitized information. The tools are done by computer by artificial intelligence, and the methods used are computer-assisted skeletal age, CASA score, and bone expert score, which you can refer to in your future discussions. So what about growth hormone estimation? Growth hormone is a pulsatile hormone. It is having 4 to 6 pulses at night during NREM sleep and 3 to 4 pulses during daytime in post-absorptive phase. Therefore, random growth hormone levels may not be diagnostically useful in most situations, but they are useful when you suspect a neonatal growth hormone deficiency and growth hormone insensitivity. Value of less than 7 nanogram per ml in the first week with the classical symptoms can be suggestive of growth hormone deficiency in neonatal period, and the value of more than 5 nanogram per ml in presence of low IGF-1 is diagnostic of growth hormone insensitivity conditions. Etiology of growth hormone deficiency. Congenital is the most common thing. We are seeing the hypothalamic defects like septo-optic dysplasia, holoprosencephaly, pituitary dysfunction. These are all by genetic markers, PROP1, PIT1, LHX4, PITX2. Then the higher syndromes, type 1, type 2, and type 3 for the gene defects. Acquired conditions, of course, these are the ones which we can easily pick up by MRIs and other things, that cellular, supracellular tumors, by trauma, not to forget the meningitis and encephalitis and cranial irradiation and Langerhans cell histiocytosis. So what are the features? The features of neonatal growth hormone deficiency, basically they include hypoglycemia, prolonged jaundice, microphallus in males, and giant cell hepatitis. Its deficiency is congenital and complete. It is actually easy to confirm, but you have hypoglycemia, definitely initiate growth hormone treatment expeditiously to avoid further episodes, because early severe growth failure, delayed bone age can result in a lot of other consequences to the child. Very low hormones levels like GH, IGF-1, IGF-BP3 are also very important. This is the one which we are usually fond of seeing, but now there is a spectrum which is also seeing Indian phenotype of the classic features. The classical described cherubic face with fair complexion, with normal IQ, frontal bossing, mid-facial crowding with pallor, micropenis, truncal obesity has been described by literature. And sequence of anterior pituitary hormone loss. Remember that growth hormone is the one which is lost early, and as the time goes, thyroid hormone levels, ECTH, and prolactin level is the last to be gone. Presence of 3 or more defects associated with a low IGF-1 can be predicted as any of the other tests of provocative test. So coming to the next sector, which is evidence-based approach. So we are all using evidence-based practice. So growth chart is one of the major measures of which we are simplifying the approach in the small settings. And to highlight the 2016 Pediatric Endocrine Society guidelines, this has been published about 4 years back, and it's a wonderful literature. I will recommend you to go through when you have time in the future. So I've simplified the concept in this presentation by highlighting the influence of growth hormone stimulation and growth hormone provocative tests. And the presence of more than 2 tests is very important and mandatory to diagnose the short stature.
Sorry to disturb you, Dr. If you can accelerate and conclude the session.
Yes, I will take 5 minutes time. Exercise, levodopa, clonidine, arginine, insulin levels, insulin tolerance test, glucagon, LH, RHS are the main tests used. Yeah, and substantial number of healthy children have got values less than the accepted limits, and it can be blunted in obese individuals. And growth hormone as a molecule evolved across a lot of years. The first isolated by Chaw Hawley, and it has gone through a lot of spectrum, just like insulin has been derived. Highest efficacy is seen in growth hormone deficiency. These are the table of the approved indications of use of growth hormone. And biologically, it acts by promoting the linear growth in children by stimulating the cartilage in the epiphyseal plate. It's available as subcutaneous injection, administered at bedtime, ideally 8 p.m. to 9 p.m. And you should do every day. It's because of the short half-life. It is dose dependent as well. Growth hormone assays are very important, standardized, and this is the way the recommended assay to be used, 22 kilodalton GH isoform. And there is also a role of sex steroid priming for before you do provocative digest testing. This is the rationale for doing it because sex steroids have a major influence in the age group when bone age is more than 10 years of age. And it is done by using 2 milligram of beta-ethionyl estradiol, beta-estradiol, and dose of 1 mg when both body weight is less than 20 kg. Boys can be primed by IM testosterone of 50 to 100 milligram depot. And challenges to growth and short stature, because we have got a lot of challenges. The major challenge is the diagnosis. We have the spectrum like Turner syndrome, idiopathic growth stature, Prader-Willi syndrome, chronic kidney disease, achondroplasia, and mucopolysaccharidosis. Distinguishing them needs a firm diagnosis because follow-up is very essential. The dose, very important, just to have, you can have a screenshot because the organizers want me to speed up. This is the way in which we approach the standards. No one single size fits the same patient. What are the predictors of good height response? Younger age diagnosis, pick them early and catch them early. Greater deviation from the target height, more frequent, the feeder is better result. And monitoring requires IGF-1, specialized endocrinology visit, evaluation of compliance, adverse effects. And IGF level is the one which we use in the clinics when you have population-specific data. And IGF-BP3 is useful in younger children when you have got lesser influence by age, nutritional factors, that has good sensitivity, but no Indian data. When to stop GH therapy, when growth velocity is attained, bone age is crossed, when height is close to the target range, and when you have reached the adult growth hormone levels. And I will just speed up because I have no time, just to show a case of a Turner syndrome-like condition called SHOX haploinsufficiency being presented in international forum by me. And this way we had highlighted the SHOX deletion because unlike Turner, this is a different gene, SHOX gene in the Turner syndrome. And you also see that we have got a lot of criteria to follow up. The goal of treatment is to attain 75th percentile of the height velocity during catch-up. Another case was Russell-Silver syndrome brought to me for evaluation. Different criteria is also there. For want of time, I will not rush through this. Again, adverse effects of growth hormone therapy, just like insulin has adverse effect of hypoglycemia, the effect of growth hormone is producing metabolic effects. The antibodies to growth hormone also been described. Conditions like skipped fibrinolysis, fluid retention edema is also described. Very rarely we come across second neoplasm, and it's not described very commonly. And the safety workshop also highlighted that there is LOL, that there is very soft long-term safety of use. As recently as last month, we had got a publication from Lancet which highlighted that SAGE cohort study showing longest follow-up, which is having a good, less risk for developing all the cancer risk. Existing therapy has been modified now. The future may be once weekly therapy also. We are the result of REAL-1 study, which I was a part when I was in Amrita, is awaited. The challenges, I am highlighting only the red line, the incorrect technique, inadequate nutrition, unrecognized hypothyroidism, and wrong diagnosis. These are the major challenges when you have a community line setup. So concluding remarks from me, precision diagnosis, the prognosis depends on the diagnosis time. Younger age diagnosis helps the treatment, and adherence therapy ensure compliance and individualize the treatment targets. So I thank you for everybody for the kind listening, and also the organizers for giving me the opportunity. I shall be open to any questions. Thank you very much.
Thank you, Dr. Shinai, for a detailed talk. I'll just quickly invite Dr. Abhay Kumar and Dr. Srinivas Rao for the input. Or if any other questions.
Yeah, Dr. Mohan, excellent talk. Just wanted to check with you. How often how are you monitoring the growth hormone response? Response to therapy. Are you doing anything, or are you looking at IGF-1?
Yes, sir. Basically, we follow up by growth charts only, 3 monthly growth charts or 6 monthly growth charts. IGF-1 we do intermittently, around 6 monthly gaps usually, because the resource, it costs a lot and requires age-specific cutoffs as well. And IGF-BP3 when we can do when we have got an age less than 3 years, less than 5 years or less. That's what we usually do. Basically, okay. The improvement in bone age can be also take time up to 1 to 2 years as well.
Okay. Do you see any disparity between the clinical response versus the IGF-1 response?
Yes,
in the
sir.
sense
That's what. The clinical response, the height centile change also, that's what height velocity, height centile, there is a small disparity that's also described, sir.
Because there could be some children who are growing well, but their IGF-1 levels are low. And then you're happy with that. You don't want to really chase the IGF-1.
Basically, the metabolic profile is very important, sir. That's the way in which improves, sir. We have to check the thyroid hormone levels every time when the patient is coming for follow-up as well.
I think that's a very important point that we need to remember to check all the thyroid profile and other aspects. Thank you. Thanks for the.
Thank you, sir.
Okay. Thank you very much, Dr. Shinai, for your talk. I think we'll move to the next topic. That's parathyroid journey over time by Dr. Siddharth Chakravarti. Okay. Thank you. So it's a talk about parathyroid, a journey over time. Dr. Siddharth Chakravarti is a consultant endocrine surgeon specialist in endocrine and breast surgery at Apollo Hospitals and works with Idea Clinics, Hyderabad. He's consultant in the Department of Endocrine and Breast Surgery at CMC Vellore from 2015 to 2018. He specializes in scarless thyroidectomy and retroperitoneoscopic adrenalectomy. He has numerous publications and presented papers at various national and international forums. Thank you, Dr. Siddharth, for joining us. Over to you. Thank you.
Thank you, sir. Good afternoon, everybody. I hope I am audible.
Yes, you are audible. Yeah.
Okay. Just a second. Yeah, I am Dr. Siddharth. Thanks, Idea Clinics, and thanks, Dr. Rakesh Rai sir, Sudhakar sir, and Dr. Sham for giving this opportunity. Primary hyperparathyroidism, a journey over time. As described by Fuller Albright, it's a disease of bones, stones, and growths. This is the outline of my talk, introduction, the definition of primary hyperparathyroidism, the biochemical diagnosis. We'll discuss about the causes and the differential diagnosis, then the clinical management, treatment, focusing more on surgical and also medical management. Calcium is an important element in our body, and the hormonal mechanisms keep the serum calciums within the normal limits at all times under homeostatic conditions. So if you look at the normal calcium level, it varies. This is the if you look at the normal calcium level in an individual, it varies from 8.5 to 10 milligram per deciliter. But within an individual, the spectrum is very narrow, as you can see this in the dark blue. So defined primary hyperparathyroidism is a syndrome characterized by excessive secretions of parathyroid hormone that leads to hypercalcemia. And primary hyperparathyroidism is the most common cause of hypercalcemia. Coming to the diagnosis is mostly by biochemistry. The calcium is above the upper limits of normality, and the parathyroid hormone is also above the upper limits of normality. There are certain surrogate biochemical markers like hypophosphatemia, elevated alkaline phosphatase, and elevated calcitriol. Looking at the causes of the primary hyperparathyroidism, 80% of the times the patients have a solitary benign parathyroid adenoma, whereas 15% of the patients can have parathyroid hyperplasia, wherein you can have multiple parathyroid, sometimes 4, even 5 and 8 hyperplasia. It is seen in only 15% of the patients. Rarely you can have multiple parathyroid adenomas, and also occasionally you will get parathyroid carcinoma, which is seen in 0.5 to 1% of the patients. And most of these are sporadic. Some are familiar, then they are associated with hyperparathyroid jaw tumor syndrome. This graph depicts the differential diagnosis of primary hyperparathyroidism. On the x-axis, you have the blood calcium in milligrams per deciliter. On the y-axis, you have parathyroid hormone levels in picograms per ml. If you look at this, is the blue one is the primary hyperparathyroidism, where the majority of the patients have a mildly elevated calcium levels and mildly elevated parathyroid hormones. But in clinical practice, we do see certain patients who have high calcium levels and the parathyroid hormone levels are minimally elevated, and vice versa. You can have similarly, you can have a high PTH hormone and mildly elevated calcium. Another important differential diagnosis is vitamin D deficiency, wherein the calcium levels are normal, but the parathyroid hormone levels are mildly elevated. The one in the pink here is because of malignancy, wherein the calcium levels are quite high, but the parathyroid hormone levels are low. This is a very severe type of hypercalcemia. Here, the cause is the PTH hormone-related peptide, which is the cause in 80% of the patient, and the 20% is because of osteolysis, and rarely you can have ectopic production of PTH. The one in the blue is the renal failure. Here, the parathyroid hormone levels are markedly elevated, but the calcium levels are within the normal limits. Now, this there's an entity called familial hypocalciuric hypercalcemia. It's a rare and a challenging, rather, it's also called as a troublemaker. It's an autosomal inheritance of inactivating mutation of the calcium sensing receptor, wherein the threshold for calcium is high, and this high calcium level is required to maintain the homeostasis. These patients have hypocalciuria, and they have mild hypercalcemia, and they can have a normal PTH or slightly elevated parathyroid hormone. This is diagnosed by checking the calcium creatinine clearance ratio, and if it is less than 0.01, it is diagnostic of familial hypocalcemic hypercalcemia. Is this familial FHH disease? The answer is no. These are normal individuals like you and me, but they don't need any particular surgical or medical intervention. If you look at the primary hyperparathyroidism in the United States or in the West before 1970, as described in the NEJM 1966, primary hyperparathyroidism was a rare and very dramatic disorder of the calcium metabolism. The disease was present for several years, even before the diagnosis was made. So he's Captain Charles Martel, a New York Sea Mariner, 6 foot 2 inches, and and he suffered with the primary hyperparathyroidism. and he had 6 failed cervical explorations for parathyroidectomy. He was an avid reader. He went to the Harvard library, read extensively about parathyroid, and told the surgeon that my lesion is in the mediastinum, and they explored his mediastinum, found the lesion, and cured him of primary hyperparathyroidism, but he subsequently succumbed to urosepsis and laryngospasm. So unfortunately, in India, we do still see these patients. This is one of our patients from my previous institute in CMC Vellore. She is the patient, and this is her mother. Look what the disease has done to this young lady who is hardly 42 years old. So looking at the end organ toxicity, if you look at the skeleton, what you see in this is the osteolytic lesions. These are not because of metastasis, rather these are called the brown tumors. In the skull, you have a what is this? This is called a salt and pepper appearance because of increased bone turnover. In the clavicle, you can see there's a distal resorption of the clavicle. This is called the pencil sign. When the bone mineral density was first, the DEXA, when it was introduced in the late 80s, the parathyroid hormone, as you know, affects mostly on the cortical bone. And the radius constitutes, the distal third of the radius is predominantly made of cortex. The femoral neck is a mixed cortical and a trabecular bone. And the lumbar spine is predominantly a trabecular bone. Initially, they thought that it is protective in the lumbar spine and femoral neck, but later they realized that it has catabolic effects definitely on the cortical bone. It also damages the trabecular bone. Like you can see in this extreme CT, the high resolution CT, the left you see the matched control, and on the right you see a primary hyperparathyroidism patient. Here the cortex is thinned out, but also the trabecular are destroyed by the hyperparathyroidism. If you look at the kidney, the patients will have hypercalciuria. Around 60% of the patients can have renal stones, nephrocalcinosis, reduced glomerular filtration rate, and they can go into renal failure. Other manifestations of this primary hyperparathyroidism, you can have gastritis. Occasionally, patients can have pancreatitis. And currently in the West, the common symptoms are these neurocognitive features, and the rest are coming down. And you can even have cardiovascular disease. So after 1970, then in the West, they have started using this multi-channel auto analyzers, and everybody was being screened for calcium. So what happened after this, more and more asymptomatic patients started increasing, and the bone disease has started come down. Initially, it was 57%. In the West, it has come down to 17%, but in India, we still see around 36%. This is from SGPJ, and this is from CMC Vellore. Around 31% of the patients have. If you look at the overt skeletal disease, in the West, it has come down to 1.4%, but in India, we still see 46 to 77%. Asymptomatic disease, which has become more common in the West, the 80% of them is asymptomatic, but here we less than 10% of our population, we see the asymptomatic disease. Now, with the advent of this multi-channel, there are 3 phenotypes which have come. One is symptomatic primary hyperparathyroidism, which is more common in India. And then you have this asymptomatic primary hyperparathyroidism, and in centers of excellence where they have bone, where they study extensively on bone and do the parathyroid hormone, they have an entity called normocalcemic primary hyperparathyroidism. So they looked at the mortality in an asymptomatic disease patient with PHPT, and they realized that patients who have mild hypercalcemia, the mortality is normal compared to the general population. And even if they look at the bone mineral density of asymptomatic primary hyperparathyroidism, the first 10 years, the bone mineral density is not affected much. But later they have realized that in the distal 1/3 of the radius, femoral neck, and the lumbar spine, there's a drop in the bone mineral density. So around 37% of them over the period of 15 years developed the indications for surgery like hypercalcemia, hypercalciuria, or reduced bone mineral density. But still, following up these asymptomatic patients is a very good option. So who are the patients? Whom should we operate in this asymptomatic hyperparathyroidism? There was an international workshop conducted by Bill Zikian in 2013, and then they said asymptomatic patients with serum calcium of more than 1 milligram per deciliters, or if they have a 24-hour urine, if they have a creatinine less than 60 cc per minute, or if they have renal stones, or if the patients have are osteoporotic with a T-score of less than 2.5, then you should consider them for surgery. Now, as you can see, till now we have not discussed any role of imaging. The role of imaging in primary hyperparathyroidism, like all endocrine diseases, comes only after diagnosing the disease. So now when you look at the localization, you have ultrasound, you have Sesame B, you have 4D CT scan and choline PET CT, which is available in Apollo Jubilee Hills, but it is still evolving. And then also we'll discuss about the surgery. So the dictums for surgery, as said by Dopeman in 1977, the best localizing technique is to locate an experienced parathyroid surgeon, and that still holds true. And if you have failed to prepare, be prepared to fail. And the procedure varies from usually an embarrassing simple adenomaloma excision, which can be finished in 22 minutes, to a less commonly a frustrating search for a missing gland. So if you look at this, it's a 90-minute scan of the Sesame B. You can see that the MIB is retained in the parathyroid gland. And then there's an ultrasound image showing the same lesion. If the lesion is concordant, that means the lesion is seen both in Sesame B and the ultrasound, then the chance of cure is more than 90%.
Dr. Siddharth, you have 5 minutes left.
Okay. Then you look at the preoperative localization studies. There are several, that ultrasound, scintigraphy, and 4D CT, but the sensitivity of 4D CT is increasing, and it is around 70 to 90%. This is one of our patients who, when her ultrasound and Sesame was negative, but we did a 4D CT, which is, you can see the lesion here. But the problem with the 4D CT is it has increased radiation exposure around 28 millisieverts, whereas the scintigraphy has 12 millisieverts. But whenever you're using this 4D CT, you have to be judicious with regards when you're using it in a younger age group. But in an elderly group, the relative risk of them developing cancers due to the stochastic effect is minimal. Looking at the surgery during the 20th century, surgery in the conventional approach, the standard was to open the neck with a large incision, look for all the 4 parathyroid glands, and take out the one which was abnormal. But it is associated with increased hypocalcemia and voice change. And now, currently, what we do in the 21st century is the minimal invasive approach, where the lesion is concordant. You just go make a small incision, 1-inch incision, and it's a 22-minute procedure, can be done under local anesthesia. And we use the intraoperative adjuncts like IOPTH. And if the IOPTH drops from 50% of the baseline value, then it is most likely cured. And occasionally we do use frozen biopsies when there is suspicion. This procedure can be done under local anesthesia too. When you have a parathyroid hyperplasia, you have to do the standard approach, look for all the 4 parathyroid glands, do a subtotal parathyroidectomy along with cervical thymectomy, because 20% of the ectopic parathyroids are located in the thymus. Now, what happens with the impact of the successful surgery? Definitely the calciums will come down. The parathyroid also hormone should come down after the surgery. When you look at from an objective perspective, if you follow up these patients, the x-axis is showing the number of years and the change in bone mineral density on the y-axis. You can see that the bone mineral density after 1 to 2 years has improved in all the parts, like in the radius, femoral neck, and the lumbar spine. Will it have an effect on decreasing the risk of the fracture risk? Yeah, definitely. If you look at this complicated graph, after the surgery, there is a drop in the relative risk for fracture. An impact of the surgery on the kidney, it decreases the rate of renal stones by 90%, improves the glomerular filtrate, reverses the osteitis fibrotica, cystica, and disappearance of neuromuscular and neuropathic symptoms. looking at the medication is only for patients who are unfit for surgery or patients who are unwilling for surgery or metastatic parathyroid carcinomas. There are several drugs available like estrogen, raloxifene, cinacalcet, and bisphosphonates and denosumab. Currently, the drug which we use is cinacalcet, but cinacalcet doesn't have decreases the calcium but doesn't change the bone mineral density. But cinacalcet, when combined with bisphosphonate, particularly the alendronate, it increases the bone mineral density too. So when we looked at the study, when they started using the cinacalcet, the calcium level has dropped, but in the placebo group, the cinacalcet, placebo group, there was no drop in the calcium. And when they did the crossover study, by using the cinacalcet, the calcium levels dropped again. So this is a short our experience in Apollo Jubilee Hills in my current institute over the past 1.5 years. We have done some 27 cases. The mean serum calcium was 11.62, PTH is 422. The BMD in the spine is -2.1, and the mean BMD in the radius is -3.32. As you know, that it is affects the distal 1/3 of the radius. And the mean weight of parathyroid is 3.5 grams. We had 4 atypical parathyroid. To conclude, symptomatic primary hyperparathyroidism is still common in developing countries. The surgical and medical approaches to this disease have changed, and PHPT is a very interesting and sometimes a challenging condition in the clinical practice. Thank you.
Thank you, Dr. Siddharth, for taking us through the journey of parathyroid with very interesting updates as well. I'll welcome any questions and comments from our chairs.
Thank you, Dr. Siddharth. It's a nice presentation. So, in hyperpara, how many cases you have in your series? How many cases you are having hyperplasia, parathyroid hyperplasia, not adenoma?
Yeah, currently we have 2 patients with hyperplasia, sir. Both of them had MEN2A. So, in these patients, when we use the IOPTH, when we after excising the largest one, the IOPTH dropped from 200 to 150. And after excising the 3.5 glands, the IOPTH dropped to 20. And she's cured for the primary hyperparathyroidism.
Yes. And is that there, have you followed up this BMD after actually this removal of surgery? Have you did follow up BMD?
Currently in our study, I mean, we have had 6 patients on follow-up, but they haven't completed the 2 years. I mean, all the 6 patients out of them, 4, it is static. I expect probably it will improve in 1 and 2 years. And it is too early. Maybe in 2 years down the line, I'll be able to present the data. But we do follow up after 6 months, 1 year and 1.5 years, and 2 years. We ask them to do bone mineral density for all the patients.
Yeah. Have you given any anti-disruptive agents in those groups? Any percent?
Which one,
after surgery? Any anti-osteoporotic agents given to any of the patients after surgery?
No, sir. I don't. I have not. I mean, my endocrinologist here, I think. Post-op complication that we have is hypocalcemia, but we try to look at the bone mineral density of the patients. If it is in the osteoporotic, significantly osteoporotic, like -5 and none, we anticipate these patients will have hypocalcemia. Prophylactically, post-operatively, we start them on Rocaltrol, sometimes 0.25 milligrams BD or sometimes 0.5 BD and with high calcium, and maintain them. Fortunately, we never had to give them any IV calciums now.
Okay. Thank you.
That angry bone syndrome, what is your experience of angry bone syndrome after surgery?
Sir, in Vellore, we remember, I remember quite a few patients we seeing hungry bone syndrome, sir. Their BMD was -6 and all. So only one patient that I remember very vividly, we had to give him IV calciums for 6 days, I think. 5 to 6 days he was on IV calciums. But otherwise, with the oral calcium, Rocaltrol and calcium supplements, most of them won't need intravenous calciums.
Siddharth, as a surgeon, your experience of parathyroid carcinoma?
Yes, sir. We have operated. I mean, we have operated couple of, 3 patients in Vellore that I remember that I had operated, and over a period of 8 years, we have some 22 cases in Vellore. Here we have operated some patients in Apollo Jubilee Hills, like operated outside, and the patient had parathyroidomatosis. It's a rare quantity when you breach the capsule of the parathyroid while operating. These parathyroid seedlings can recur. So we have operated on these patients. 4 of our patients had atypical adenoma, sir, but none had carcinoma here in Jubilee Hills.
So that what the prognosis, follow-up prognosis, this thing, carcinoma, parathyroid carcinoma?
Carcinoma, sir, so parathyroid carcinoma, it's a very difficult entity to manage if it is metastatic. The options are very minimal, and it is very difficult and traumatizing to treat these patients. If it is non-metastatic and on table, if you have a doubt of parathyroid carcinoma, what we suggest is to do an en bloc resection, probably hemithyroidectomy, and also ipsilateral neck dissection. So on table suspicion, whenever you have, you should be aggressive. And also there are certain markers, like if the size of the tumor is more than 4 centimeter and the pre-op PTH, if it is more than 1000, then there's the suspicion for carcinoma should be high.
Nice presentation, Siddharth. Thank you for presenting.
Yeah, I think there's no further questions. I think we'll conclude this session. Thank you, Dr. Abhay Kumar and Dr. Srinivas for chairing this session. And we'll be closing the session. The last talk in this session would be done at a later time. Thank you. Thank you.
Thank you, Dr. Abhay Kumar. So we are going to quickly go to the next section, for which I am privileged to have Dr. Ganapathy Bantwal as our chair for the next session. He is a professor and head of Department of Endocrinology at St. John's Medical College in Bengaluru. He's also the president of the Endocrine Society of India. He is an avid researcher and has numerous publications to his credit. He has several oral and he has several orations and awards to his credit. He's been an examiner in endocrinology for all the universities across the country. We're very privileged to have you, Dr. Ganapathy Bantwal. Please allow me to join you. Thank you. And we also have Dr. Akhil Saeed as the moderator for this session. Dr. Akhil Saeed is a consultant physician and clinical lead in Department of Diabetes Endocrinology at Salford Royal Hospital in UK. And he's an honorary senior lecturer who has published over 100 research articles. He's a peer reviewer of many well-known international journals. His clinical research and interests include obesity and bariatric surgery. So our next stop will predominantly focus on obesity. And Dr. Saeed, I just want to brief you about a brief change of the lineup of the talks that we have. It will be Dr. Wasim Hanif who will be starting the talk, followed by Dr. Rajendra Kumar, and then Dr. Mihir Prasad and Dr. Gautam. So I'll put up Dr. Wasim Hanif's talk, and then I'll leave you to moderate the next session. Thank you, Doctor.
Thank you. Yeah, I think the first talk will be by Dr. Wasim Hanif. So he'll be speaking on how much is too much, ideal weight for an Indian. Let me introduce Dr. Wasim. He's the professor of diabetes and endocrinology, consultant physician and head of service in diabetes at University Hospital, Birmingham. Research specializing in diabetes management, diabetes kidney disease, diabetes prevention, and the management of diabetes during Ramadan. Professor Hanif's research on diabetes is widely published. He's been involved in several multi-center trials as a principal investigator and helped to set up the United Kingdom Asian Diabetes Study. He's been the chairman of Diabetes Working Group of South Asian Health Foundation. Is a member of European Policy Forum on Diabetes, advising EU. He's a part of the NICE Health Technology Appraisal Committee 2009 to 15. He's had several international projects in the IDF WHO Global Policy Forum on Diabetes. He's a strategy for Wealth to guide ministers at the UN Summit. Over to Dr. Wasim Hanif.
Thank you very much, Dr. Bantwala. Let me just share my screen.
Yeah, we can see it.
You can see my screen. Can you hear me clearly?
Yeah.
Yes.
Yes. Yes.
Yes. Okay. Thank you. Thank you very much to Rakesh and Shyam for this kind invitation, and thank you very much for the organizing committee to give me a chance to speak. So today, what I'm going to be talking about is probably taking a slightly different view about obesity in a kind of an Asian Indian population, and trying to explain what is the reason or rationale behind it. So this is something we published about 4 years ago, and this was basically what we are trying to see was the number of patients of South Asian origin in cardiovascular outcome trials. So this was a kind of a global meta-analysis. And what we found was we identified about 12 studies, but generally the representation of South Asians or people from the Indian subcontinent was extremely low. Now these cardiovascular outcome trials are the ones that have really guided us to make the guidelines in terms of managing people with diabetes across the globe. So just hold that thought for a second. My good friend Salim Yusuf, I really liked this quote of his, and he said that obesity is a normal response to an abnormal environment. And that is what we are actually seeing globally. One of the things I tell the medical students, why cows eat grass? Because it is there. Similarly, humans are eating food because we have got a plenty of it, especially in the West and now even in parts of India. So we're carrying more weight than we should. So the question comes in, and this is something for us all to reflect, is what is a normal BMI? And this is a very difficult thing because it's a variable, and the normality is actually decided by what 2 standard deviation is for most of the population. So if you look at the median BMI of newborns in the US, it is 13. For 16-year-olds is 16. For an adult male in 1900 it was 21. Now it's gone up. In rural Bangalore, it's about 19.5, and in the Onkring study in China, it was 19. So what we are finding is that when you're born, you don't carry much weight. But now we're considering a BMI of 25 to be normal in a Western environment. And this is something for us to really think and reflect about. But when we talk about obesity, I think we need to understand this J-shaped curve. And a lot of people actually, and some of the endocrinologists tend to focus on the other side of the curve, which actually shows that as your BMI starts going above 25, your mortality tends to increase. But we also need to focus on the fact that if your BMI starts going by 18, your mortality actually increases. So somebody with a BMI of 18 has got the same mortality as somebody with a BMI of 30. So it is a J-shaped curve. And in this J-shaped curve, what we call an ideal BMI is a very narrow range between, say, about 19 and 25. And it is something which is very difficult to maintain. You all possibly know this classification of obesity. But the important thing, what I'm trying to focus is, and this will become clearer when I start showing the data from a South Asian Indian concept, is the current definition for obesity. Normal is 18 to 25, overweight 25 to 30, greater than 30 is considered obesity, and then you have got 3 class 1, class 2, and class 3. Now, each of the obesity classes actually produces different or increases the risk for different complications. If you focus on obesity class 3, that is where you get most of what we call the complications of obesity. And we know all these complications of obesity. Now, from an Indian concept, if you really want to think about obesity as an issue and want to tackle it, you have to look at the metabolic consequences of obesity and mostly type 2 diabetes. The reason for that is that if your BMI is going to be 35 or probably 40 or over, that is when you are going to start getting the musculoskeletal concept, osteoarthritis. Although OSA tends to happen in lower BMIs, but it's the higher BMIs which produces these complications. But for the metabolic complications, especially from an Indian context, it can happen at lower BMIs. So this is, I always say this to Yajnik, that if this picture, if he got a pound for every time this picture was shown, he would be a millionaire by now. So, but this actually illustrates the concept of body fat. These are two things. One is Professor John Yudkin from London and Ranjan Yajnik from Pune. They have somehow similarly BMI, but if you look at the body fat percentage, Yajnik, even at a BMI of 22, carries much higher percentage of fat. Now, this is a study which we published from Leicester, and this is actually looking at your risk of developing diabetes. So principally, we're looking at diabetes, comparing a white European with a South Asian population. And what we find is your risk of developing diabetes for a South Asian man at a BMI of 22.6 is same as for a European man with a BMI of 30. So this is just showing that the risk for a South Asian person starts at a BMI of 22. Now, this is a thin database. So this is one of the largest primary care database, and this is the analysis which we actually did to look at the risk of developing diabetes depending upon the mean BMI across various ethnicity in the UK. And again, what we find here is that when it comes to South Asians, the BMI for people with type 2 diabetes is much lower. It's about a mean of 29 when compared to 32 for white Europeans and 31 for Afro-Caribbeans. Again, suggesting South Asians get diabetes at a lower BMI. Now, this is again a very interesting study from the same group. And here we actually look at classification of obesity according to ethnicity. So this is overweight, grade 1 and grade 2. And what is very interesting here is that when you look at people of South Asian heritage, once you go to grade 2 obesity, that's BMI of 35 or 40, the percentage becomes much more smaller. And most of these people with high BMIs in South Asians are shorter. So they don't carry a lot of weight when compared to other populations. Again, suggesting that obesity in South Asians is not about a huge amount of weight, but a less amount of weight. And then its consequences, mainly type 2 diabetes. So this has brought into this concept, which is extremely fascinating, I find, what we call normal weight type 2 diabetes. And this is the data from the United States. And this actually shows that if you look at the number of patients with normal weight prevalence of diabetes, what we find is that the highest prevalence of normal weight diabetes is found in the Indian subcontinent, again suggesting people of Indian subcontinent, again suggesting that this is an important issue. And this again is again from our analysis actually showing that along with increasing age, your BMI tends to increase, and at a BMI which is much lower than the white Europeans, your risk of developing diabetes tends to increase. Now, when we talk about obesity, normally we have associated obesity with type 2 diabetes, which is true. But when you actually look at the genetic models or the SNP analysis of obesity, what we find is there is a lot of discordance between obesity and type 2 diabetes, suggesting there are only few genes which code both for obesity and type 2 diabetes, but most of the genes that code for type 2 diabetes are different from those that code for obesity. And this is something for us to think about. So what is the difference that we are actually seeing, and why is this happening? And this is to do with what we call the adipocyte cell size. So in this in a South Asian person, the size of the adipocyte is very big, and this is actually all stuffed with the triglyceride. So this is what we call the hypertrophy of the adipocyte cell. While in the Europeans, the size of the adipocyte is small, but they have loads of it. So this is hyperplasia. And the reason why this is important is because the adipocyte are less and they start getting bigger, you get what is known as the fat overflow hypothesis. The South Asians as a concept don't have a lot of subcutaneous tissue to actually store fat. So the envelope gets fatter, so the fat starts getting stored at lower BMIs in wrong places. And as you probably know, probably one of the worst places for the fat to be stored is in the viscera. So the fats get stored in the viscera, and some of the fat actually starts getting stored in the liver. And this is where you get NAFL, and also the consequences of metabolic disharmony, causing increased insulin, glucose, triglycerides, leading to type 2 diabetes and coronary heart disease. So this is what's happening. So there is not enough fat storage, and the fat is getting stored in the wrong places. So if the fat is getting in the wrong places, what is actually driving it? Now, one of the factors, and this is very important when we are actually planning to treat people of Indian origin for obesity, and especially with regards to type 2 diabetes, we also need to start thinking about what we call the beta cell dysfunctions or low mass of C-peptide. And this is a very interesting study published in Diabetic Medicine. It actually shows that most of the Indians would come in this category of what we call normal weight type 2 diabetes. And in this group of population, if you look and compare two factors that contribute to type 2 diabetes, one is insulin resistance and one is less of beta cell dysfunction C-peptide, what we find is less of the C-peptide is more statistically significant in terms of the causation for type 2 diabetes than insulin resistance. Since then, there have been a number of publications from across the globe and some from Mohan's group in Chennai. And all of these have actually suggested the evidence of reduced beta cell dysfunction in Asian Indians with mild dysglycemia. And again, suggesting that the beta cell dysfunction is something which is very important and needs to be considered. So this is what I call so if you look at the reduced beta cell function in Asian Indian with mild dysglycemia, what it becomes clearer is even at a stage of impaired fasting glucose, although HOMA-IR is not there, the beta cell dysfunction actually starts. So it is starting at a much earlier phase in physiology. So this is what I call the tale of two Indians. Now we have been told the tale of the Pima Indian, which is the prototype that we have used for a long time in terms of our understanding of type 2 diabetes. But there is another prototype, the Asian Indian or the South Indian or the Chennai Indian. And these populations have got a different prototype. Let me just try to explain. So if you look at the prevalence of type 2 diabetes in both the prototypes is very high. It's about 50% by the age of 55 years. But if you look at obesity, in the Pima Indians, they're very obese. The mean BMI is 33. This is the classical Western description of type 2 diabetes. But in the Asian Indians, they're very thin. Their BMI is about 25. If you look at the glucose profile, the Pima Indians, it's higher mean 2-hour plasma glucose. while the Indians have got mean fasting plasma glucose that is elevated. If you look at the pre-diabetes distribution, nearly 2/3 of the pre-diabetes is IIGT, while in the Indians, its pre-diabetes is IIFG. And if you look at the insulin resistance is about 4 times higher in the prima Indians, while in the Indians, it is more to do with insulin secretion. Now, this is some of the modeling that has been done, and I probably need to focus on class 3, which represents a distinct and unique pattern with second highest peak in 30 minutes postprandial blood glucose, but low fasting plasma glucose and 2-hour plasma glucose. And in this group, which represents this one, you find that the glucose burdens during an OGTT being very important, and this is what is here need to be studied. Why is this important? So when we talk about lifestyle intervention for type 2 diabetes, and we have seen the data from Indian Diabetes Prevention Program, and also from the DREAM study, and what these data actually show is that the lifestyle perhaps doesn't work that well in the Indians. Or probably it works as well as, say, metformin. There could be a number of reasons for that, but one of them could be the speed of this function. So if you look at this meta-analysis from DREAM with rosiglitazone, and what you find is in the Indian population, it had a greatest effect in terms of reducing the progression to type 2 diabetes. So why is this important? So if you look at BMI subjects with impaired glucose tolerance, impaired fasting glucose, and diabetes mellitus in red line, and lowest quartile or 120 minutes glucose in green line, what we find is that those who went to develop diabetes became obese related to themselves. So this is very important, obese related to themselves. And those who went on to develop diabetes also have a poor beta cell function. So these are 2 important factors to understand that these patients are obese not because of a definition, but they're obese to themselves, and they also have poor beta cell function. The other important issue is to talk about the muscle strength. And this is, again, something that has been ignored for a very long time. So when you're trying to deal with obesity, it is not only the fats, but it's also the muscle strength. And again, in this study, what it becomes clearer is when it comes to the muscle strength or the grip strength, the South Asians have got the lowest. Again, in terms of physical activity, there is now the recommendations that have come is that with the same BMI, you probably need to do nearly double the physical activity to prevent your risk of developing diabetes. In the last few slides, what we're going to talk on is we are what we eat. Now, one of the big focus that has come in lately is in terms of carbohydrate consumption. And this data from SHARE actually shows that when it comes to South Asians, they have got the highest consumption of carbohydrates. Not all carbohydrates is bad, but the amount of carbohydrate that is consumed is the highest when you even compare it to the Chinese, who again have got a large carbohydrate in their meals. And again, if you look at the protein consumption in this population is the lowest. So why is this all important? So we have had this amazing publication from Roy Taylor and Mike Lean's group. I was on one of the committees that gave $5 million for this project, and this actually showed that if you put people on a 900 kilocalorie diet, what we call low-calorie diet, stop the diabetes medications, give them what is known as the shakes and soups diet, then you can actually reverse diabetes or cause diabetes remission in patients who lose 15 kilograms in weight with weight of 86%. Now, when we talk about a study like this, and we stop, because in this study there were no Indians or South Asians in the UK. Now, we had a number of discussions with the Roy Taylor group about how this could be translated in the South Asian concept. We even designed a study called Disha to actually look at a South Asian population. The reason why it is important is that what should be the BMI cutoff in South Asians? So are you going to ask a patient with a BMI of say 25 or 23 when the risk of developing diabetes is as high as somebody of white Europeans with BMI of 30 to lose 15 kilograms in body weight? And if they lose it, what the consequences will be? So these are some of the very difficult questions to really answer about weight loss in an Indian context. And this becomes even more when you're trying to define the cutoff target. So this was a nice committee I was involved in. And there is very little data, very little research for us to decide what is the cutoff at which you should recommend bariatric surgery from a South Asian context, because most of the recommendations are based on the research that comes from the West. So this brings in this lovely paper from Venkat Narayan, and it actually shows the issues with type 2 diabetes, or what we call the heterogeneity of type 2 diabetes. So there is the metabolic load with type 2 action caused by decreased insulin action, adiposity, physical inactivity, dietary factors. It's diagnosed by 2-hour glucose, and it's lifestyle and metformin. And the classic ethnic group is Pima Indians. The second group, which we have to start recognizing, is decreased metabolic capacity, which is caused by decreased insulin secretion. The causes are unknown. It could be poor maternal, child malnutrition, epigenetics, lipotoxicity, microbiomes, reduced beta cell mass. This is shown by fasting glucose and perhaps by 30-minute glucose. Initial treatment is lifestyle, but you've got to rely more on secretagogue, gliptins, and perhaps even insulin. And the classic ethnic groups is Asian Indians. Now, the last 3 slides is just for you to reflect about why we have got this discordance, the advice and the guidance that is coming from the West. So this is the world population in the map, and you could see where the most of the world actually lives in Asia and around in this patch of what we call the Indo-Chinese belt. And if you look at the total underweight children, they are actually again found in this part of the world, and most of them are around in the Indian subcontinent. But if you look at the total, and then if you look at the total number of diabetes, this is the area that has probably got the highest prevalence rates of diabetes. But if you look at the world by cohort publication, what you find is that the most of the research and publications is actually coming from the West, which is guiding the therapies and the guidelines and the practice that is followed in these countries. And therefore, it is very important for us to start reflecting and thinking as to how we can change and reflect that. So there is nothing I can describe as an ideal BMI for an Indian, but it needs to be done by doing more research and trying to find out what is that BMI and what is that heterogeneity of type 2 diabetes that we need to deal with. So thank you very much.
Thank you, Professor Hanif. That was a fascinating and absolutely riveting talk. Really enjoyed that. And you have obviously clearly illustrated some of the difficulties with managing obesity and diabetes in South Asians, including the questions around bariatric surgery, for instance. If I may draw your thoughts on what you think your opinion is in terms of the intervention thresholds for both medical and surgical management.
Yeah, no, I mean, thank you very much, Akhil. That's a lovely, fascinating question. Now, I think let me just give you a background. I'll answer this question. So we one of the first centers in the country in the University Hospital Birmingham Heartlands. So I was working with Professor Kumar about 20 years ago when we set up a bariatric clinic. And this was in the east of Birmingham, which has got a large South Asian population, mostly of Pakistani origin. And when we audited our first bariatric surgery, so this was based on the NICE guidelines of 40 and over. So this was, if you remember, the previous guidelines from NICE was you only do bariatric surgery if your BMI of 40. And when we audited the first audit in 5 years, we hardly had any Asians in that category because they wouldn't have a BMI of 40 or 45. Now the criteria since then have changed. So now the criteria is you've got BMI greater than 35, then you should offer bariatric surgery. Now the question I always ask is, what is the reason for offering the bariatric surgery? Most of the time it is for a metabolic reversal of type 2 diabetes or for obstructive sleep apnea or for NAFL or other conditions. There is very little data to suggest that once your BMI is about greater than 30 or 27, bariatric surgery per se offers any benefit. That is the endobariatric data suggesting, reversal of diabetes, but long-term data in what you can call normal BMI surgery is not there. So I would be currently with the current data, unless more data comes in, I would be reluctant to offer anybody bariatric surgery in BMI less than 35, including South Asians.
Thank you.
Professor Hanif, you talked about the adipocyte size is more in Asians. Is there a role for glitazones because it's said to produce the fatty acid steal phenomenon? So do they work better in Indians?
Yeah, so I think this is a really fantastic question, and you see, because the glitazones have fallen a bit for various reasons, rightly or wrongly. Now, when it comes to the glitazones and the role, so there was a lot of promise about these drugs and perhaps being quite this. So the data I showed you with rosiglitazone from DEEM again suggests that they possibility have got a role. Now, the question really is about the side effects from the glitazones in terms of the weight gain, in terms of osteoporosis, in terms of heart failure and other risks. Now, I think in certain group of Indians, I'm not saying a lot of them, probably the glitazones have got a role. And again, we need more research in normal weight. But the dose I will probably be use of pioglitazone is about 15 milligrams. I won't probably go to 30 or 45. And this is just to perhaps help with the redistribution of fat because of the adipocytes. But again, as I said to you, there is very little data available, but there is an indication. One of the difficulties is that nobody is interested in funding these research, and this is where we don't have all the answers.
You talked about, once again, the Asians having more of impaired fasting glucose compared to that of IGTs. Any reason for this? Why is that we have more of IFGs rather than IGT?
Yeah, so this is this data actually comes from a lot of studies from Professor Mohan's group in Chennai, and this is again is the heterogeneity of type 2 diabetes that described. So it's probably, and it's not only the low fasting glucose, it's the 30 minutes. So the surge happens at 30 minutes. And this is probably to do with beta cell dysfunction. So the beta cell mass in Asians is actually less when compared to the white Europeans. So our beta cells actually, and because we have got less of the beta cells, our beta cells fail at a much lower BMI than compared to white Europeans. So their beta cells can carry up to a BMI of 30. Now, one of the things, I'll just take the other side. So one of the things I have actually seen in the clinics is fascinating. I haven't seen, or very lately, I'm not sure what your practice is there in India. I haven't seen an Indian with a BMI of 50 or 60. Very, very few Indians reach that BMI because by that, the beta cells fail. But here we see a lot of white Europeans with BMI of 50 or 60, even in Afro-Caribbeans who don't have type 2 diabetes. So these people can carry a weight up to a BMI of 60 without the beta cells failing, suggesting that the beta cell, even in obese Indians who don't have risk of diabetes, is less.
Thank you.
Any questions from the floor?
I have one query for both of you. Dr. Akhil Syed is very calm, but he's an authority on obesity. My question is, the paradoxical question is, every now and then we get patients with normal BMIs asking to put on weight. So this peer community pressure on them. So we are struggling to convince them that they are healthy and the rest of the society is unhealthy. How should we handle this ever common problem we are facing now with the normal BMIs wanting to put on weight?
I think I'll butt that to Professor Hanif.
Oh yes, okay, fine. Okay. Oh yeah, Shyam, that's a lovely question. So I'll just tell you this conversation I had with Roy Taylor. So we are trying to design this study in South Asians, and I'm not sure whether you've met Roy Taylor. Roy has a BMI of 18. He doesn't eat anything, and he thinks he needs to lose more weight. So he was trying to convince me that, you know, that for the South Asians, the cutoff for the study in diet was 27. He wanted to be 23, and he wanted them to lose 15 kgs or 10 kgs. And I said, Roy, you can make them do that, but none of the Indian girls in the UK will get married. So you know, and this is where the societal pressure comes in. So you remember in our growing days, all the South Indian, all the Telugu film industry heroines, they had to be fat. You know, this is where the society. So if you lose weight, so sometimes, you know, when I go back and try very hard and lose weight, the first thing there is, are you okay? You have lost weight. So this is a societal thing with this one. So, you know, and this will not be easy to change, and it will require some kind of education and societal guidance to change that. And I always get this, and especially with people with diabetes, if they've got poor control of diabetes and they're losing weight, the first thing they'll say is, what can I do to put on weight? And sometimes they say, go on insulin. It helps you. Insulin is the best thing for you to make you put on weight. But this is something we do see.
Yeah, I think we'll go to the next talk.
Cheers. Thank you very much. Can I leave now if that's okay? Okay.
Sure,
Thank you, Shyam. Thank you, Professor Bantwala and Akhil. Thank you very much.
Thank you, sir.
Thank you for this.
Please.
So I understand that there's a slight change of program. So we now go back to Dr. Rajendra Kumar for his talk.
I think his profile is just loading up. Maybe I'll just escape the screen so that we can see. Yeah, that's his profile.
So
shall I start shall I start to share? No, I don't have.
So 1 minute, sir. We're just going to introduce you, sir. Dr. Rajendra Kumar, sir, is a director at the head of department, consultant endocrinologist at KIMS Hospital. He has 22 years of experience in cardiology. He's a member of American College of Cardiology, Association of Physicians of India, IMA, and the Cardiological Society of India. He has multiple publications and has got some Best Reviewers Award also to his name. So, sir, I'm going to stop my share and then you can start your presentation. Thank you.
Can you see my slides?
Yes, thank you.
Yes, sir.
Yes, sir.
You can see
There
slides. Yes.
Okay. I thank the Idea Clinic organizers for giving me opportunities in this wonderful forum. The talks are very interesting. In fact, as a cardiologist, I learned a lot from Dr. Wasif's talk about obesity and the changing concept and why we Indians get more diabetes. So it was nice. In fact, I think I should log on. In fact, for all the cardiologists, we should log on the whole session because a lot of interaction is there between cardiology, diabetology, endocrinology. And we really interact with all our diabetologists, especially with management of heart failure. So with this introduction, my topic today is diabetes as a comorbidity. Is it a bystander or is it a driver of heart failure? Let us understand this. So I need not tell you all of you that the diabetes mellitus is itself an independent risk factor for heart failure, and it increases the risk of heart failure by 5 times in women and 2 times in men. And in chronic heart failure, 25% of the chronic heart failure patients have diabetes. 40% of the acute heart failure patients have diabetes. And diabetes is more prevalent in this heart failure, 4 times more. So this definitely indicates diabetes has a pathogenic role in heart failure. They are interlinked, diabetes and heart failure interlinked. And the management of heart failure in diabetic patients, how we should approach. And today's my more focus will be how to use sacubitril valsartan in patients with heart failure, especially in patients with heart failure with reduced ejection fractions. I'll not be covering anything about heart failure with preserved ejection fraction in patients with diabetes mellitus, because that itself is a different topic, and I'll be more restriction to heart failure with reduced ejection fraction, that is in patient with LV dysfunction. And all of us know that the diabetic population is increasing. 8.7% of the diabetic population is in very younger age, 20 to 70 years. And as the age progresses, the diabetes is increasing. And 60% of India is having diabetes or pre-diabetes by age of 60. And the prevalence of diabetes in India is 62.4 million. And the prevalence of pre-diabetes is 77.2 millions. So what can we do? How we manage heart failure in this diabetes patient? So the common presentation of patient with a diabetes is a heart failure. Sometimes they don't present with a stable angina, they present with SOB, and this is more frequent presentation than a non-STEMI or a STEMI or an unstable angina. A heart failure is a very common initial presentation for a diabetes with cardiovascular disease. Coming to the mechanism, how this diabetes causes heart failure. So in a diabetes, we know we have hyperglycemia, insulin resistant, hyperinsulinemia. They causes inflammation, dyslipidemia, endothelial dysfunction, which cause coronary disease. And this coronary disease, especially in diabetic patients, it is a very diffuse triple vessel disease, and this causes ischemic cardiomyopathy and a heart failure in diabetes. The other mechanisms of heart failure in the diabetic patients is the hypertrophy, left ventricular hypertrophy because of the hyperglycemia and insulin resistance. And along with this, RAS activation causes fibrosis, and this causes again heart failure. And autonomic dysfunction along with the diabetes, this also causes cardiomyocyte hypertrophy, left ventricular hypertrophy, and this again causes heart failure in a patient with diabetes. So there are 2 pathways. One is through the coronary disease, and one is without a coronary disease. Still we see a lot of patients with heart failure. So what are the risk factors for heart failure and diabetes? The common risk factors is age, sex, race, hypertension, and obesity. And the diabetes itself, again, with hyperglycemia, dyslipidemia, insulin resistant cause coronary disease, and they also can cause renal disease, and the renal contribution also be responsible for a heart failure. So the coronary disease, again, as I said, it can cause a myocardial infarction and arrhythmias and cause heart failure. And through 2 mechanisms, through the coronary disease and renal disease, a diabetic patient can get a heart failure. So what is the prevalence of this diabetes in various studies? Let us take the prevalence of diabetes in a heart failure studies, and then patient is a heart failure in a diabetic population where diabetic studies were done. For example, the prevalence of diabetes in heart failure patient is the classic, the best trial, the largest trial till now in heart failure is paradigm heart failure, where sacubitril valsartan was compared against enalapril. The prevalence is 35%. Whereas SHIFT trial where ivabradine was used is 30%, ECHO-CRT was 41%, and senior style was 26%, merit heart failure where metoprolol was used 25%, and CHARM added candesartan trial was 29%. Whereas if you see the prevalence of heart failure in a patient at diabetic trials, that is DPP-4 inhibitor trials, SAVAR-TIMI-13, TECOS and EXAMINE, it's 13 to 28%. SGLT inhibitors, EMPA, and CANVAS trial is 10 to 15%, and GLP-1 receptor agonist trial, that is LEADER, ELIXA, and EXCEL, it is 14 to 22%. So in a chronic heart failure patient, the prevalence of diabetes was around 30%. In a diabetic patient, the prevalent heart failure was approximately 10 to 30%. So it is around 30%, both in a heart failure patient, the prevalence of diabetes, or in a diabetic patient, the prevalence of heart failure is around 30%. So these two coexist, and they have a strong impact on a clinical management and prognosis. So this is a reduced ejection fraction is an independent predictor of fatal and non-fatal clinical outcomes in patient type 2 diabetes mellitus. And diabetes worsen the clinical status, increases all-cause and cardiovascular mortality in heart failure patient with reduced ejection fraction. So if you see that all the trials, how strong is a diabetes predictive factor, like Paradigm heart failure, the adjusted all-cause mortality risk in type 2 diabetes mellitus patient is 46%, and adjusted cardiovascular mortality risk for type 2 diabetes is 54% in Paradigm heart failure. If you see echo CRT, the adjusted all-cause mortality risk of type 2 diabetes is 108%, whereas cardiovascular mortality in type 2 diabetes is 179%, which is quite high, 79%. So similarly in CHARM trial also, it is the heart failure, all-cause mortality in a diabetes patient is 55%, and adjusted cardiovascular mortality is 50%. So these all studies tell us that the diabetes is associated with increased all-cause and cardiovascular mortality in heart failure patients. So what is the incremental risk? That is, in a patient with heart failure in concomitant diabetes is a strong predictor of adverse outcomes. It is 1.2 to 1.9 fold in a patient for risk of being hospitalized for heart failure. In a patient with diabetes, it's quite high. These are all the trial data from SOLVE trial, DITCH trial, MERIT heart failure trial, CHARM Candesartan trial, SHIFT, which rivaroxaban was used, emphasis eplerenone was used, and Paradigm heart failure where sacubitril valsartan trial. Again, the same trial, this is heart failure clinical outcomes in a diabetic patient is a strong predictor of adverse outcomes. These are various diabetic trials where the outcomes of heart failure was seen, that is proactive pioglitazone, Elixa lixercide, leader liraglutide, examine algoglipin, savartimethirtine is saxaglipin, Tecos is sitaglipin, EMPA outcomes is EMPA, and CANVAS program is CANA, where heart failure reports are not reported. And there's excess rate for heart failure hospitalization at 2.2 to 4.3 fold. So what is the impact of diabetes in clinical outcome of heart failure at 1 year? So in type 2 diabetes patient, there's a 7% increase in risk of cardiovascular death and 27% risk of heart failure hospitalization. Long-term mortality is 50% among heart failure patients with diabetes. It is quite high. So still heart failure is frequent and forgotten complication of diabetes. So how to treat this, recognize this complication? So we should understand that 50% of the patient of left ventricular systolic dysfunction with antecedents to heart failure, they remain undiagnosed, untreated. And then clinicians should not overlook the diabetes patient with stable coronary heart disease may present with atypical symptoms such as shortness of breath. So early diagnosis, immediate treatment can help to delay or prevent the progression of this debilitating disease. So how to manage these heart failure in patients with diabetes? The treatment options of heart failure with diabetes, they consist of mainly 4 drugs, that is ACE inhibitors, and where ACE inhibitors are not tolerated, ARB drugs are used. And now with the availability of ARNI, so again, if the patient is still symptomatic on an ACE, or if ACE is not tolerated, is an ARB, and the still patient is class 2 shortness of breath, ARNI is a new class of drug where it can be used. Beta blocker should be standard of care for all heart failure patient. And if the heart rate is not reduced up to the maximum tolerated dose of the beta blockers in a patient of the heart failure, that is, for example, in a patient with a severe LV dysfunction, an ejection fraction of 30%, and you have increased the beta blockers dose up to 50 milligrams twice daily, for example, a metoprolol succinate, and still the heart rate is 80, and the blood pressure of the patient is not allowing to increase to more, is 100 by 80, and you're not comfortable for the hemodynamic consequences of further increasing beta blockers, then you can start ibabardine. That's another class of drugs. So other diabetic drugs now have become very important in a patient with diabetes or heart failure. That is SGLT inhibitors. Now they have revolutionized now the treatment of heart failure because they're very hemodynamic friendly. And in fact, now the recent trial have shown that even in a patient with heart failure without diabetes also, this group of drugs can be used. So this is the armamentarium we have in a patient with a diabetes with heart failure. Again, that is ACE inhibitors, ARB, ARNI, beta blockers, and mineralocorticoid receptor antagonistic. That is also has a lot of role. But a little caution about using mineralocorticoid receptor antagonistic in a patient with heart failure, because most of these diabetic patients will have a type 4 renal tubular acidosis, about 25% of them, and they'll be having some amount of hyperkalemia, or the potassium is in the higher range of 5. So when you want to use in a diabetic patient with heart failure, this mineralocorticoid receptor antagonistic, you have to be more careful. Do we have any trials specifically seeing a management of diabetes heart failure? There are no clinical trials of heart failure conducted exclusively in patients with diabetes mellitus. But when you use heart failure drugs, we should also account the metabolic effects of these drugs in patients with diabetes mellitus. What are the guidelines recommendation for heart failure in a patient diabetes? ESC 2060 guidelines. There are no specific constraints to heart failure in type 2 diabetes mellitus patient for management of heart failure. In clinical trials, all pharmacological and device therapies for heart failure were similarly effective whether our patient is having diabetes or without diabetes. So this is again, as I told in that armamentarium, we have ACE inhibitors. If they're not tolerated, ARB, and the beta blockers are very important. Even though the mass symptoms of hypoglycemia, these drugs have to be used cautiously in this group. And even though they influence the lipid profile, they have more benefit than damage by worsening the lipid profile of this patient. And again, MRA, I said, definitely you have to be more careful in diabetic patient because their potassium levels are around 5 in 25% of the patient. You have to be more careful. Coming to diuretics, also they have some adverse effect on a patient with diabetes or heart failure, increase insulin resistant and subsequent worsening of the glycemic control. So once a patient becomes asymptomatic, that is, there is no volume overload in this group of patient, the diuretics can be safely withdrawn and the other 4 classes of drugs can be given safely. So at least of all these drugs, diuretics can be removed safely once the patient becomes euvolemic and the JVP is normal, the patient doesn't have pedal edema and he has class 2 symptoms, they can safely remove diuretics. MRA, you have to have a little more caution that the potassium might get rise in a patient diabetes in 25 the patient, but it also has to be added in every patient because on top of ACE or ARB or an ARNI with a beta blocker, this has shown a simple drug like aldactone has shown a 30% reduction in sudden cardiac death. And this is they prevent the fibrosis, they maintain the intracellular potassium of the myocardium, and they reduce the sudden cardiac death. So these are very wonderful drugs, can be continued to use in a patient with heart failure. So the need of the hour is several anti-diabetic drugs have been implicated in worsening our heart failure prognosis. But again, only diuretics you can be more careful, but other drugs, I still feel beta blockers are very, very important. They can cause dysglycemia, but the benefit is more with the beta blockers in a patient with heart failure. There's a new class of drugs that is the neprilysin inhibition. That is a novel therapeutic strategy. And this has become a new pharmacological biotarget in heart failure patient because inhibition of this leads to a gradual increase in natriuretic peptides and other substances in plasma concentration. Once you inhibit the degradation of the natriuretic peptide system by using a drug sacubitril, which suppresses the neprilysin, it is stopped the degradation. So there will be no more natriuretic peptides in the blood, which reduces the blood pressure, reduces sympathetic tone, reduces aldosterone level, reduces cardiac fibrosis and hypertrophy, and increases the natriuretic risk. So in fact, when you use an ARNI in a patient with heart failure with diabetes, you can safely withdraw diuretics because you added a drug which is not only a ARB with a neprilysin inhibitor, it has a diuretic effect and it has a significant diuretic effect. So you can safely stop the diuretics when you use this ARNI group of drugs. It also has an effect on the bradykinin And this bradykinin degradation, accumulation of bradykinin, again that reduces the blood pressure, increases nitric oxide, and increases the natriuresis. So this is how the neprilysin inhibitor helps in a patient with a heart failure. So the combination of sacubitril and valsartan has shown a superior outcomes over enalapril in clinical endpoints. And this is the data by the famous Dr. McMurray, who has published this data from in New England Journal of Medicine. If you see, there's a 20% reduction in primary composite outcome, 20% reduction in cardiovascular death, 21% reduction in first hospitalization after discharge, and 16% reduction in all-cause mortality when this drug was compared to a standard care drug, that is ACE inhibitors, enalapril, that was compared with 10 milligrams of ACE inhibitor versus 200 milligrams of sacubitril valsartan. So it has shown that not only it reduces risk of rehospitalization, it reduces cardiovascular death, it reduces all-cause mortality and primary outcome. So in patients with diabetes, let us see, is it any different? Does it behave additional benefit? So sacubitril valsartan, it inhibits, the valsartan part inhibits AT1 receptor blockade, and this increases inclusion sensitivity. And neprilysin inhibition, because of the natriuretic peptides, as I said, increases insulin sensitivity, increases lipid mobilization, increases insulin metabolism, and reduces blood glucose level, and increases postprandial lipid oxidation, and increases muscle oxidative capacity. By increasing bradykinin, again, it increases insulin sensitivity, attenuated lipolysis. By increases GLP analogs, it has anti-hyperglycemic effect, and increases cyclic skeletal muscle CGMG. It facilitated lipolysis, vasodilatation, and decreases DPP4 activity and increases beta cell function. So sacubitril valsartan improves insulin sensitivity, lipid mobilization, and oxidation by augmenting natriuretic peptides. So in paradigm heart failure, there was a heart failure sub-analysis. There's a sub-analysis 1, compared the effect of sacubitril valsartan with enalapril in a patient with paradigm heart failure according to the glycemic status. The sub-analysis 2 was investigated the effect of sacubitril valsartan versus enalapril on HbA1c and time to first initiation of insulin or oral hypoglycemic drugs in a patient with diabetes and heart failure with reduced ejection fraction. So let us see what the sub-analysis 1 and sub-analysis 2 shows. If you see, sacubitril valsartan positively impacts cardiovascular outcomes in heart failure with reduced ejection fraction, irrespective of the glycemic status. So there is a 20% reduction of risk in the death, which favors a sacubitril valsartan when compared to enalapril. So this also reduces hospitalization in heart failure with reduced ejection fraction, irrespective of the glycemic status. So it also equally effective in a patient diabetes population. That is a 20% risk reduction in hospitalization. What about the quality of life? It provides 17% quality of life improvement, probably in the first 8 months after starting the drug when compared to enalapril. It also enhances glycemic control in a patient with diabetes and reduced ejection fraction. There's a change in mean HbA1c and confidence intervals by treatment group at screening, at randomization, at 1 year, 2 year, and 3 year visit. So the decrease in HbA1c was persistently and significantly greater in patients receiving sacubitril valsartan versus enalapril over the 3-year period. Even though this is not, p-value is not significant, but there's a definitely difference between the sacubitril valsartan with enalapril. Magnitude of treatment also affected HbA1c level. At 1 year with sacubitril valsartan, more than 8% at screening, 8% of the more patients moved to lower HbA1c category, and 11% moved to a lower HbA1 category when the HbA1c was 6.5 to 6.9 or 7 to 7.9, and 14% lesser patient likely to have moved to higher HbA1c category. What about the sacubitril valsartan impact on insulin initiation in a patient with diabetes with heart failure? There was a 29% reduction in new patient use of insulin in patients who are on sacubitril valsartan when compared to enalapril. So sacubitril valsartan may enhance the glycemic control in patients with diabetes and heart failure with reduced ejection fraction. And sacubitril safely results according to glycemic results. And this drug is better tolerated when compared to enalapril in a patient with diabetes, even though there is a renal dysfunction, creatinine more than 2.5, it is safely, in a diabetic patient, it is having safe when compared to enalapril. And coming to the slow reduction of the GFR in a patient diabetes or heart failure, again, there's a better control of GFR in a patient diabetes with reduced ejection fraction with sacubitril valsartan when compared to enalapril. Summarizing my brief talk, hyperglycemia, insulin-resistant hyperinsulinemia in a diabetes mellitus trigger a cascade of deleterious effects that contribute to development of heart failure. Heart failure and concomitant diabetes increase the morbidity and mortality, but it is still overlooked in a patient with diabetes mellitus. There are no specific constraints to heart failure treatment in type 2 diabetes mellitus patient for management of heart failure, but a heart failure therapy that is protective against incident diabetes or worsening glycemic control will be a welcome addition. Sacubitril valsartan improves clinical outcome and improves glycemic control in heart failure with reduced ejection fraction patient with diabetes mellitus. Thank you.
Thank you. Thank you, Dr. Rajendra Kumar. That was, again, a fascinating talk. You have covered a huge topic very succinctly and very clearly. Before opening the floor, one small comment in relation to obesity and the metabolic syndrome in heart failure, and that's the obesity paradox, where generally when we advise people to lose weight, in people with heart failure, it might actually be counterintuitive. And there's been evidence that people might actually do worse if they lose weight once they have developed heart failure. I wonder if you have any particular thoughts on that, Dr. Kumar.
Yeah, obesity and heart failure. I really don't have any practical experience. I think I don't have. On obesity and heart failure, reduction of weight, is it beneficial for heart failure or not? That's the question, correct?
Yes. Seems to be some evidence that weight loss in an obese person with heart failure is actually harmful and has a worse prognosis, which is seemingly counterintuitive.
Yeah, but our practical experience in a patient with a heart failure, especially with obese, they're doing extremely well, especially like people who are obese and who need a CPAP machine, and they come with a heart failure with a reduced ejection fraction. And when we give these drugs like ARNI and SGLT inhibitor, they do extremely well. Even loss of 10 to 15 kilos we have seen, and they do very well, and there's no worsening of any events like rehospitalization or getting another cardiac event. I haven't seen anything. And I'm talking especially in obese with a reduced ejection fraction substrate. So probably it might be a scenario like a heart failure is a preserved ejection fraction with obesities. So that's totally a different scenario. So particularly in a severe dysfunction with a obesity, I think reduction of heart failure is not going to be harmful for them.
Thank you. Any questions from the floor?
Yeah. I think if there are none, we'll go to the next talk.
Thank you, Dr. Rajendra.
Thank you very much. Thank you very much, Philippe.
Yeah, so the next talk will be by Dr. Meher Prasad, who is a consultant in diabetes, endocrine and obesity at Idea Clinics, Chennai, Chettinad Health City and Global Hospitals. He is a regular speaker at obesity talks. He has a special interest in the management of obesity. over to Dr. Meher Prasad. So he'll be speaking on diabetes as a why am I not losing weight in obesity? I think this is a very apt topic. In fact, one of my colleague friends has removed obesity from his prescription because it's very difficult to treat obesity. I'm talking as a medical line of management. So it's such difficult. Patient says, I don't eat, but in fact, they'll be eating more. So it's the most difficult thing. So I think many of them are finding it very, very difficult to treat obesity. So I think over to Meher Prasad, he'll be speaking on this, how to tackle that.
Thank you very much, Dr. Akhil. Yeah, I mean, we come across this situation quite a lot, and it's just quite challenging to convince the patient and also make them to lose weight. Let me share my thoughts with you. What we tend to do is sometimes simply brush them away, saying that you're lazy, you're not exercising enough, or you're eating too much, hogging on food. Is it true? I mean, maybe partially true, but not entirely, I would think so. So if you go through sit with them and go through. We all know that obesity is a complex disease. It's caused by multiple causes, and also it's got multiple effects. It could be psychological effect, the depression leading on to eat more and then causing obesity, disordered eating again as a result of depression or a habit, social reasons and supportive. I mean, social reasons, as Dr. Wasim was mentioning, that it's a stigma when you're thin, and being fat is, or obese is seen as being wealthy and healthy. So all these things, drive obesity. And say again, socially unsupportive family who want them to put on weight, and the husbands driving the wives to put on weight and things like that. So all of them contribute. And again, genetic causes. We had an elusive talk in the morning about this. I'll also share a few thoughts about that. And poor physical activity, which could be because of medical issues, and other comorbid conditions, like endocrine causes, which we have gone through in the morning, and renal disease and other diseases, endocrine diseases, as we said, which could lead to obesity. And again, the problem is that these lead to various complications, metabolic complications, diabetes, hypertension, mobility issues because of joint pain, other, again, psychological issues, where they have to go on medications, sleep disturbances. So sleep, as we know, is a very important issue which can cause weight gain. So all these things, these effects again, put them into another cycle of causing obesity, and this goes on and on. So making it worse, they're going to end up in a vicious cycle and a rut. So coming out becomes a very difficult problem. So as we so again, we mentioned about genetic causes. Whether the gene has genetics has got a role. It's certainly in a lot of and at least some of the patients, it does have a role. The single gene mutations, or it could be a part of the syndromic obesity, whereas they're associated with multi-system organ malformations. These are quite rare: Lawrence moon beetle, Prader-Willi syndrome. But more common would be this sort of polygenic obesity, where there are multiple genes driving obesity. Again, in a weight-promoting environment, as we heard earlier, that these genetic influences, along with they are amplified by the weight-gaining environment, where there's plenty of food, and the being obese has become a norm. For example, in America, it's very difficult to spot very thin, non-obese people. But again, so that's what happens in a lot of situations. So how does the regulation of weight, body weight happen? The brain again is a very important cause. I mean, a very important organ which regulates the weight. So various it uses various impulses from the messenger system in the body, from the peripheral tissues, the fat, whether the right amount of fat is there. This has again this has evolved over the over centuries. You know, that's how the man has protected himself, and this has been again it's been through genetic influence. It has genetic influences or each person. So each person has his own set normal, which I'll talk about in the next couple of slides. So the body senses the fat tissue, which is again the biggest endocrine organ, which senses the peripheral tissues and sees whether the storage is enough or not, and sends impulses to the brain, which sends again impulses to the peripheral system, effective system, like the gut and the energy skeletal muscle, to either increase the absorption or increase the exercise, increase the decrease the absorption. So all these things help with the bringing down or increasing the absorption. So the monogenic diabetes, we said. So this is how the brain, gut, adipose tissue axis works. These are all the main centers in the hypothalamus, and which has it has got the paraventricular nucleus and the ventral lateral medial nucleus. So all of these things have impulses which either promote weight gain, like orexigenic signals, or anorexigenic signals, which promote weight loss. So all these impulses are modulated by the brain through the impulses from the cortex. So the cortex, you know, it's a very important aspect in the weight management, where it receives all the impulses, stores them, and then uses it for the next for the future as well. So impulses, which food stuff which is seen as giving pleasure or satisfying the person, will be driven the next time they see food. So all those things are stored and then used for the next time. So all these promote weight gain or weight loss inducing foods. I won't go in much detail in that. So this is the leptin melanocortin pathway, which is again it's in the arcuate nucleus and the paraventricular nucleus. Arcuate nucleus, which is anorexigenic, which promotes weight loss, and then the paraventricular nucleus is orexigenic, which induces weight gain. So all these two areas strike a balance, and that will result in either weight gain or weight loss. And so there is again another hypothesis called the set point theory, where there is a predetermined and a preferred level of feedback control mechanism which drives so in that according to that theory, body has got a predetermined weight. Each person has got a predetermined weight. So if there is any deviation from that, then the measures will be taken by the measures will be taken by the body to bring it back to the homeostasis stasis. So that is another important aspect. So when the patients say that I'm not able to lose weight, and my parents have been heavy, the spouses, the siblings have been heavy, then they probably might be saying the right thing, and they have a set predetermined weight for their body, and they may not lose much weight from that. And whatever we do, they will probably regain their weight. So that's one thing we need to remember. And then if you look at the total energy expenditure, each person has got a resting metabolism, and 60 to 70% of them, the body expenditure will be through that. And then I'll come to that in a minute, where how we can increase the resting metabolism, which will help people lose weight. So if you look at this, nearly 60 to 75% of them of the energy expenditure is through the resting metabolism. So if you have more skeletal muscle uses the 20% of the energy expenditure, and the other vital organs account for about 60% of the energy expenditure. So again, the body, the lot of heat is produced in the body because of metabolism, which again contributes to energy expenditure. Physical activity again is a modifiable factor, which we can increase to help with the increase in the energy expenditure. So if you look at this, so all these things, what we call as a basal metabolic rate. Each person has their own set basal metabolic rate, and this is the rate. This is the metabolic rate or the calories that the body requires to maintain the essential functions like the cell repair, breathing, and then organ functioning. So all these and the chemical reactions which happen in the body. So all those things are influence, and they are called the basal metabolic rate. So and this is set for a person, and then there are certain things which can help with that. I'll come to that in a minute. So the amount of the muscle mass also affects. So what are the factors that affect the basal metabolic rate and metabolism? The muscle mass. So if you have a lot of muscle tissue, then you will lose weight. So one of the ways to lose weight is build muscle mass. So the fat will be converted and to maybe the muscle, and also the muscle metabolism is more. Body size, again, the higher the body size, more basal metabolic rate. Body composition, again, more fat, more muscle, then more the BMR. Gender, males tend to have a higher BMR. Genetics, again, and the physical activity. I'll come to that in a minute. And the hormonal factors like the hyperthyroidism, it makes you lose more weight, and also the type of food. If you look at the proteins, tend to have a higher basal metabolic rate, and requiring higher calories to burn. So if if you look at the amount of calories burned by a person, one is the basal metabolic rate. The total energy expenditure is a basal metabolic rate into the so total daily energy expenditure is based on the physical activity they do, and 60% of it is through the basal metabolic basal metabolism or the basal metabolic rate. 30% of it through physical activity, and only 10% and 10% of it is through the so the next I'm going to introduce a concept called the NEAT, non-exercise associated thermogenesis. So this is one of the things which if you look at the calories that are burned through the exercise and the thermogenesis, exercise contributes to a part of it, but the most of the contribution will be through non-exercise activity thermogenesis. So what does that mean? So if you look at this, these are and why is it important? So the small things which we do, like pacing around using a phone, or fidgeting, or the cleaning, doing small chores. So all those things contribute, because if you look at the exercise, you do 1 hour of exercise, which is about 4% of our day. So rest of the 63% of the exercises through these sort of small active physical activities. So this is what contributes more for the basal metabolic, more for the energy expenditure. So if you look at it, only 4% of the, as I said, day will be through the exercise. 63% of the energy expenditure will be through NEAT. So that it makes more sense to increase these sort of activities, especially in the corona situation. This is probably very, very appropriate. So all these sort of activities promote that. Then the next question is, why am I not, as I said, when you look at the food, why am I still eating healthily most of the days? Why am I not eating? Why am I not losing weight? So if you look at this graph, Friday, Saturdays, weekends are notorious because all the good work done during the week is destroyed during the weekends. They don't realize how much the calorific value of the food items are. I'll come to that in a minute. And similarly, so if you look at this, a piece of slicer, it's only a pizza. They think it's only a piece of pizza. But if you look at it, it's about 560 calories, which is equivalent to so quite a lot of exercise done. So they might compensate partly, but a lot of it. If you think about weight gain, about 100 calories of weight, 100 calories of excess food or calories saved in a day. If you look at it for over a year, you might put on 7 kilograms of weight. So in other words, if you do that much of reduction through calories and through the food and also some exercise, then you might lose that amount of weight. And that's what patients might be missing because they think they are doing a lot of exercise, eating very sensibly. Only occasionally I cheat, but they don't realize that they are compensating for it. So for example, they might say, I have eaten only chicken korma for a day or something. If you look at it, it's 870 calories. So which is like doing 10 hours of exercise. So which they can't do it. So each day they accumulate a small quantity and then they put on weight. And if you look at vegetable samosa or bhaji, which is only a small snack, which you might eat on passing, again, these all accumulate. And even a papadam, which you don't even think about it, puts on make you put on, done over a lot of time, it will make you put on weight. So those are the things which if you highlight, then the patients might think about it. And each time they save maybe 1 time out of 3, they might cut down on the calories. So these are examples of the exercise they have to do to burn the calories. Even for 100 this is 30 minutes of exercise. For example, aerobics, but only you burn only 150 calories. So this is not. So there is a mismatch between what they eat and what they burn. So what are the difficulties in the obesity management? Again, there is satiety. Sugar and oil has. Sugar has a very low satiety, very high satiety index. So they have to eat a lot to make them feel full. Again, satiety is 2 different things. One is it might be physical, where they feel full. So they have to eat a lot to feel satiated physically. Mentally, again, they are used to eating, say, for example, if they eat 10 chapati, 10 pieces, 2 pieces of bread or 4 pieces of bread, anything less than 2 pieces is starvation. So that's not the case. So mismatch between.
2 minutes. Thank you.
Okay, 2 minutes. So there is a mismatch between the amount of the overestimating the calories burnt and food intake is causing underestimating the calories of the food intake. So when there is a mismatch, then and making them understand that recognizing them is important to help them lose weight. So in conclusion, unrealistic expectation can lead to frustration. So explaining to them what is making them put on weight, which is got by which we can do by a detailed history, will be useful. And similarly, understanding the physiology both by the physicians and also by the patients is vital for in the weight management. This will help the clients and the patients and the healthcare professionals to get the best outcomes and avoid frustrations and stay focused and avoid complaints in patients. And then for sustained long-term changes yield better and sustained results. So that is small sustained changes. It'll be useful in the long run. Thank you.
Thank you, Dr. Meher Prasad. I think difficulties we face in the real world when advising people on weight management. One of the things I tell patients is precisely the kind of points you raised about exercise and how few calories are burnt and so on and so forth. And sometimes it's easier for people to understand if you give that in very easily understood kind of examples. So I say to them, if you eat 1 bar of chocolate, you know, you will need to do the walking of about 2 miles. You know, so that kind of brings the point home to them that that's the amount of exercise they would need to do, yeah, to simply burn off one bar of chocolate.
Yeah, that's true. And
any
then
questions? Any questions from the floor?
Yeah, just a couple. Yeah, normally, see, what's been found is even just 10 calories of excess intake per day over a period of, say, 10 to 15 years will lead to a 10 kg weight gain.
Yeah.
So it's such a small, it's less than half a cucumber.
Yeah.
That is the amount which can lead to so much weight gain. So they must realize the importance of that ultra management of calories.
Sure. I mean, what sometimes I used to do is to reverse it, saying that even a small reduction will help you lose weight in the long run. Even a small, piece of bread a day will help you lose about 7 kilos in a year's time. So that in giving them some positive inputs as well. So both of them helps actually. Thank you.
And another thing we must tell is, say, suppose somebody is 95, he's come to 90 now. He must put in more effort to lose from 90 to 85. Otherwise, he'll go back to 95. So that's another thing which we must tell, the yo-yo phenomenon.
Sure. So that's why I always ask them to do some sustained changes. I mean, any changes, it shouldn't be big, but small sustainable changes, and which you enjoy doing it. So yoga, some people enjoy. Zumba dance, some people enjoy. So ask them to continue that and go ahead with that.
I've certainly learned a new term today, non-exercise associated thermogenesis, NEAT. It's a good concept to take to the patients. I think we can probably have a poster of it on outside our clinics.
Yeah.
Thank you.
Actually, simple things like, say, you have the software guys who are sitting and doing. I tell stand and do. You're burning more calories.
Yeah.
That's a NEAT.
Yeah.
So simple things, because you're standing, you're moving your legs, you're moving here and there, your weight is there, so you're burning calories rather than sitting.
Sure. Yeah. So in this age, mobile phones again, you use it like a mobile phone, not a sitting down phone. So that also helps.
In some remote areas, it really makes us mobile, but in where the connectivity is good, no, there is no mobility.
That's true.
So thank you, everyone. Sorry, the chairs and I apologize. There's been a little delay, so we'll just have this last talk, and I'll introduce Gautam. He's a very well experienced nutritionist who works with us in Idea Clinics. We regularly refer patients for diabetes reversal. In fact, a lot of the patients personally ask themselves, what is this diabetes reversal? Can we try this? And Dr. Wasim alluded to this earlier on in his talk. So over to you, Gautam. Gautam, go ahead and share us your experience of what your diabetes reversal in Idea Clinics has been.
Yeah, sure. I hope my screen is visible to everyone.
Yeah.
So Last but not least, I would like to end with my diabetes reversal with diet, technology, and AI. And see, what most patients are afraid is whenever they hear that they got diabetic, is they get into shock. So Idea Clinics is always there for them to assure, for people who have been getting into shocks in that way. We always assure them that diabetes is reversible if their lifestyle is being managed and it is addressed. So coming to that, diabetes reversal can't be achieved manually. So it is always related to technology and AI. So to eat is necessary, but to eat AI intelligently is an art. So previously we used to say intelligently, now AI has taken everything. So we say is an AI intelligently is an art. So what we do at Idea Clinics is we have an evaluation of the patient to make sure that we cover these points. So the age, the duration, the HbA1c at the time of enrollment, the BMI, any mobility issues or psychological issues or motivational issues. So we screen them and make sure that a particular patient is eligible for this therapy. So we evaluate them at the beginning and then we do the process. And it involves diet, physical activity, and inner transformation. So many of patients think that they get a diet chart, they go home and they do that. It never happens unless and until there is a constant follow for 3 to 4 months with customized diets and supplements. There is it's a bit hurdle for every a nutritionist to treat them in a way where they can see the results. And proper follow-ups and weekly reviews will definitely give them a boost up and then more motivation every day, being in touch with them through WhatsApp or any other app that which gives them motivation on a daily basis. So so the key components of diabetes self-management are like nutrition and pharmacology, like usage of medications and injectables like insulins, and physical activity. If we see it in a more perspective way, so the goals will be delivered to each patient individually, and we make sure that this is followed through. And we used to have challenges previously, like we used to do it manually. So now as technology and AI has taken into place, we are coming up with an app. It is still in process. Prototype has come out. So with just one click of it, a patient can get into contact with a doctor, with me, with a team of psychologists and physiotherapists as well, where they can address each and every issue of that and make sure that their diabetes is at least, their HbA1c is at least reduced to 3 to 4% from the initial stages within a few months. So what output came out of this diabetes reversal therapy through constant follow-up and into the therapy is, till now there have been 200 patients enrolled in the therapy, and 85% of them have achieved normal glucose levels within 3 weeks of therapy, with the usage of medications and all. Reduced dosages happened eventually, step by step. And in that, out of 20%, 15% were out of insulin, and then 5% are still using on insulin, and the other 10% are still under treatment. So I can say that there is a success rate of 85%. And as we can see the process flow that happens at Idea Clinics is a patient visits doctor or talks to doctor, and doctor advises a dietitian, and then this all can happen even within a clinic or without a clinic. I mean, as it's a techie word, and by 2030, I think like patient hardly visits a clinic and they all do it over the mobile. So the other challenges that are with compliance and adherence. So we made sure that we have designed an app and made sure that it is not an issue anymore. So we'll always be in constant touch with the patient and make sure that the goals that we advise them, the targets that they put for themselves, is always achieved. And so the gadgets that we can use in this therapies are CGMS machines, glucometers, smartphones, where this all is connected to app. So all the EHR data and all is recorded, and then every patient data is very secure, and it has a lot of analytics at the end of the day. So through AI, what we can achieve is there are 3 methods, where one is exploring and discovering the information. So when a patient enters the data, we know what it is, and we can learn how to use the information and extracting conclusions from the information. So this is a very crucial thing for for the part of technology to be imbibed to the diabetes reversal therapy. And through some predefined algorithms, we tend to achieve this very soon. And we are looking forward to it very soon. And I'll just give a small live example to you. I'll be sending you a small link in the speaker's WhatsApp section. If you can just do it, it won't take you much time. It is a 10-second time. You can do that. Just click on the link and just follow the steps, please.
You're putting it in the chat box?
Yes, please. I'll also put it in the chat box. If possible, they can also do it in the Zoom meeting.
Oh, you've put it is in the WhatsApp screen. Okay.
Yeah, anywhere, Zoom or anything. So I'll show you the real-time data, how, where my job is very easy. So I don't need too much worry about it. Just need to fill your name, what you had for your lunch, your glucose levels, and just a pic of your meal that you had on that day. By then, I'll be just discussing a case study that we have faced. Patient age is 32. Her weight is 126 kilos. And she turned up with very high levels of HbA1c. It's 14.4. Her fasting levels were 300. Post-lunch levels were 450. So we have initiated the therapy with insulin and metformin. Insulin initially. She has joined the diabetes reversal therapy. She has been under constant supervision for 3 months. Within 3 months, within 3 months, she has achieved a weight of 110 kilos. And in between, her insulin dosage came down because her sugar levels were coming down. So the insulin dosage got reduced and she got onto medications like metformin and DAPA. So also some drugs like DAPA has also helped in reduction of weight. So after 3 months, her HbA1c levels turned up to 6.1. Now her sugar levels are fastings of 92 and 112, and she is completely out of her medications. So it has been this has happened 8 months before. So this is an 8 months, so we have to wait for 4 more months and make sure that her HbA1c levels are maintained below 6.5, and then we declare her as non-diabetic. And the other results we can see, so these are some of the data of the patients like we have been researching on and the therapy that we have been putting on. So initially their weights were 88 kilos, 126 kilos, 93, 117, 80, 76.5, and 126. These are the HbA1c values that they turned up to us. And after the therapy, their values came. The weight, there was a steady reduction of 10% of their initial weight. With that, we have achieved an HbA1c levels of 5.5, and we have achieved good levels of even 4.9 and 4.7, and the least was 6.1. So I hope some of the dignitaries have added some data, so I can see. So I'll show you this. Anyone can see here. So they have entered the time that they're 437. Their levels were 120, 220. So everything is visible here. So I don't need to do anything. So everything is captured. I can download it with just a single click of it, and then I can analyze the data as well. So this is how AI helps in making things easy and make sure that in diabetes reversal therapy, this is what the major major role that it plays. And in conclusion, I would like to say that the 3 E's at Idea Clinics are app for engagement, idea skills for empowerment of patients, and tele-diabetes for education. And through that, reduce the burden of nation by reducing burden of medications on patients. This is what our motto is. And these are our idea skills page. So anyone can get into that. We have courses, we have skills platform where they can access the courses and then enroll into it. and get some knowledge out of it. I hope I've been giving a clear idea of what Idea Clinics has been doing. And these are the things related to diabetes reversal therapy. And I thank you all.
Thank you. Any questions or comments from others?
Yeah, Gautam, what length of diabetes disease? I mean, like for early diabetics, better, or even late diabetics, you're seeing what? And
yeah,
not just our experience.
Yes,
from literature also.
Okay, so till now I've been seeing pre-diabetic people, diabetes people who's their early onset of who are like a couple of years, or even recent joins like 10 years and 15 years as well. So they are still under treatment, but the majority of people who have joined the therapy in the initial, what I've observed is on an average, their sugar levels drop to normal within a couple of months of the treatment. So it's a mixture of microbiome diet and a balanced diet that we put them on. And mostly what I find intriguing is the motivation that we give and the response they have from their side. So which works on a longer term. And then the belief that they have on the system, like, more rapport between us, and a doctor, a dietitian, a psychologist, a physiotherapist and all. So all together as an umbrella program that we have designed it. So this is giving us a lot of achievements.
Dr. Saeed or Dr. Bantwal, you have experience having this sort of programs, running your programs at your place? Dr. Bantwal, you can start.
Not really. I mean, not in my place. We don't have, though we have a very good nutritional team where we had counseling with a psychiatrist, where we used to give a behavioral therapy along with the nutritionist and ourselves. So we did have a thing, but then not specially on the diet part, so more of behavioral therapy. Now, for example, what the case elicited by Dr. Gautam was 126 kgs. Yeah, that could be a little bit easy. So it becomes more tough when you're normal weight and then you want to control the diabetes with more meticulous intake of food. So then it becomes more difficult, because here you are 126, you came down, it's very easy. So I have many patients where, in fact, I put them initially on insulin, I stop it and they're all fine, something like a beta cell rest, that happens. But then what we want is normal weight and then you lose. That's more important. I think that the choosing your right diet plays a main role. Maybe you take a low glycemic index foods. So that is probably the way to go, I think.
Yes, we also had a few cases like what you have been speaking, doctor. So it was a bit difficult task at the beginning, but eventually as the therapy progressed and the levels of diets changed and the approach changed and individualized, customized diet approach them, and the physical activities that we changed accordingly. So that gave the more results, and on top of it, the supplements that they take at that time also improved their HbA1c, and then they also improved their complete gut health as well, where they used to previously give a lot of complaints about the gut health.
In fact, one of my colleague is doing what is known as putting the Freestyle Libra Pro, and you are going to see on your own which food is increasing your glucose, how much, because you just have that flash glucometer, so monitor, keep it above. You eat a particular food quantity, see how much glycemic excursions are happening. Because each individual is different. For a particular individual, rice may not increase. For another person, it could increase. So like that. And okay, this food is not going to increase my glycemic response. So that's what he is doing actually. And he's had good outcomes with that also.
There is also a concept called resistant starch, where we cook the rice today and then put it in fridge and eat it tomorrow, which decreases the starch content and carbohydrates content in it.
Yes, that's right. Yeah. Correct.
Dr. Saeed, I think one of the initial trials of all these diabetes reversals, I think everything started in the UK. Your experience in this?
Yes, indeed. So I think a lot of lessons have been learned from bariatric surgery, and the same kind of concepts have been proven to work even with non-surgical weight management. And so the Professor Roy Taylor's group from Newcastle focused on the low-calorie diets, which Professor Hanif was speaking about earlier. Here in the UK with weight management, we have these tiered structures, and my practice is around tier 3, tier 4 weight management, which is the more complex end of obesity management. And these patients get a lot of support with dietitian, psychology, and therapy input. But the UK is generally actually quite backward when it comes to using technology, such as food diaries and so on and so forth. We simply don't do that in clinical practice, unfortunately. But I have collaborated with research colleagues in the Middle East who commonly use, technologies such as camera-assisted food diaries, programs, and so on and so forth. And there are, of course, lots of free apps available these days for smartphones. MyFitnessPal, I think, is a very popular one, but obviously it has to be adapted for local needs. So even in the UK, MyFitnessPal doesn't have quite the same variety and detail as you see in the US because it's basically an American program. But yes, the technology will hopefully change things for the better as in time to come.
And do you, if these diabetes programs that Dr. Roy Taylor's group did, like having a low-calorie diet and the amount of reduction that we saw, has that been reciprocated or replicated in other studies?
So now it's actually been rolled out to general practice as a clinical program rather than research. So for people who have recent onset of type 2 diabetes, general practice actually offer low-calorie diets as an option. Another general practice group, Dr. David Unwin, who have recently published their data, and what they have shown is in people with pre-diabetes or new onset of diabetes, reduced calorie diets with particularly with a focus on low carbohydrate can be very effective, and they have shown huge reduction in the cost of treatment, because here medications, everything are provided on the NHS at extremely reduced costs in general practice, and they've shown that they can actually reduce the use of prescription medications and thereby reduce the total cost of healthcare.
I can also add that there are at least two other published studies that I know of. One is from India itself. Dr. Unikrishnan has done this in 11 or 12 patients in a small number, and he found about 50% remission of diabetes with low-calorie diets. He has not used formula feeds, but he has used a 1,000-calorie diet initially, and then went on to about 1,500 calories, maintenance of 1,500 calories. So they did show that improvement. And then there's one study from the Middle East. I think from Saudi Arabia or somewhere published recently, about 3-4 months back, and they also showed a similar sort of reduction in remission of diabetes as was shown by Roy Taylor's study. This study is, I think, just published about 3-4 months back.
Yeah. The question is how long will you sustain it? Yeah. Because as long as you're in the trial, you will be taking that. And I see we have in Bangalore a center known as Jindal Center. Jindal. Okay, so where you are given hardly any food. In fact, once they are given the food, the patient, the person says, "Where is food? Real food." I thought this is just a starter. So it's something like that. And once they are gone, say they will be there for at least a week or 10 days, you lose some 5-6 kgs weight. And then the government asks, sir, please tell me the best restaurants in the town or in the city, because they are so much starved. It's a bit difficult to follow those diets a long time. So unless it's a little bit filling, then I think yes. Because you have around 18 to 22 types of diet and everything is lasting only 3 to 6 months. and afterwards it actually fails.
Gautam, how long have we followed? What is the longest patient without remission of diabetes have you followed? I mean, how long has the patient who has turned non-diabetic stayed in a non-diabetic state? If we have a
there was clearly one, only I could find only one patient till now, because at the initial stages of the therapy, his weight was quite normal, as Dr. Ganapathy was saying previously. So the issues are compliance and adherence to the therapy. He was on and off over the diet, and it happens. People travel, people don't stay at the same place and don't get back to us. So here, as I was saying, if AY was much more introduced earlier, then this might not have been happened. But its technology is changing. I hope he'll get into a better place.
Just a couple of comments, if that's okay. One is as the duration of for reversal, they usually, even Roy Taylor study, they said about 6 months without medications. So how long have you been following them up for for reversal? That's only then you can say about reversal. That's one thing. And the other thing is, in reversal, if you go back on the same diet, even in Prof. Roy Taylor study, who I was working with before, they went back, they did gain weight, and then the diabetes came back. So it is important to maintain weight. So it's not only lose weight, for the reversal to continue.
Yeah.
Can I come in? I think reversal may be little, hard on it. I think the metabolic benefit they accrue by just bringing the motivation levels, the metabolic benefit they may get. I think technically some of them may relapse, but the confidence they get through lifestyle changes, that will have a lot of behavioral impact. We do see a lot of relapses, but I think it's a journey that every patient should go through. Newly diagnosed diabetics should undergo through a reversal program. Leave alone whether they reverse or not, at least it will help improve their health, and they will get motivated by the changes in numbers they could see by lifestyle changes. I think that one thing we should drive across. Even if they relapse, there is a benefit.
Yeah, I do agree, because in the overall, even the Swedish obesity study, the overall weight loss was there, but it did reverse, but the benefit was still there. I mean, they did have a problem. They didn't maintain the weight, and the cardiovascular benefit and all those things were still there. So I think, yes, I agree. It's right that losing weight helps, whatever amount, and also sustaining. Even if they don't sustain, they still don't go back to the same levels, but maybe a bit lesser. That's one group. But there's some other group who fluctuate, go up and down. They do tend to put on weight, some of them. So that's what we need to avoid, that fluctuating, what do you call that, weight?
Cycling, we call this.
Yeah. That's it.
So thank you, everyone. Thank you, Dr. Saeed, and thank you, Dr. Bandwal, for this wonderful discussion. I hand over to
Yes, sir. Srinath, sir, please.
Advanced technology AA, not only advanced technology AA, there is a old technology called Bhagavad Gita also. Rakesh has published an article, very old established advanced technology called Bhagavad Gita. Where you can practice and read it, and you can be healthy.
Right.
I think Ganpathy is also here. He is also part of that publication. So thank you, Ganpathy, Dr. Ganpathy, for sparing your time today and being with us at this important meeting of Idea Clinics, and also to Professor Akhil Saeed for joining us for this program, and also the speakers who have all spared their time today. I think we had a good audience, and I'm sure they would have benefited from the interaction. Thank you.
Thank you.
Over to Dr. Sudhakar Rao for his final comments. I would now request Dr. Sham to give his final comments. Dr. Sham?
I think Dr. Sudhakar Rao might be saying something. Sir?
Yeah. We are very fortunate to have international faculty as well as local faculty. National faculty, Dr. Ganpati joined as a chairperson, as a guest of honor. Thank you. And I thank all the faculty members, including chairpersons, and especially Joydeep and his team, technical team, and the other who have been helpful to our Idea Clinic conference. Shyam.
Thank you, everyone. I think we are getting delayed. Sorry for the delay. We were meant to finish by 4 o'clock. Hope you have rest of the weekend for your family. Thank you.
Thank you, everyone. Thank you.
Thank you, everyone.
Thank you.